Assalamu alaikum. Good morning, everybody. Good morning, Prof. Jolie. Welcome.
Good morning, Dr. Hin. Good morning.
Good morning. Yes, good morning, Dr. Fatima. How are you?
Good, alhamdulillah.
Good
Yes.
morning, doctor.
Salam. Good morning.
Good morning, Jolie. Yes, good morning.
So when do you think that we يعني متى حنتكلم بالكلمة؟ أي ساعة؟ 9 إلا 10، 9 إلا ربع؟
والله إن شاء الله الآن بس يدخل المعالي معنا إن شاء الله بعد حوالي 15 دقيقة ونبدأ الفعاليات. تقريبا راح تكون كلمتك إن شاء الله دكتورة بعد حوالي تقريبا 10 دقائق من بداية الفعاليات.
أوكي تمام.
راح في مقدمين إن شاء الله وراح يقدمونك بإذن الله.
أوكي، يعطيكم العافية.
الله يعطيك.
مجهود يعني الحمد لله جبار.
ما شاء الله.
يكتب الخير فيها إن شاء الله.
اللهم امين. السلام عليكم. بالتوفيق دكتورة فاطمة.
تسلم. With time for coffee.
السلام عليكم، صباح الخير معالي الرئيس.
هلا صباح الخير دكتور، كيف حالك؟ الصوت
الله
واضح؟
اي لا واضح دكتور، واضح معالي الرئيس، الله يعطيك العافيه.
على قولتك. اي واضح، خلاص اوكي. اوكي يلا.
When the people chatting is sound, how can I switch this one? You want to switch off? I switch off the chatting sound. Yes. هذا دكتور احنا لايف. نعم اي خلاص واضح. نعم هو تكلم معنا. ظهر فيديو شارك معنا. فيديو في القرآن الكريم فيديو كلمة رئيس المؤتمر، كلمة الضيوف، كلمة المعرفة. المعرفة. الله يعطيك العافية. الله يعطيك العافية. الله يسلمك. بإذن الله بإذن الله. ويلكم بروف الفونس. معالي الرئيس،
حياك الله، يا هلا وسهلا.
نستاذنك طال عمرك نبدا الفعاليات.
تفضل.
الله.
الصوت واضح؟
صوت واضح، تفضل.
بسم الله الرحمن الرحيم، والحمد لله رب العالمين الذي أمرنا بالتقوى والتدبر، والصلاة والسلام على رسوله الأمي الداعي إلى العلم والتفكر، صاحب المعالي الأستاذ الدكتور خليل بن إبراهيم الإبراهيم رئيس الجامعة، أصحاب السعادة وكلاء الجامعة، سعادة عمداء الكليات، السادة الزملاء أعضاء هيئة التدريس، المشاركين والمشاركات، الحضور الكريم، أحييكم بتحية الإسلام الخالدة، فالسلام عليكم ورحمة الله وبركاته. كلية العلوم الطبية التطبيقية بجامعة حائل واللجنة التنظيمية للمؤتمر ترحب بكم في المؤتمر الدولي سرطان الثدي، التحديات والإدارة. فأهلا وسهلا بكم وبجمعكم الكريم في جامعة حائل. بداية يطيب لنا الترحيب بكم جميعا في هذا المؤتمر الدولي، والذي انطلق من يقين الجامعة في أهمية التطور النوعي في مجالات البحث العلمي التي تقود إلى التقدم في دور التنمية الشاملة والمستدامة لخدمة العلم والعلماء، بما يحقق رؤية المملكة العربية السعودية للاهتمام في تطوير المنظومة التعليمية والبحثية، لتصبح المملكة من بين أفضل 10 دول في مؤشر التنافسية العالمية بحلول عام 2030.
Bismillah ar-Rahman ar-Rahim. Praise be to Allah, the most gracious, the Lord of the universe, who commanded us to be pious and to contemplate. And blessings and peace be upon his messenger, who calls for knowledge and reflection. Your Excellency, Professor Dr. Khalil Ibrahim Al-Ibrahim, President of the University. Your Excellencies, Vice Presidents of the University. Your Excellencies, College Deans. Dear brothers, colleagues, and faculty members. Dear participants, ladies and gentlemen, I greet you with the eternal greeting of Islam. Peace, mercy, and blessings of Allah be upon you. The College of Applied Medical Sciences at the University of Hayat and the Conference Organizing Committee would like to welcome you to the International Conference entitled Breast Cancer, Challenges and Management. A warm welcome to the University of Hayat. First, we would like to welcome you all to this international conference, which started from the university's assurance of the importance of high standard development in the fields of scientific research. This development that led to progress in the role of comprehension and sustainability in of science and scientists in order to achieve the vision of the Kingdom of Saudi Arabia. The vision to pay attention to the development of the educational and research system, so that the kingdom would be among the best 10 countries by the year 2030, according to the Global Competitiveness Index.
الإخوة الحضور، خير بداية لكل بداية آيات من الذكر الحكيم يتلوها على مسامعكم مالك الزامل.
Dear distinguished guests, we begin our conference with the best teachings from the Holy Quran that will be recited by Malik al-Zamid.
أعوذ بالله من الشيطان الرجيم. إن هذا القرآن يهدي للتي هي أقوم ويبشر المؤمنين الذين يعملون الصالحات أن لهم أجرا كبيرا وأن الذين لا يؤمنون بالآخرة أعتدنا لهم عذابا أليما ويدعو الإنسان بالشر دعاءه بالخير وكان الإنسان عجولا وجعلنا الليل والنهار آيتين فمحونا آية الليل وجعلنا آية النهار مبصرة لتبتغوا فضلا من ربكم ولتعلموا عدد السنين والحساب وكل شيء فصلناه تفصيلا وكل إنسان ألزمناه طائره في عنقه ونخرج له يوم القيامة كتابا يلقاه منشورا اقرأ كتابك كفى بنفسك اليوم عليك حسيبا.
اليوم نجد أنفسنا في هذا المؤتمر الدولي الأول لكلية العلوم الطبية التطبيقية، وهكذا هي الحياة، أيام تتوالى ونجاحات تتحقق، ويظل جهد الإنسان هو أساس كل تطور وتجديد. ونحن في رحاب جامعة حائل نحرص على بناء الإنسان وتطوير مهاراته من خلال دعم وتبني مؤتمرات علمية ترتقي بقدرات أبناء الوطن لنلتمس ثمار مخرجاتها بإذن الله بانعكاسها على تطوير الأيدي العاملة والمجتمع. لقد سعينا في مؤتمر سرطان الثدي التحديات والإدارة بالتركيز على عدة محاور، بدءا من التوعية بمرض سرطان الثدي واستعراض أبرز الأساليب الحديثة للتشخيص والعلاج، واستعراض آخر المستجدات في أبحاث مرض السرطان من خلال أيام المؤتمر الثلاث بمشاركة نخبة من الخبرات العالمية والمحلية.
Today marks the first international conference, College of Applied Medical Sciences. With the succession days, succession of successes are achieved. The human effort remains the basis of every development and renovation, and we at the University of Hawaii are keen to empower people and improve their skills by supporting and adopting scientific conferences that raise the capabilities of the people and the community. In this conference entitled Breast Cancer, Challenges and Management, and during the 3 days of the conference with the participation of a group of international and local expertise, we at the university are focusing on several aspects, starting with awareness of breast cancer, reviewing the most prominent modern methods of diagnosis and treatment, and reviewing the latest developments in cancer research.
نستأذن معاليكم الآن لعرض فيلم خاص بالمؤتمر.
We ask your permission now to show a movie about the conference.
يهدف المؤتمر لإيجاد مجتمع حيوي يتمتع بمستوى عالي من الخدمات الصحية ضمن رؤية المملكة 2030 والتوعية بمرض سرطان الثدي. وستكون محاور المؤتمر مشتملة على التوعية بمرض سرطان الثدي وأسباب انتشار المرض وكذلك أهمية الفحص المبكر، وسيتم استعراض الوسائل والتقنيات الحديثة للتشخيص المبكر كالتصوير الإشعاعي والموجات فوق الصوتية والتصوير.
الصوت ساعة العميد، الفيديو والصوت.
يهدف المؤتمر لإيجاد مجتمع حيوي يتمتع بمستوى عالي من الخدمات الصحية ضمن رؤية المملكة 2030 والتوعية بمرض سرطان الثدي. وستكون محاور المؤتمر مشتملة على التوعية بمرض سرطان الثدي وأسباب انتشار المرض، وكذلك أهمية الفحص المبكر. وسيتم استعراض الوسائل والتقنيات الحديثة للتشخيص المبكر كالتصوير الإشعاعي والموجات فوق الصوتية والتصوير بأشعة الرنين المغناطيسي والأشعة المقطعية. وسيتم استعراض الطرق الحديثة في الجراحة لمرض سرطان الثدي، وكذلك دعم وتأهيل الناجين من مرض سرطان الثدي، وأيضاً أهمية ودور العلاج الطبيعي والتأهيل لمرضى سرطان الثدي، والتوعية بأهمية التغذية العلاجية لمرضى سرطان الثدي. وأخيراً سيتم استعراض آخر الأبحاث في علم الجينات وعلاقتها بمرض سرطان الثدي.
سرطان الثدي هو مجموعة غير متجانسة من الأمراض، ومن المعروف أنه يبدأ موضعياً في الثدي وينتشر تدريجياً إلى العقد اللمفاوية الإبطية ليصبح سرطاناً غازياً، ثم يمتد انتشاره إلى الأعضاء الأخرى. ولا زالت أسباب مرض سرطان الثدي غير معروفة ومفهومة تماماً، حيث أن هناك مجموعة من العوامل المترابطة، ومنها العامل الوراثي والعامل الهرموني، وكذلك العوامل البيئية والبيولوجيا الاجتماعية وفيزيولوجيا الأعضاء، بالإضافة إلى عوامل عديدة أخرى. الإحصائيات: لا شك أن سرطان الثدي أصبح هاجساً يخيف السيدات حول العالم، فالإحصائيات تقول سرطان الثدي يأتي بالترتيب الأول بين أكثر أنواع السرطانات شيوعاً عالمياً وإقليمياً ومحلياً. سرطان الثدي هو السرطان الأكثر انتشاراً في المملكة العربية السعودية. سرطان الثدي في المملكة أكثر شيوعاً بين السيدات بعمر 40 عاماً فأكثر. تشير الإحصائيات أن أكثر من 50% من حالات سرطان الثدي في المملكة يتم كشفها بمراحل متقدمة، مقارنة ب20% فقط في الدول المتقدمة. احتل سرطان الثدي المرتبة الأولى من حالات السرطان في المملكة، 2282 حالة، 3.4% نسبة سرطان الثدي من مجموع السرطانات لدى النساء في المملكة، وهو ما يعادل الثلث، والثلث كثير. معدل الإصابة محلياً هو 27.2 لكل 1000 سيدة. أهمية الكشف المبكر لسرطان الثدي: لا شك أن الكشف المبكر عن سرطان الثدي من أهم استراتيجيات الوقاية الثانوية، وهو يزيد أيضاً من نسبة الشفاء التام، مقللاً بذلك من الآثار الجانبية، ويزيد من معدل الشفاء إلى أكثر من 95%، وكذلك يخفض معدل الوفيات بنسبة قد تصل إلى 30%. طرق تشخيص سرطان الثدي: تتضمن الاختبارات والإجراءات المستخدمة لتشخيص سرطان الثدي ما يلي: فحص الثدي: يتم فحص الثدي الإكلينيكي من قبل الطبيب المختص. التصوير الإشعاعي للثدي أو ما يعرف بالماموغرام، وهو تصوير الثدي بالأشعة السينية. أشعة الموجات فوق الصوتية US. خزعة الثدي: تصوير الثدي بالرنين المغناطيسي MRI. خيارات العلاج: يحدد العلاج وفقاً لنوع سرطان الثدي ومرحلته ودرجته وحجمه، ما إذا كانت خلايا السرطان حساسة تجاه الهرمونات، مع مراعاة الصحة العامة للمريضة. ومن خيارات العلاج: العلاج الجراحي: تخضع معظم السيدات لجراحة سرطان الثدي، عن طريق إما إزالة واستئصال الورم أو إزالة الثدي بأكمله. العلاج الإشعاعي: يستخدم العلاج الإشعاعي حزماً قوية جداً من الطاقة مثل الأشعة السينية والبروتونات لقتل الخلايا السرطانية. العلاج الكيميائي: يستخدم العلاج الكيميائي أو الأدوية ليدمر خلايا السرطان ويقلل من نسبة عودة المرض أو انتشاره في أجزاء أخرى من الجسم. العلاج الهرموني: يستخدم العلاج الهرموني لعلاج أنواع سرطان الثدي الحساسة للهرمونات. وهناك طرق مختلفة للعلاج تحدد من قبل الطبيب المشرف على حالة المريض كالعقاقير الموجهة أو العلاج المناعي والعلاج بالخلايا الجذعية والرعاية الدائمة التلطيفية، وكذلك العلاج بالطب البديل لعلاج حالات التعب كممارسة التمارين الرياضية الخفيفة والتحكم في التوتر لتقليل الإجهاد، وأيضاً من خلال التعبير عن المشاعر. ولا نغفل عن دور الرعاية والعلاج النفسي والدعم الاجتماعي، فهو جزء أساسي من العلاج وله دور كبير وبارز يمكن أن يحسن من نوعية الحياة للنساء المصابات بسرطان الثدي وعائلاتهن. لا بد أن نعي جميعاً أن الكشف المبكر عن سرطان الثدي والوقاية منه عملية إدارية منهجية ومستمرة تشمل التخطيط والتطوير والتقييم لبرنامج الكشف المبكر عن سرطان الثدي، بما في ذلك صياغة السياسات وتحديد الأولويات. ويجب أن تطلع المؤسسات الصحية المعنية والمؤسسات والجامعات التعليمية والجمعيات التوعوية كل بحسب في دورها في توعية المجتمع بأهمية الفحص المبكر. أخيراً، لا شك أن المملكة العربية السعودية وعبر رؤيتها التي تجعل من الفرد أولوية قصوى قامت بجهود كبيرة في سبيل الحماية والتوعية من سرطان الثدي عبر البرامج المختلفة كالبرنامج الوطني للكشف المبكر عن سرطان الثدي، وأيضاً من خلال المنصات التعليمية والجامعية والحملات التوعوية. ومن هذا المنطلق قامت جامعة حائل ممثلة بكلية العلوم الطبية التطبيقية بمؤتمرها الدولي الأول عن سرطان الثدي إدارة وتحديات، مواكبة لتوجه الدولة حفظها الله في سبيل المساهمة في تعزيز الوعي ونشر ثقافة الكشف المبكر، وكذلك مشاركة آخر ما توصلت له العلوم والأبحاث الطبية في هذا المجال مع نخبة من المختصين حول العالم.
الآن مع كلمة سعادة عميد كلية العلوم الطبية التطبيقية الدكتور قرين بن تركي الشمري، المشرف العام على مؤتمر سرطان الثدي التحديات والإدارة.
Now a speech by His Excellency, the Dean of the College of Applied Medical Sciences, Dr. Qureen Turki Shemri, General Supervisor of the Conference, Breast Cancer, Challenges and Management.
بسم الله الرحمن الرحيم، والحمد لله رب العالمين، علم الإنسان ما لم يعلم، والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا ونبينا محمد وعلى آله وصحبه أجمعين. يطيب لنا الترحيب بكم بكلية العلوم الطبية التطبيقية بجامعة حائل لحضور فعاليات مؤتمر الكلية الأول بعنوان سرطان الثدي التحديات والإدارة. أصبح السرطان لسوء الحظ كلمة شائعة في حياتنا اليومية، وينطبق هذا بشكل خاص على سرطان الثدي، وهو أكثر أنواع السرطان شيوعاً بين النساء على مستوى العالم، لدرجة أن واحدة من بين كل 8 نساء سيتعين عليها مواجهته في مرحلة ما من حياتها حسب إحصائيات منظمة الصحة العالمية لعام 2020. ومع ذلك فقد تضافرت التطورات الحديثة في التشخيص وطرق العلاج المتقدمة والإدارة الأفضل للآثار الجانبية والإدارة الأفضل للآثار الجانبية، بحيث لا يحتاج السرطان إلى تحديد نهاية الطريق لمعظم الناس. السرطان هي كلمة مخيفة لمعظم الناس، ولكن بين النساء قد تكون كلمة سرطان الثدي أكثر إثارة للخوف لأنها تؤثر على علم التشريح وخاصة المرتبط بالأنوثة. ومع ذلك يمكن أن يحدث سرطان الثدي أيضا بين الرجال، على الرغم من أن فرص حدوثه هي 1 من بين 1000 مقارنة ب1 من بين كل 8 نساء. إن المملكة العربية السعودية بقيادة مولاي خادم الحرمين الشريفين الملك سلمان بن عبد العزيز وسمو ولي عهده الأمين جعلت الخدمات الصحية المقدمة للأفراد أولوية قصوى في رؤية المملكة الطموحة 2030، والمشتملة على برامج الكشف المبكر وعلاج سرطان الثدي. سينعقد المؤتمر على مدى 3 أيام، وستكون أبرز محاوله التوعية بمرض سرطان الثدي وأهمية الكشف المبكر واستعراض الوسائل الحديثة للتشخيص عبر تقنية الأشعة المتقدمة مثل أشعة الماموجرام وأشعة الموجات فوق الصوتية وأشعة الرنين المغناطيسي، واستعراض أبرز الطرق الحديثة للجراحة والرعاية النفسية والتأهيلية لمرضى سرطان الثدي والتوعية بأهمية التغذية العلاجية. جرى تحكيم أكثر من 40 ورقة علمية قدمت للمؤتمر، وبلغ إجمالي عدد الباحثين المشاركين في هذه الأوراق أكثر من 160 باحث وباحثة من 34 جامعة وكلية ومركز بحثي داخل وخارج المملكة. كما أتقدم بالشكر الجزيل لمعالي رئيس جامعة عائل الأستاذ الدكتور خليل بن إبراهيم لدعمه اللامحدود لإقامة هذا المؤتمر ومتابعته الدقيقة لكل تفاصيله، والشكر موصول لسعادة وكيل الجامعة للدراسات العليا والبحث العلمي الأستاذ الدكتور ماجد بن محي الحيسوني لدعمه وتوجيهاته الدائمة، وكل الشكر لضيوفنا المتحدثين الذين تكبدوا عناء التحضير معنا لهذا المؤتمر خلال فترة إعداده وحضورهم لفعالياته، وجميع أعضاء اللجنة العلمية برئاسة الزميل البروفيسور عبد المنعم آدم من جامعة الأمير سلطان. في الختام أشكر كل من أسهم في التخطيط والإعداد والتنفيذ لهذا المؤتمر، ابتداء باللجنة المنظمة لهذا المؤتمر، سعادة وكلاء الكلية الدكتورة أمجاد اليحيوي والدكتور مشاري المشاري والدكتور ياسر الزامل، ورئيس قسم الأشعة البروفيسور بشرى حسين والدكتور جرود الكانترا والدكتور شاهنواز السيد، والمدير الإعلامي للمؤتمر طارق الحربي، وجميع الطاقم الإداري عارف الجميل وغسلان الغسلان ورائد الشمري. والشكر لكل من عمل معنا داخل الجامعة لإقامة هذا المؤتمر، وأخص بالذكر مدير إدارة الإعلام الجامعي الدكتور عايض الخمشي وجميع زملائه في الإدارة، وعميد تقنية المعلومات الدكتور خالد العتيبي وزملائه، ورئيس إدارة المؤتمرات الأستاذ سليمان العامر، ومدير العلاقات العامة الأستاذ درعان الدرعان. أخيراً أسأل الله عز وجل أن تتكلل كل أعمال هذا المؤتمر بالنجاح والتوفيق لتحقيق الآمال والطموح، والسلام عليكم ورحمة الله وبركاته.
كلمة المتحدثون بالمؤتمر يلقيها نيابة عنهم استشاري الأشعة الدكتورة فاتنة بن محمد الطحان، رئيسة البرنامج الوطني للكشف المبكر عن سرطان الثدي، ورئيسة برنامج التحكم بالسرطان، ورئيسة برنامج الأمومة بوزارة الصحة بالمملكة العربية السعودية.
السلام عليكم.
A speech by the conference speakers is delivered on their behalf by the head of the radiology consultancy, Dr. Fatin Mohammed Al-Tahan, Director of the National Program for Early Detection of Breast Cancer, Director of the Cancer Control Program, and Director of the Maternity Program at the Ministry of Health in the Kingdom of Saudi Arabia.
شكرا على التقديم. أول شيء السلام عليكم ورحمة الله وبركاته. يسعدني بل يشرفني أني أكون أنا يعني المتحدثة باسم المشاركين جميعا. هذه طبعا شرف لي كبير، وأشيد خاصة ب يعني مشاركتنا جميعا ومشاركتي بهذا المؤتمر المتميز والذي سيتطرق إلى موضوع جدا مهم كما أشار الدكتور برين أنه هو مهم في حياة المجتمع كله، حيث النساء تعتبر يعني عنصر أساسي في حياة العائلة وبالمجتمع وعاملة أيضا ومنتجة في المجتمع إن كان في بيتها أو في سوق العمل أيضا. طبعا المؤتمر كما أشرتم سيتطرق إلى التحديات اللي تواجه مكافحة سرطان الثدي ومحاولة إيجاد الحلول للقضاء أو للوقاية من هذا المرض، والتي تعتبر من أهم استراتيجيات هذا المكافحة هي الكشف المبكر عن سرطان الثدي، بالإضافة طبعا للوقاية وتأمين طرق التشخيص والعلاج بكل أنواعه إن شاء الله. طبعا أثبتت الدراسات العالمية جدا، هذه حنتكلم فيها خلال المؤتمر، أنه هناك في حال تطبيق برامج الكشف المبكر عن سرطان الثدي سيكون هناك زيادة في نسبة الشفاء وانخفاض كبير في نسبة الوفيات، في معدل الوفيات قد تتراوح بين 25 ل 40%. طبعا وبحمد الله وبدعم قيادتنا الحكيمة تم إنشاء البرنامج الوطني للكشف المبكر عن سرطان الثدي والذي من عام 2012 والذي يغطي جميع مناطق ومحافظات المملكة. متواجد معنا حوالي أكثر من 125 عيادة كشف مبكر في جميع مناطق ومحافظات المملكة، والتي إن شاء الله سنقوم يعني هذا المؤتمر كمان سيسلط الضوء على توفر عيادات الكشف المبكر، حيث من المهم أنك لما تبدأ بالتوعية للسيدات بأهمية الكشف أنه توفر لها مكان مريح ومناسب للكشف المبكر. طبعا الكشف المبكر باستخدام الماموجرام. نعمل كمان في البرنامج الوطني بالشراكة مع جميع القطاعات الحكومية الصحية وأيضا المؤسسات المجتمعية التي تتطلع أو يكون من مهمتها مكافحة مرض السرطان، لأن مسؤولية القضاء على هذا المرض أو مكافحته والوقاية منه هي مسؤولية مجتمعية مشتركة للجميع. ختاما لكم الشكر والتقدير باسمي وباسم جميع المتحدثين في هذا المؤتمر. الشكر موصول لمعالي رئيس الجامعة ولدكتور جريني يعني لجهده المبذول إن شاء الله النجاح الذي نتطلع إلى نجاح هذا المؤتمر، ونرجو طبعا من الله والمولى القدير أن تتواصل هذه الجهود جميعا بهدف القضاء على أول شيء نشر الوعي لدى المجتمع. هذه نقطة جدا مهمة بأهمية الكشف المبكر وإدخال ثقافة الكشف المبكر عن الأمراض بشكل عام المزمنة، والتي تشكل نسبة 70% من أسباب الوفيات المبكرة قبل 70 سنة بالمملكة، وبالذات أيضا لسرطان الثدي. شكرا لكم جميعا ولكم يعني يعطيكم العافية. شكرا.
الآن مع كلمة معالي رئيس الجامعة الأستاذ الدكتور خليل بن إبراهيم الإبراهيم.
Now a speech by His Excellency, the President of the University, Professor Dr. Khalil Ibrahim Al-Ibrahim.
معالي الرئيس بس الصوت متكبر.
بسم الله الرحمن الرحيم، والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. أصحاب السعادة المشاركين والمشاركات في مؤتمر سرطان الثدي، التحديات والإدارة، زملائي وكلاء الجامعة وعمداء ووكيلات الكليات وكذلك أعضاء هيئة التدريس، أحييكم تحية الإسلام، السلام عليكم ورحمة الله وبركاته. يسعدني ويشرفني أن أكون معكم هذا الصباح المبارك في افتتاح فعاليات مؤتمر كلية العلوم الطبية التطبيقية الأول بعنوان سرطان الثدي، التحديات والإدارة. هذا المؤتمر الذي سوف يناقش أحد أهم القضايا الصحية التي تواجه مجتمعنا اليوم، وهو سرطان الثدي، حيث يعتبر سرطان الثدي أحد أكثر أنواع السرطانات انتشاراً، والتي تصيب النساء عالمياً وإقليمياً ومحلياً كذلك، حيث أظهرت الدراسات لسرطان الثدي زيادة متوقعة بنسبة حدوثه تقدر بأكثر من 350% بحلول عام 2025. ويلاحظ أن ارتفاع معدلات وقوع هذا السرطان في المملكة العربية السعودية يرتبط بشكل وثيق مع ازدياد معدل متوسط العمر، حيث أن سرطان الثدي هو أكثر أنواع السرطانات شيوعاً بين السيدات في متوسط عمر 40 عاماً. إن جامعة حائل وهي تحتضن هذا المؤتمر تهدف إلى إيجاد مجتمع حيوي يتمتع بمستوى عالي من الخدمات الصحية ضمن رؤية المملكة 2030. محاور هذا المؤتمر سوف تشتمل على التوعية بمرضان سرطان الثدي، والتي تعتبر أول سبل النجاة من هذا المرض، وأسبابه والأساليب الحديثة لمنع حدوث تشخيصه والعناية بالمرضى وعلاجهم، والتي أصبحت من الوسائل التي لا يمكن تجاهلها لاحتواء المرض. إن الجامعة وبدعم وتوجيه من القيادة الرشيدة بقيادة خادم الحرمين الشريفين الملك سلمان بن عبد العزيز وولي عهده الأمين الأمير محمد بن سلمان، وبمتابعة من مقام وزارة التعليم بقيادة معالي الدكتور حمد بن محمد آل الشيخ، أخذت على عاتقها أن تكون رائدة في السعي لتحقيق رؤية الدولة حفظها الله مع شقيقاتها من الجامعات الأخرى. ولا شك أن أهداف الجامعة متمثلة في التعليم الراقي والبحث العلمي المتميز وخدمة المجتمع الهادفة عبر إقامة مثل هذه المؤتمرات والفعاليات. إن اجتماع نخبة من الخبراء والمختصون من دول مختلفة في رحاب الجامعة على مدار 3 أيام لمناقشة مثل هذه القضايا الصحية ووضع التوصيات اللازمة، لا شك أن هذا يجسد أكبر خدمة تقدمها الجامعة للمختصين والمجتمع معا. لا شك أن حكومة المملكة العربية السعودية وعبر رؤيتها الطموحة والتي تجعل من الفرد وصحته أولوية قصوى قامت بجهود كبيرة في سبيل الحماية والتوعية من سرطان الثدي عبر البرامج المختلفة للتوعية والكشف المبكر خلال المنصات الطبية والتعليمية والجامعية التي تبناها وزارة الصحة والمنظومات الصحية في الجامعات السعودية. ومن هذا المنطلق قامت جامعة حائل ممثلة بكلية العلوم الطبية التطبيقية بعقد هذا المؤتمر الأول عن سرطان الثدي، وذلك لمواكبة التوجه الدولة حفظها الله وتوجه وزارة التعليم والجامعات في سبل المساهمة في تعزيز الوعي المجتمعي والصحي عن هذا المرض الخبيث ونشر ثقافة الكشف المبكر، وكذلك مشاركة آخر ما توصلت له العلوم والأبحاث الطبية في مجال تشخيص وعلاج سرطان الثدي مع نخبة من أبرز المتخصصين حول العالم. أخيراً نتمنى لكم فعاليات علمية طيبة خلال ال3 أيام المقبلة، وأن تكون هناك توصيات تجد طريقها إلى التنفيذ على أرض الواقع لخدمة المجتمع والحد من مرض سرطان الثدي. شكراً لكم والسلام عليكم ورحمة الله وبركاته.
شكرا معالي الرئيس.
في الختام أشكر كل من أسهم في التخطيط والإنفاذ والإعداد والتنفيذ لجعل هذا المؤتمر ينبض حيوية وإبداعا ويعمر بالمحبة والتآخي، لتكن أحلامكم وطموحاتكم بحجم محبتكم لهذا الوطن، وشكرا لكم.
In conclusion, I thank everyone who contributed to the planning, preparation, and implementation to make this conference vibrant with a collaborating and welcoming environment. Let your dreams and aspirations be as large as your love for this country. Thank you.
دقائق ويبدأ البرنامج العلمي للمؤتمر.
In a few minutes, the scientific program of the conference shall commence.
Thank you so much. We will start soon. Just 2 to 3 minutes, we will start the scientific program. Thanks. Good morning, everybody. Thank you so much for coming today. And we have 3 days conference, and we'll start today with first speakers. We will open our session for today with first keynote speaker, Professor Julie Sparkle. She is working as a professor and she's founder and president of Bahrain Breast Cancer Society. So please join me to welcome her, and we start the session.
Salam alaikum. Ismi Professor Julie Sparkle. I am thrilled to be part of the conference today, Breast Cancer Challenges and Management, hosted by the College of Applied Medical Science in Saudi Arabia. I would like to extend my sincere appreciation for Dr. Amir Abdulatif and Dean and overall Chair, Professor Salam alaikum. Ismi Professor Julie Sparkle. I am
كمان هاي كان دوش. On the breast card. It's not sharing.
Salam alaikum. Ismi Professor Julie Sparkle. I am thrilled to be part of the conference today, Breast Cancer Challenges and Management, hosted by the College of Applied Medical Science in Saudi Arabia. I would like to extend my sincere appreciation for Dr. Amir Abdulatif and Dean and overall Chair, Professor Al-Shamari. Before I proceed any further, I would like to introduce my presentation as the global perspective of breast cancer, and also to note that I have no conflicts of interest, but only noting that I am the founder and president of the only standalone breast cancer charity organization in the Kingdom of Bahrain, Think Pink, but that position is as an unpaid volunteer. So let's get started. Whilst we are all aware that breast cancer is the most common cancer in the world for women, we are also aware that men are on the increase of being diagnosed with breast cancer. The World Cancer Research Fund incidence and survival rates noted in 2012 that nearly 1.7 million new cases were diagnosed in 2012, representing 25% of all cancers in women. Well, at the time of the report, that incident varied across the world from 27 per 100,000 in the Middle East and Eastern Asia to 92% per 100,000 in North America. It is the most frequent cause of cancer death in women from regions characterized by low indices of development and or income, and this equates to 14.3% of all deaths. And the second most frequent from regions characterized by high incidence of development or income at 15.4% of all death after lung cancer. Moving forward, as you see on the slide, 6 years later, we see a jump in newly diagnosed. Globoclan, where the evidence is from, is an online database providing global cancer statistics and estimates of incident and mortality in 185 countries with 36 types of cancer and all forms of cancer combined. We can see from the graph that 630,000 women were estimated to die in 2018. It's 15% of the total breast cancer, of the total cancer was breast cancer. From the global perspective, we might say that 2 types of breast cancers can be diagnosed within women. This multi-scheme can be subclassed into screened breast cancers or clinical presenting, hormone positive or negative, conservative breast cancer mastectomy, immediate or delay reconstruction, and benefits to Herceptin and doesn't benefit to Herceptin. Developed healthcare systems versus women living in least affluent of the developing world is another thing to consider. Did you know that 70% of breast cancer deaths happen in the developing world? In fact, 5-year survival rates from breast cancer are about 80% in higher income countries, but the statistics drop to 60% in middle income countries and 40% in lower income countries. Too often in low and middle income countries, doctors will see advanced, complicated or unusual breast cancer cases, and they may not have the resources or the expertise to know how to move forward with the patients. This is what I'm seeing here in Bahrain, and it was definitely what I was seeing in Brazil. One reason for poor breast cancer outcomes in low to middle income countries is the long delay in getting definite cancer diagnosis and starting treatment. One study that I noted showed the system delay for breast cancer in high income countries ranged from 10 to 42 days, while in Mexico City, reported delays of 5 months or greater. The longer it takes for women to access proper breast cancer care, the more advanced her cancer becomes and the poorer the prognosis. We all know that. For example, in the US, 60% of breast cancer patients present with early stage diseases, while this is true for only 20% of breast cancer patients in Brazil. From 2002 to 2012, breast cancer mortality declined from 17.9 per 100,000 to 15.2 per 100,000 in Europe, while the incidence had increased by 30.5-ish%. The mortality had not increased significantly from 2003 to 2016. An estimate from the United States reported that between 384,000 and 614,500 breast cancer deaths had been averted through improved treatment between the time period of 1989 to 2018. Country-specific differences in age standardization female breast cancer mortality is the basis for what we're going to talk about resource-rich regions and resource-poor regions. This is the global perspective. Increasingly, mortality gaps within countries and across countries within the same region are striking. Key factors that are the most likely contributing are population structure and the difference in tumor biology and geometrics. among different populations, with the effect totally exacerbated by gaps in healthcare systems and quality of care. Although there is a genetic contribution of inherited mutations in cancer, genes such as BRCA1, BRCA2 have been widely studied. Most women with breast cancer have no identifiable genetic risk factors. All global regions are recording an increase in incidence of premenopausal breast cancer, presumably linked to epidemiological transition and changing reproductive patterns associated with increased risk of triple-negative breast cancer. Unfortunately, both the looming epidemic of premenopausal breast cancer and the presentation at advanced stages in the low to middle income countries have not received the attention it deserves from the global scientific community. Incidence of premenopausal breast cancer in these countries is significant. To better understand the enormous influence of this disease on public health, it is worthwhile to review and analyze the related global trends. Thus far, several regions and national studies on breast cancer incidence and mortality have been performed, and the results of the various studies from different parts of the world present an inclusive picture. Epidemiological studies from Arab countries, India, Latin America, and Europe show an alarming rise with the associated incidence and mortality. However, specific studies of breast cancer burden at global level are lacking. The identified incident patterns of postmenopausal breast cancer are probably attributed to the increase in lifestyle and reproductive factors that are causally associated with breast cancer. Risk of postmenopausal breast cancer, for instance, is significantly augmented with the increased body mass index. As the prevalence of obesity is rising worldwide, and this region are in the top 5, some of the countries are in the top 5 for obesity, we are seeing more than 50% of adults classified as obese. One of the studies showed this is an impending risk factor of global cancer. We look at this screen and we see the country-specific differences. And whilst this is 3 years ago, what do we know? What we do know is that this is an estimate and a guesstimate in some places. But what's really happening on the ground? GloboCan, Cancer Tomorrow predicted a tool from Bray, publication that Bray 2018 used in the Cancer Journals for clinicians. They highlighted the further narrowing conversations and highlighted variations in the premenopausal and postmenopausal breast cancer incidence and mortality burden by development levels and geographical regions. Notable findings included the increase in incidence exclusively in premenopausal ages in high-income countries, and that the largest increase in postmenopausal breast cancer were primarily in countries undergoing socio-economic transitions. Finally, case fatality of premenopausal and postmenopausal breast cancer was greatest in low-income and middle-income countries, highlighting the inequalities in the mortality burden worldwide. Implications of all the available evidence means that we are able to, as healthcare providers across the multidisciplinary team, plan because early diagnosis and access to breast cancer treatment remain crucial in low-income and middle-income countries. Moreover, they will inform preventative initiatives warranted in the world regions to curb future breast cancer burdens. When we looked at the Global Cancer Observatory slide 2018, we get a snapshot of a global perspective, increasing the mortality gap within countries and across countries within the same region is striking. Key factors that are most likely contributing are population structures and difference in tumor biologies. This effect basically exacerbates the gaps in healthcare systems and quality of care. Although genetic contributions, which we mentioned in the previous slide, contribute to the inherent mutations of cancers, such as BRCA1, BRCA2, that although they have widely been studied, most women with breast cancer have not identified a genetic risk factor. But all global regions are recording an increase in incidence of premenopausal breast cancer. According to the worldwide epidemiological data and recent advances in genetics, we've begun to understand that there may be geographic, racial, ethic, and possibly cultural diversity in terms of genetic predisposition, age standardization incidence, and mortality of breast cancer. A deeper understanding of this potential diversity is established, will be essential, beg your pardon, to establish screening and prevention schemes, as well as systematic treatments that are optimized and specific for each region. The onset of breast cancer also differs across countries. In most Western countries, 48% of breast cancer patients are diagnosed at the age of 50 to 69, with the risk of breast cancer progressing increasing around the age of 50. For instance, in the United States, the median age of diagnosis is 62, and 82% of breast cancers are diagnosed in women at the age of 50 or older. About 90% of breast cancer deaths occurs in the same group. However, in Asia, countries such as China and Japan, the peak age standardized incidence occurs at an earlier age than in the Western countries, most cases concentrated at the age of 45 to 69. A study that came out of Qatar in 2017, Brown and al., predicted the same sort of thing, that our GCC nationals are being diagnosed with breast cancer 10 to 15 years younger than our Western counterparts. And it's surely what I've been seeing in Bahrain. I wanted to take a snapshot because this is the country I've lived in for the last 18 years, and our neighbors are Saudi Arabia, and this is where the conference is, just to put things into perspective. IARC is an international agency for research on cancer, and their COO and group head of screening, Dr. Sankar Naraya, was in Bahrain in January 2017 as a keynote speaker at the CME accredited Bahrain Breast Cancer Forum, for which my charity hosted. He reiterated that correct data collection and the completeness of cancer registries vary, giving us rise to estimates that may or may not be reflecting what's happening on the ground in certain areas of the GCC. In a funded research by Think Pink, the main investigator and PI was Fatima Al-Hanam. She published her work in 2018 and investigated the spectrum of BRCA1 and BRCA2 germline mutations in familiar and early onset breast cancer among Bahraini women. The entire coding sequence and introx exon boundaries of BRCA1 and BRCA2 genes. What she found was 2 harmful BRCA1 and BRCA2 mutations were detected, and 1 mutation in BRCA1 gene, which was not reported previously, all registered in the BIC database, suggesting that this might be novel. In addition, the researchers also identified 24 polymorphic and unclassified variants. The data suggests that BRCA1 and BRCA2 mutations may contribute to familiar breast cancer in Bahraini patients. And the data also suggests that utilizing this BRCA1, BRCA2 in screening mutations might be the next generation sequencing. I wanted to highlight this as a global difference. It's an area where I live, and so a global perspective whilst we're looking at breast cancer, we're realizing that there's many independent, individual snapshots happening around. Hence, that not one glove fits every region, and hence the guidelines for breast cancer need to reflect that accordingly. When we talk about a global perspective, we must then look into the different actions taken globally. The global perception in relation to how breast cancer is treated and its gaps. It was for this reason, and the reason that at a grassroots level I have seen changes in 16 years, that my NGO directed our efforts into developing what is now the most recent and up-to-date breast cancer screening guideline for the region based on clinical scenarios. Understanding this cultural nuance and realizing that West is not always best, and being a breast cancer survivor myself, was one of the driving forces. And I wanted to give you a snapshot into this. We're talking about Bahrain in these last few slides and the incidence and the potential genetic disposition that relates to the national population. In a mapping review that I did of literature from Bahrain from 1974 to 2018, we realized the gaps in literature included a guideline. So we wanted it customized. I'm very much Bahraini on the inside, although I'm born in Australia, and I really wanted to be part of that push to make a change. So this is how we developed the guidelines. Also knowing that everyone's singing from a different hymn book within the region, because many medics, nurses, and healthcare professionals on the multidisciplinary team are from different countries around the world. We wanted them to sing from the same hymn sheet. We also wanted our patients to understand the pathways, which is critical. Where do they go when I find a lump? What do I need? What are my risk factors? And we also made sure that the rigor of the development was pushed back against the Institute of Medicine, Lance's red flags, and the agreed-to tool. We realized that specifically for Bahrain, although there's a global perspective, we are very unique. And we definitely need organized population-based breast cancer screening. And we definitely need some sort of hymn sheet or guideline. Hence the guideline was developed as we turn into an area of privatization for health across the GCC, which will potentially mean we definitely need guidelines. Along with this, and as further research, I've just finished a 1-year-long study with EBSCO, Information Services, to develop a breast cancer, basically cheat sheet for 3 of the patient-centered clinical scenarios from the guidelines itself, which are in Arabic and in English, of what patients feel that they need to know. So this example is construction, or to have it later or sooner, and their risk factors based on the IARC publications and the WHO publications and the cancer registries. The current reach of this has been endorsed by many entities around the world, which is fantastic for Bahrain, and slowly being taken up by the Ministry of Health here, but we're all in the midst of COVID and it's quite consuming, but ironically, we still have patients being diagnosed with breast cancer. So we keep on pushing. Whilst this is a global perspective, I think it was important to see many of the speakers are from different places around the world and will have their own perspective of what's happening on the ground. But for me, this is a very important conference to be able to showcase like-minded academics, students, healthcare providers, and be able to give our stance on what we're seeing going on in the countries that we live. Thank you very, very much for this opportunity. I appreciate your time, and have an enjoyable rest of the conference. Thank you very much.
Thank you so much, Prof. Julie. It's a great talk, and I'm grateful you will be with us today. And I have just one question for you, Prof. So what's the care you can give it to the patient after finish treatment? Yes, just the question for Prof. Julie.
Yep.
It's okay, Prof. Julie, yes.
Home here. This is COVID homeschooling. Say salam, Yasmin. Hi, everyone. Hi. I think the care that is given on the ground from us, from our standpoint of view, is being able to inform our patients with the best evidence and moving forward, arm them with the information that they need before they come. Here in Bahrain, the clinicians only have 7 minutes between patients. So we've developed a cheat sheet per se, so that patients are able to understand the evidence and where they fit within that stance. I think that supports the professionals, the multidisciplinary teams. I'm so sorry, that's why we pre-recorded.
It's okay.
The future of Bahrain. But yeah, this is everyone's reality at the moment. But yeah, that's where I see it. I think the more transparent we are, the better grasp they have of the disease. I was diagnosed when I was 23 in London. I was by myself. I'm from Australia. You know, I didn't get a whole lot of information. I was guided. So information is key. Knowledge is power.
Okay, thank you so much, Prof. And we are.
Is it possible to have another chance of questions?
Yes,
absolutely. I'll stay around, but we'll be muted. Say,
sure, Prof.
Salam, a good girl.
Yes. Is it possible to have a question for Dr. Julie?
Yes, sure. Yes, go ahead.
My question, if you don't mind, I'm sorry to come late, little lagging behind. My question is that, do you feel, is there any chance of gloominess? Is the picture gloomy when you look into the resources, the funds raised, the research is done, and the enthusiasm of people to eradicate or at least to limit the incidence of cancer or to have good welfare for patients who are affected by breast cancer? Do you think, is there any place for gloominess?
And I think there is aspects in every disease which is gloomy. I think I've been here quite a long time, so I've seen as my colleagues, my friends become older, they revert back to traditional ways of thinking, which is ironic, many of them being in healthcare. I think the driving agent is the schools and educating them at that level and giving them the opportunity to understand what's going on. There's some fantastic people in this region. There's some fantastic people within the region and offering things, but I think we need to look across the multidisciplinary team and have the patient as the key and ask the patients what they want. From the guidelines that we developed, 32 of the clinical scenarios, many of the surgeons didn't understand why we were going down the physio or the nutrition or the different pathway, because after one of their pathways finished, they move on to their colleagues. But the patients felt that some of the questions needed to be answered. So I think we always need to have patients in our mind, you know, that's the reason we do our jobs, and ask them, because, you know, they know. But I think it's positive. I think there's more positive than negatives in answer to your question.
Thank you so much, Prof. Julia.
Thank you very much for your question, for your answer of my question.
Yeah. And I see you are a little bit busy, and thank you so much for coming today.
Okay. Thank you.
So
thank you.
Have a good day. Thanks.
You
bye-bye.
too. Bye-bye.
Thanks. Bye-bye. Now we'll yes, we will move to the second speaker. We are pleased to welcome the next keynote speaker, which is Prof. Alfonso Tijan. We are so happy to be with us, Prof. And the Prof is currently a professor and consultant of radiation oncology at Harvard Medical School, USA, and he has a long experience about oncology. And we are so happy today because he joined us on the conference and to do a presentation. I know, Prof. Alfonso, now it's about 2 a.m. in New York Times, and we are so sorry to keep you stay with us.
That's all right. It's my pleasure.
Yeah. Yes. Thank you so much, Prof. Now we'll start the presentation with lymphedema after treatment for breast cancer, screening and risk factor.
Hello, my name is Alphonse Tagian. I am a breast radiation oncologist working at Mayo General Hospital in Boston. I am also the director of the lymphedema research program and a professor of radiation oncology. Hello, my name is Alphonse Tagian. I am a breast radiation oncologist working at Mayo General Hospital in Boston. I am also the director of the lymphedema research program and a professor of radiation oncology at Harvard Medical School. I would like to thank the organizers for inviting me to give this talk on screening and risk factors for breast cancer-related lymphedema. So I just wanted to give you an idea about how devastating lymphedema is to patients. And I asked actually 900 patients about what they feel about lymphedema. And I selected few quotes. Lymphedema almost immediately after surgery, like it happened immediately after surgery for this patient, it has ruined my life. I feel like a freak. I would almost rather I had died. One of the strongest quotes I have seen. The other one is, I fear lymphedema more than recurrence. And I heard this from more than a patient. And the other thing, it also affects the family. This is a husband of a patient who developed lymphedema. It strangled the mobility and quality of life from my wife and consequently from me, because the husband will always wrap the patient arm continuously every day. So why lymphedema is so devastating? Because it is obvious to everybody that the patient has lymphedema. While usually patients after years from the diagnosis of breast cancer, they like to heal, like to put things behind them. And this lymphedema, this swollen arm, will always remind them that they had breast cancer in the past. And it also tells everybody who meets them socially that, yeah, we know that you had breast cancer. Also, lymphedema at this stage is incurable, so you can do nothing about it. You just palliate it. It has been devastating on the impact on the quality of life, the body image, and the upper extremity function. And there are a lot of publications about that. And the issue is that it could be prevented in many patients, as we will see in this presentation. Now, there are many ways that lymphedema presents to the healthcare providers. The upper panel, that's 3 different ways, and the lower panel. And I think the success of the treatment will depend on when you see the patient. The upper panel is what I call impairment-based model. So it's sort of like, let me see the problem first, and then I will refer the patient to the appropriate people, which in this instance is physical therapists. And then what do you think the physical therapist will do when you have an arm like that or like that? This is too advanced. The percentage here means that the right arm or the affected arm is larger than the unaffected arm by 54%. Now, what I would like to see in the future is screening-based model. I would like to send the patient to physical therapist when you still don't see the lymphedema. You just measure it. And in order to do that, you need to have a screening program. So you need to have a way to measure the arm, compare it to the other arm or to the baseline, and find out what is the relative volume change. 7%, 3%, or 11%. 11% is considered lymphedema because it is more than 10%. So what I would like to talk about is, can we switch from impairment-based model, which is the model which is mostly everywhere, into a screening-based model? Now, what is the optimal technique to measure lymphedema? So the cheapest one is actually a very simple tape measurement, and then you could take the circumference at many points. You could do every 4 points, or you could do actually like a 1 point here below the elbow, and another one here above the wrist, and the third one here. And then you take these numbers and you put them in the truncated cone formula, and then you will calculate the volume of the arm. And I will tell you why using just the circumference to diagnose lymphedema is just wrong. The second one is water displacement. It used to be used in the past. It's very unhygienic, and you cannot just use it in a screening program when you need to measure at least 20, 30 patients a day, like the way how we do it. We use at Mass General the Perometer, which is an infrared volumeter. So there is a frame here with some infrared technology in it, and then the patient sit and then extend her arm like that, horizontal, and then this frame will go back and forth, and then the volume of the arm will show up on your screen. And it's usually very accurate. And then there is a method, bioimpedance. It doesn't really measure the volume, it just measure the ability of an electrical current to pass through the limb, which relates to the volume of fluid under your skin. Now, is it necessary to have a baseline measurement? In one of our first studies, we looked at 1,000 patients, and then we wanted to know whether both arms are equal in volume, just without any surgery. And then we found that what we expected, a bell-shaped distribution, but we were really surprised to know at least 28% of the patient, they have an asymmetry of more than 5%. Just they are born one arm larger than the other. And then 3% have an asymmetry of more than 10%. Now, 10% is the definition of lymphedema. So 3% of your patient, if you don't know that originally at baseline, they have one arm larger than the other by 10%, you will misdiagnose this patient. So it is very important to know what is the baseline, whether one arm is larger than the other without any treatment. That's very important. Now I wanted to know what is the level of uncertainty. What if you don't have the baseline measurements? What if you see the patient for the first time after the surgeon performed a surgery? So we found with some calculation, assuming that there is no baseline, and we took a quasi-baseline after surgery, that we will underdiagnose or overdiagnose 40 to 60% of the patient. And that's why I feel very uncomfortable to measure a patient without baseline, because I might diagnose the patient that, yes, there is an arm larger than the other by 10%, but in fact, it was like this before surgery. And this is very, very serious. Now, how do we quantify lymphedema? So we developed a formula. It's called relative volume change. It looks like it's very sophisticated, but it is not at all. This is the affected arm. So you put the volume of the affected arm or the ipsilateral arm at baseline right here. That's one. And the time, the follow-up after that. And you put with the unaffected arm at baseline, unaffected arm in the follow-up. And then you plug it into this formula, you will have a relative volume change, which will come on a percentage. So relative volume change 10% or 5%. So this is basically quantifying the increase in volume of the affected arm with integrating the baseline measurements. And then we developed another one for patients who have bilateral surgery. Now, how do we define lymphedema? So there is no universal standard definition for lymphedema. The one which has been used a lot is the absolute circumference change of more than 2 centimeters. Then you take it at 1 or 2 points, like 1 point above the elbow, 1 point below there, or an absolute volume change of 200 milliliters. Either you transform the circumference into a volume, or you do some volumetric measurements, or an absolute volume difference of more than 10%. So you could see that it's absolute. So that's with whatever way you measure, some people will define lymphedema as an absolute change. We prefer the relative volume change, and I will tell you why in a second. So, and we define relative volume change as more than 10% as a lymphedema. Not only us, but a lot of people, with some acceptance of this definition. The people who uses the bioimpedance, they define an LDEX score, is some score which comes on this little machine of more than 10, or some people also define it as more than 7.5 or any change from the baseline. Why absolute difference between one arm and the other is flatly round, and why we moved into the relative arm volume. So let's say we have a clinical trial to evaluate, for instance, the lymph node dissection versus sentinel lymph node. And one of the endpoint is lymphedema. So if we go with the absolute volume change or absolute difference in circumference of 2 centimeters, we will basically, taking the definition of 200 ml as a definition for lymphedema, we could see a difference in the arm volume of this patient here, which is a small arm, between this and the opposite arm of an increase of 1.5 centimeters of circumference, or an increase of 180 ml as in relative volume change is 15%. While if you have the difference of 2 centimeters in circumference here, comparing one arm and the other in a very large arm like that, the 2 centimeter, 2.5 centimeter difference will represent 3.7%. And then when you put a graph here, if you look at an increase, an absolute increase of 200 ml, or absolute increase in circumference of 2 centimeters in a very large volume, it will represent only 4% increase in volume. Or in a very small volume, arm volume, it can represent almost 13 or 14%. So the 3% difference is actually not lymphedema. It could be temporary, or it could be just the patient as a baseline had 3 or 4% difference, like the majority of patients. Yet, if you use a 2 centimeter circumference, you will diagnose her as a lymphedema patient. And the opposite here, you will have to wait until the relative volume change is almost 14% in a small arm in order for you to see a difference of 2 centimeters in circumference. That is why we think that the absolute difference between right and left arm without any baseline measurement is wrong. It overdiagnosed and underdiagnosed a lot of patients. So we established a prospective screening program for many years now. We measured more than 5,500 patients, and we have a lot of data about that. We wrote about it. Any person, any institution or any department who is interested to establish screening program, it is basically described in this paper. Now, what are the factors which increase the risk of lymphedema, and what are the factors which probably decrease the risk of lymphedema? And I will go one by one. There are 6 which increase the risk and 2 decrease the risk. And we'll talk mostly from the data we generated from our program or over the years, what we learned from. Let's start with the lymph node dissection. Lymph node dissection is the most important risk to increase lymphedema. So we just recently, a few months ago, we looked at 1,800 patients, and all of them had baseline measurements, and they had a screening. They were in a screening program. Like we kept following them prospectively. Every 6 months, we measure them. Every 6 months, we measure them. We define lymphedema as a relative volume change of more than 10%. And we divided the cohort into 4 different categories: lymph node dissection and sentinel lymph node biopsy, plus or minus radiation. So here I'm going to focus at the difference between lymph node dissection and sentinel lymph node biopsy. At 5 years, the risk of lymphedema in the lymph node dissection alone was 25% compared to 8% in the sentinel lymph. So there is no doubt that lymph node dissection increased the risk of lymphedema. And of course, a lot of people found, almost the great majority of publications really showed that. The Zipio in a big meta-analysis actually almost quoted all the time. They found that the lymph node dissection had 20% lymphedema versus 5.6%. Another group from Australia, if you have more than 5 lymph nodes removed, it's 18%. If you have less, it's 3.3%. So lymph node dissection increased the risk of lymphedema compared to sentinel lymph node biopsy, and it has been a tremendous progress in axillary surgery, which reduced tremendously the risk of lymphedema when surgeons moved from lymph node dissection into a sentinel lymph node, in particular for patients who had a negative lymph node or 1 or 2, 3 positive lymph nodes, like I will show you later. So that's number 1. Factor number 2, regional lymph node radiation. And it has been mentioned many times that regional lymph node radiation increased the risk of lymphedema. So we had an early analysis for that, like around 1,500 patients, and we looked at the different fields of radiation based on the type of surgery. So here we put the cumulative incidence of lymphedema, sentinel lymph node here, no radiation, there was basically no lymphedema, but we had breast and chest wall only, breast and chest wall plus supraclavicular fields, or breast and chest wall plus supraclavicular and axillary fields. And we found that when lymph node dissection was alone in this cohort, the risk of lymphedema was around 18%. When we added supraclavicular lymph node radiation and axillary radiation, it jumped up to 25%. So lymph node dissection is 18 to 20, and you add radiation is 25%. Here we had a small number of patients who had sentinel lymph node plus regional radiation, like the Amaros study, and the risk was still small, but we had a small number of patients. So because this paper was published 5 or 6 years ago, and we could see this on this graph of a cumulative frequency. So that's the supraclavicular with plus axilla, so that supraclavicular radiation here, and the chest wall was much lower. And we actually wanted to know when does this lymphedema occur? And this is very important. And we looked at more than 2,000 patients. We had a follow-up of more than 4 years. Again, every patient was a prospective study. Every patient had baseline measurements and was followed every 6 months. So usually the lymphedema occur between 12 and 24 months. And you need to pay attention to that. If you have the sentinel node, it just goes a little bit quickly and then it plateaus, and then it goes down at 5 years. If you have lymph node dissection, it will go quickly and then it will plateau at like 3% per year, and then it will go down with more time. And then if you have the lymph node dissection plus the regional lymph node radiation, it will go up, it will plateau, it will reach a peak at 24 months, and then it will go down after that. So what we see here is that at 5 years, the risk of lymphedema from treatment really goes down. So once you move beyond the 4 or 5 years, your risk of lymphedema from surgery plus or minus radiation will go down. But we still see patients beyond 5 years, at 10 years, at 15 years, and they develop lymphedema. Usually it comes quickly, it's acute, but we are studying this. So the great majority, from my observation, the great majority of the patients who develop lymphedema very late, they have a reason or a cause to trigger it. And I have seen women who had cellulitis. And cellulitis, as I will show you, increased the risk of lymphedema. Some women had a fracture, trauma, or they underwent surgery. And I knew a patient who just had to replace her implant, and then after the operation, she basically woke up with lymphedema in her arm. So it seems to be that the cause of lymphedema, when it comes late, there is something triggered it. But within the first 5 years, it will be mostly related to her treatment. Now, the other thing I wanted to show, what is the contribution of radiation compared to surgery in the risk of lymphedema. There is no doubt when you add radiation to lymph node dissection, you increase the risk of lymphedema. But this increase actually was not significant. And this is shown here, lymph node dissection plus regional lymph node radiation versus lymph node dissection alone. The hazard ratio is 1.2. No doubt we add some risk, but this risk was not significant. The same thing, you add the risk of lymphedema when you give regional lymph node radiation to sentinel node, you go up from 8 to 10.7%, but this risk again was not significant. The only significant risk comes when you compare lymph node dissection to sentinel lymph node radiation. And I just wanted to really highlight a very important thing. When you say radiation increase the risk of lymphedema, you've got to be specific, because we have looked at several thousands of patients with just breast radiation. Breast radiation alone does not increase the risk of lymphedema at all. It has to be regional lymph node radiation. And we don't know whether regional lymph node radiation, is it the supraclav or the axilla or both? I think the supraclav without the axilla still increase the risk of lymphedema. But it has to be regional lymph node radiation to add risk of lymphedema. And unfortunately, when we have positive lymph node, we usually do lymph node dissection, and then we add regional lymph node radiation after this. So we basically increase the risk of lymphedema from 25 to 30%. Now, what about BMI or weight fluctuation? So we looked at BMI, just focused on it, on a large number of patients, almost 800 patients. And we found that when the body mass index is less than 25 or 25 to 30, the risk is still low. But once you reach above 30, the risk is significantly higher with an odds ratio of 3.6. So here we compare more than 30 versus 25 to 30, or more than 30 versus less than 25. The BMI became very significant in a multivariate analysis. And it is important to know that it is universally known, like the great majority of studies looking at BMI and lymphedema, they found that BMI is a significant risk to develop lymphedema. So at the end, if you have a patient with lymph node dissection and regional lymph node radiation and high BMI, this patient will have a very high risk of lymphedema. Now, what about chemotherapy, taxanes and Herceptin? And this was debatable a little. So the studies are not really clear. The association between chemotherapy and breast cancer-related lymphedema is not well defined. Some studies suggested that taxanes and Herceptins were significantly associated with lymphedema. There's a study from my group here that showed that it is not, chemotherapy is not associated with lymphedema, but it's very debatable. Some people found it and others did not find it. Some people really focus on the taxane because the taxane can cause some swelling on its own. And you don't know whether it's really lymphedema or not. So we have to be careful with that. Now, what about cellulitis and seroma? In a study that we have done, we looked at the different prognostic factors or risk factors to develop lymphedema. So we found the BMI as expected, the lymph node dissection as expected, the regional lymph node radiation, and the cellulitis with very high risk of lymphedema. It is very important to inform the patient to avoid infection or cellulitis, especially when patients, they like gardening and they have a cut or a mosquito bite. Just a simple cellulitis will trigger lymphedema. We have seen this many times, and it becomes a vicious circle. Cellulitis causes lymphedema, and lymphedema predisposes the arm to cellulitis. And I have seen women who continuously, just like went into this circle, and they are put on antibiotics for life. So we have to be careful when we advise patients about that. What about subclinical lymphedema? So what is the subclinical lymphedema? We define it as an increase in arm volume from baseline that does not qualify as clinical lymphedema. So there's an increase in volume, but not that much, and is not causing any symptoms, like and not visible. So that's what we define as subclinical lymphedema. And then my point is that if we identify patients at this stage, subclinical, we can see it, but it's there because it's quantified using the problem. Can we intervene? Can we give sort of like prophylactic sleep? And this is a main study that we are working on. So we looked at 1,100 patients followed by 27 months. And we looked at women who had a very tiny increase in volume, relative volume of 3%, or 3 to 5%, or 5 to 10%. What was their natural history? Who will progress into lymphedema and who will not progress? And we actually found that women who had 5 to 10%, they are not lymphedema yet because they didn't reach the 10% line, but they have some swelling, 5 to 10%. These patients had a significant risk to develop lymphedema down the road. Like just a lot of those patients will progress. And we also found it whether it's 5 to 10% early on or after the 3 months period, which we think is like any swelling before 3 months period will be related to post-operative change. There is a study that we moved on with that, and I wanted to know among women who developed 5 to 10%, who will progress into more than 10%? And this is under review. So women who had lymph node dissection and developed 5 to 10%, almost 40% of the patient will develop lymphedema. And this group of patients is worse to attempt treatment early on when they are at the 5 to 10%. But actually, patients with sentinel lymph node, when they develop 5 to 10%, it's only 10% of them will develop lymphedema. So it might be, it might not be worth it to actually give sleep to these women because 9 out of 10 will regress on their own. So how often patients develop this subclinical lymphedema? With lymph node dissection, we have 40% of our patients develop subclinical lymphedema, and 40% of those will progress into full-blown lymphedema. And what we think should happen here, we should probably do a randomized trial, treatment or no treatment for this cohort. However, patients with sentinel lymph nodes, only 24% will develop subclinical lymphedema, and among them, 10% will move into a full-blown lymphedema. Now, are there any factors which can decrease the risk of lymphedema? We looked at immediate breast reconstruction, and we were actually, in a way, surprised. So we had 997 patients, almost 1,000 patients with 1,700 mastectomies. And we did a multivariate analysis, taking in consideration the reconstruction. comparing patients who did not have any reconstruction, like they had flat chest, versus patients who had autologous or single stage or expander and implant. And we were talking here, all of them had immediate reconstruction. There is no delayed reconstruction here. And all of them were included in the screening program. So they were followed prospectively, baseline measurements and follow-up all the way until 5 years. We defined lymphedema as more than 10% relative volume change. In a multivariate analysis, we found that regional lymph node radiation, axillary lymph node dissection, BMI, all those are the 3 classic risks for lymphedema. All of them were significant. Implant reconstruction versus no implant reconstruction versus no reconstruction, the hazard ratio was 0.3, and this was significant, which means that there is a protection or there is an association between a significant decrease in lymphedema if you do an immediate reconstruction. So I wanted to know whether we are the only one who found this or not. Actually, I was happily surprised to see that Memorial Sloan Kettering, MD Anderson, and a group from South Korea, all of them with those number of patients, they found that the odd ratio, when you have an immediate reconstruction, is cut by 2/3, and it aligned exactly with our odd ratio. But the difference is that the other group, they use the 2 centimeter difference between both arms as a definition for lymphedema. And I mentioned that this is probably not the most accurate one. And the other, they said, we'll just rely on the clinical lymphedema, like the arm is enlarged. We did an original analysis which was published, and then we updated this, and this is a work in progress with more than 1,000 patients. And there is a meta-analysis which came recently, just 2 years ago, about breast reconstruction was correlated with significantly lower odds of breast cancer-related lymphedema. So that's a meta-analysis with all the studies put together. However, there was no statistically significant difference found between an implant-based or an autologous reconstruction. But do any reconstruction, whatever reconstruction you would do, there will be a reduction in the risk of lymphedema. So how can we explain that? So there are few authors who really dig deep into this. One of them suggested that when you do a skin sparing mastectomy, most of the immediate reconstruction you will do skin sparing or nipple sparing mastectomy, you actually preserve the lymphatic channels under the skin. While when you don't have any reconstruction at all, you just resect most of the skin. This could be one of the reasons. Another one, when there is no reconstruction, there will be more adhesions, more fibrosis, and more obstruction of the lymphatic flow, and this could be one of the reasons. And another reason related mostly to biology, when you have a tissue expansion or even capsular contraction, so there will be a tissue ischemia, which will increase the expression of VEGF and will stimulate tissue angiogenesis and lymphatic regeneration. This was an explanation presented in 2000. But whatever the explanation is, it seems to be that if the patient undergoes immediate breast reconstruction, the risk of lymphedema is low. Now, what about the other factor? Avoid axillary lymph node dissection for patients with 1 to 2 positive sentinel node. And this is an extremely important step forward. And thanks to the Amaros study and also the Z11 study, where you don't need anymore to do lymph node dissection when you have 1 to 2 positive lesions. The data is very clear in a randomized fashion. And we looked at this actually in our database, the same paper I talked about before, the 1,800 patients. And we found that when you have lymph node dissection and you add the regional lymph node radiation because they had positive lymph nodes, your risk of lymphedema is 30%. Compared to sentinel lymph node plus regional lymph node radiation, your risk is 10 or 11%. So you cut your risk of lymphedema by 2/3. So for people who do lymph node dissection for one positive lymph node, you basically do more harm than good, because if you just stop at the sentinel node and you let radiation do the job, you have the same local regional recurrence. So the local failure rate in the axilla is the same whether you do lymph node dissection or you just keep the positive sentinel node and then you add radiation to that. There is no difference in local failure, but there is a tremendous difference in risk of lymphedema. And that's actually one of the things that we changed in our department. We don't do lymph node dissection anymore for 1 or 2 positive sentinel node. And we actually try to push it a little bit into even 3, but you've got to be careful with that. If you have extensive involvement, if you have extracapsular extension, probably those are the situation when you really need to do the lymph node dissection, just like follow the patient in the screening program and intervene as early as possible. So in conclusion, how can we reduce the risk of breast cancer related lymphedema? Screening program for early detection and early intervention. All what you need to do is just like to take measurements with a tape and then put it in the truncated cone and then generate the volume and then make sure that you have a baseline and then follow the patient every time you see the patient every 6 months. That's you will be able to identify the swelling earlier. Identify high risk patients. Anytime you have a lymph node dissection, high BMI, no reconstruction, early volume swelling, cellulitis, all those patients, they are at a very high risk of developing lymphedema. You might need to keep close eye on them. You might need to continuously measure them, and then as soon as their volume increase, you just intervene with the sleep. And avoid lymph node dissection in patients with 1 to 2 positive sentinel node and apply either the Z11 or the Amaros. Those are the 3 things that I think if we follow them, we will see the risk of lymphedema goes down. And thank you very much. I will be happy to take any questions.
Thank you so much, Prof. Alfonso. It was a great talk, and we are so happy and glad to be with us today. And thank you so much. And the chair of this session it will be Prof. Bushra. Prof. Bushra Hussein is a director of medical radiology department. He's a professor in medicine and radiology. Go ahead, Prof. Bushra.
Thank you very much, Mr. Dean, chairman of session, and actually highly praise the nicely delivered lecture, which is actually for those people who are coming behind. Professor Alphonse has delivered a very nice lecture, and which is proved by thorough research, and it is very nice, good points. Actually, sometimes astonishing, just like comparison between radiotherapy and surgery informing the lymphedema, as well as the comparison between radiotherapy and initiating the edema and between the supraclavicular group and the axillary group in increasing this edema. It is very nice, and I think physiotherapists will benefit from this as well, very, very much like others. And I would like to ask, when do you do the baseline reading of the arm circumference? Do you do it prior to surgery, or you have a special technique for that? And do you have establishment in the department of surgery? Is it, or we're going to be established in the radiotherapy department? The second small question is
one by one.
Okay, great.
One by one.
Okay, thank you.
Right. Yeah, actually, first, thank you for this question, because it is really an important question. In our system, we have a multidisciplinary clinic. So the patient, when they come to see us, we know already that she has breast cancer from a biopsy without any lumpectomy, any mastectomy, any surgery. Just she comes to our clinic in a multidisciplinary. So we have the surgeon, the medical oncologist, the radiologist, the pathologist to review everything in one setting. And the patient just had a biopsy. We measure her arm right in this moment. And then we have a perometer. So that's the machine with infrared technology, which can give us the volume right away. But you don't have, if you don't have it, it's okay. With a little tape, and then you take the measurements in multiple points, and then you put them in the computer in a software, which will give you the volume. That's all what you need. So it has to be before the surgery. You could start neoadjuvant chemotherapy, that's okay. But just before her surgery, that's the time when you have to document the volume of both arms. That's to avoid any misdiagnosis.
Great, great. Thank you very much. The second small question is that, and I think you mentioned this point at the end of your lecture, has the mechanical draining of the arm lymphedema by raising the hand, putting it on a pillow or something like that, does it have an effect, and does it come within the education of patient education usually to raise the hand for draining of the lymphedema of the part which is affected?
Yeah, so you mean like a prophylactic, or do you mean that the patient already developed lymphedema?
Developed already.
Already developed lymphedema. So that's a different ball game now. So once the patient develops lymphedema, there will be a sleeve, there will be wrapping. The sleeve could be 12 hours only, or could be more than that. It depends on the degree of lymphedema. Of course, when you raise your arm and you put it horizontal, sometimes the fluid decreases a little. But at the end of the day, what we need to know is that once the lymphedema is fully established, like the arm is really swollen, there is no curative treatment. That's it. The patient will live all her life with the lymphedema, and she will suffer from it. That's why the whole philosophy of a screening program is just to catch it early. And we still don't know how early is early. We think in our group, early means from the 5 to 10%, but we didn't prove it yet. And this is something we are working on it. But once it is 10%, sometimes I see the 10 to 15%, they put the sleeve and then the swelling goes away with exercise and stretching and stuff like that. But once you reach the 15 to 20%, that's it. You will just
difficult to be reversed.
Yeah, it becomes irreversible.
Oh, thank you very much.
Sure.
Very, very kind of you. Thank you for answering my questions.
Thank you. Thank you.
Is there any question from panel staff or attendants?
Yes. Assalamu alaikum, Doctor.
Yes, Dr. Shahnawaz. Yes, go ahead.
Yeah, very good morning, Professor. Myself, Dr. Shahnawaz Syed from Physiotherapy Department, University of Hyde. Doctor, my question is there is any clinical treatment pathway of lymphedema related to physiotherapy? And what is the clinical criteria for referral of lymphedemic patient for physiotherapy? Thank you.
So criteria to refer patient for physiotherapy, in my opinion, as soon as the swelling reach the 10% relative volume change. But we started, so that's what we think it's early lymphedema. But we started to refer the patient at less than that. So we keep going down from the 10 towards the 9, the 8, the 7. But not every patient with swelling, with early swelling, will progress to full swelling. We found that if you have a high-risk patient, like patients who had lymph node dissection, had regional radiation, and high BMI, and she has 8%, I think this 8% will progress into 10 or more if we don't intervene. But if we have a patient with sentinel lymph node and has 8%, this 8% will regress on its own. So when do we send the patient? We send the patient first when we see high risk factors with a small swelling or low risk factor with a swelling of 10%.
Thank you, Doctor. Thank you very much.
Sure.
Yes, I have a question, Prof. Alfonso, regarding the system of breast cancer patient in USA. So do you take do you have a system, whole system, like before when established the breast cancer until the end? Do you have a care after the breast cancer, finish the breast cancer treatment? Because in G20, the last G20 meeting, and they recommend like a system or care after extend until 6-7 months after finish breast cancer treatment. So could you please give us any information about the whole system you have it in your area? Thanks.
Yeah, so the way how we do it in my hospital, as I described, we have the multidisciplinary clinic, and any new patient comes to it, and we work as a team, and we work always the same team together. You have a breast surgeon, breast radiation oncologist, breast medical oncologist, and then we have the first time there will be the pathologist to show us the slides, as well as the radiologist showing us any breast MRI or mammogram. So that's we are together. And then we all decide how we will treat the patient. Most patients are straightforward, but sometimes should we give neoadjuvant chemo or not neoadjuvant chemo, or Herceptin first? There are a lot of discussion about this. Once we decide about the different sequence of the treatment, the patient will go through all these different types of treatments. Let's say they start with surgery, and then the surgeon will send the patient to the medical oncologist if they need chemo, and then the chemotherapy a doctor will send the patient to me as a radiation oncologist. But at this point, the patient knew all her physician. So that's in the treatment phase. Then after that, there will be a follow-up. And the follow-up is alternated between the different specialties. For instance, the surgeon will see the patient once per year. I will see the patient as a radiation oncologist once per year, but not in the same day, with distance every 6 months. And then the medical oncologist will see the patient twice per year. And then I see the patient for 5 years, the surgeon the same, the medical oncologist will see the patient for longer than that. So the patient stays, and we keep seeing the patient for long period of time. Now, a lot of hospitals, because of the cost and stuff like that, they wanted to really cut this and not doing all this follow-up and then send the patient to be followed by her primary care physician. So we are not there yet, but it might come in the future. But we stick with the patient, we stay with her all the way, at least until 10 years.
Okay, thank you so much. We are so glad to be with us today. And again, I'm so sorry because I know it's 3 a.m. in your area, it's early morning.
Don't worry, I really enjoyed really talking to you, and then it looks like a really a great conference, and hopefully we'll do it again.
Thank you very much.
Thank you so much. Thanks a lot. Thanks. Thank you so much.
We have enjoyed your lecture very much. Thank you, sir.
Thank you.
Thanks a lot. Now the time to go to next speaker is Dr. Salman Al-Baishan. Dr. Salman Al-Baishan is Associate Professor in Medical Radiation Science and Breast Imaging, Mammogram and Radiology Science Department, King Saud University. He has a publication about 15 or 16 related to the mammo and epidemiology of breast cancer. And we are so happy and glad to be with us, Dr. Salman. Yes, Dr. Salman.
Yes, hello, Graham. I'm very happy to be part of this fantastic event, but I need to share my screen.
Yes, just, yeah, sure. Great. The chair will be for this session is Professor Abdelmenam Adam Sleiman. He's a professor in radiology department, Prince Salman University. So he will be chair with us for this session. Yeah. دكتور سلمان خلي الملف
Yes,
just
yeah.
مفتوح الملف وبعدين ارجع اكتب شير سكرين، اختار شير
Yes.
سكرين يكون الملف من ضمن الشاشه اذا. Yes.
I think I have some issue with the security setting. Just a moment.
Yeah, sure.
Yeah. Dr. Crane, when I want to share my screen, I'm getting a message saying that allow browser access. I don't know. This is the first time happening to me, to be honest.
Yeah, so once you open this the PowerPoint on your screen, it's open. Go to share screen and it will give you another option. You can select the PowerPoint.
Yeah, but when I want to select the PowerPoint, it's an empty, and it says that please grant browser access to screen recording.
Okay, just one second. Just one second.
I think you need to.
Now try again.
Same issue.
So now we will start with the second speaker, Dr. Faten Tahan, and until we fix the problem with Dr. Salman. So we'll Jirud, please, Dr. Faten, put the screen for Dr. Faten, please. Yes, until we fix the technical issues with Dr. Salman, we will move to the second speaker, and we are so pleased to welcome next keynote speaker, Dr. Faten Tahan. Dr. Faten Tahan is he's working as senior consultant radiologist, breast imaging, screening specialist, and also, is that your presentation? Yeah, I think the sound from you, Dr. Faten. Just Dr. Faten, the sound, you need to be unmute. Unmute, Dr. Faten.
Is it now?
Yes, it's working now. Just enlarge the PowerPoint. Yes, you can enlarge PowerPoint. Yes, excellent. So just we please welcome Dr. Faten Tahan. He's director of the early detection program of breast cancer and director of breast control center. And we are so happy to be with us. And go ahead, Prof. Faten. The chair of this session, it will be with me. Yeah, go ahead. Go ahead.
السلام عليكم ورحمة الله وبركاته. هذا يعني I will tackle an important subject, as I can find that there's a lot of people who doesn't know that there is an existing national breast cancer program for an early detection. Okay, this slide will show you the aim of this slide to show you the logistic challenges we facing in the implementation and executing the program. The kingdom, it's quite a big one. It's the largest state in the Middle East and considered the 5th largest in Asia, 12th largest in the world. It's more than 2 million kilometers. And this is really a big burden in the way that we are managing the outreaching program. As the Prof. Julie, she mentioned the global burden, I'll mention only the statistics in our kingdom. As you know, 49% of our population is a female, and about 22.6% of the female between age 40 to 69, which is the target group. It's the percentage of our population, and this is our target, more than 2 million lady. And we have also another challenges that we have more than quite big number, between 40 to 50%, and this is why we are starting our program at early 40, not at 50, as other part of the globe, especially the Western countries. The mean age is 78%, and this will add a value for us that it's justified to start a screening program, as their mean age is quite significant. So what's the case we are looking for now to change? And it's the burden for us. It's the we want to change, improve the health of the nation by reducing the burden of breast cancer. Why? Let's see some facts, as this is according to the Saudi Cancer Registry. Breast cancer, as you know, most common cancer, account for 30% for female cancer and 17% for all cancers. It's the most common between men and female. It's also, and you can see trend, there's increase 4.5% per year, which is quite significant. If you notice between the we have here between year 1999 and 2016, there is a trend of increased 4.5%, which is really a significant increase. And this is why we are expecting that the both increase in the incidence and in the mortality for 36% and 160% by year 2030 if we continue this kind of increased incidence. Aging is also, there's also a risk factor. Why we have increased in the incidence, not only because of the increase in the risk factor, aging, we said also one factor, because now we are going more age, more life expectancy now. And also there's increase in the risk factor, according to survey done with the Washington University. You can see that the risk factor, which including obesity, mainly smoking and vitamin D deficiency, physical inactivity, it's quite high. So the burden also of risk factor is quite big. Another facts we have here, that main age is quite younger than the Western population. It's 47 to 50. If you compare 60 to 65 in the Western area countries. And we have also another burden, that we have more than 40% of female in this age group. We have also below 50 years, also incidence is quite big, premenopausal, and this is also another challenges. The main challenges also because of the a lot of reasons منها from it. It's the population concept or misconceptions or beliefs. Still, until now we having diagnosis a lot of cases in advanced stages. Even this is why we have a lot of recurrence and death. Treatment, and this is also add an economic burden to the disease. Treatment is quite expensive if you compare between the treatment early detection, which does not cost more than thousands, to an cost of treatment on advanced cases, which reach sometimes to between 400,000 to 1.5 million per woman. And another thing also, we don't have really until now, we cannot find the real statistics for the mortality rate, which is very important for us to evaluate the progress in the cancer care for the breast cancer, as most of the deaths come at home, or most of them also by death certificate does not, they don't written as related to or because of breast cancer, usually for other reason. This is the bad news. What about the good news? Good news that we have a lot of studies and reports from a lot of countries who implement the population-based program, a screening program, which shows reduction in the mortality rate for at least 25 to 40%. So, and this is what we are aiming to do in the Kingdom, inshallah. The program, so program started in 2012 and by a pilot study, and in 2014 we did a very comprehensive national long-term plan covering until 2025 as the National Breast Cancer Early Detection Program is part of the Cancer Control Program, which is also implemented on 2009, and we also running in addition the colorectal screening program since 2017, and hopefully in the before end of 2021 we will start also cervical cancer screening program. So the vision of the program is we want every Saudi woman to be diagnosed with breast cancer, to become a survivor, but not only survivor, also with good quality of life. The mission, we want to reduce mortality rate, and this will solve or reduce the social burden by at least 30%. If we base there should be at least 50% participation from the target women. And also we want to reduce the economic burden of the disease. As I mentioned, there is a lot of millions expected that if we continue to have the receiving lady with a late stage like this, we will reach 2035, where the cost will be 66 billion for only treatment of the cancers. And also we want, of course, improve quality of life of the survivor. Program strategy, of course, based on the need. First, the prevention. Prevention is very important, and awareness is the key of success. We have a lot of challenges with the participation and the intake of the screening by mammography because of misconception between the women, However, we are trying very hard to do this awareness. The awareness will include also how the important to practice healthy lifestyle and reducing the risk factor. We have an advocacy group for breast cancer. We also part of the people who do the policies and regulation to reduce risk factor, like the taxation of the cigarettes and energy drinks. This is also another risk factor. Implement also Rashaqa fitness program in schools. And also we are with the SFDA for also food labeling policies. And this is all will affect the risk factor, reducing the risk factor. And then we want to ensure that we are delivering an early detection service with good quality, and to be cost effectiveness first, and also, as I said, it should be also easy accessible. And we have established a complete cancer care pathway from this awareness until the treatment. We are aiming, and this is actually happened in most of our clinics, easy access. We looking for sustainable service with good quality. We have a lot of stakeholders. We have collaborative with them. And also we listen a lot to the survivors. We have survivors group who also will always take feedback from them. And because we are centering for patient-centered care, we set guidelines, goals, and program indicators and performance to edit our also service. We have always also a quality assurance team who monitor the quality of the service. Data and information for strategic planning research. This is very important. Now we are running more than 3 research for the program to evaluate the risk factor, to evaluate also if there's any other modalities available for screening rather than only mammography, and also for another one for the cancer below 40, and what's the management of this. And of course, we are very important to build capacity and train the manpower, including the technician, the PACS system, the also, PACS admin, the technologist, the radiologist, the physicist, oncologist, as all these team affecting the cancer care. And we are trying to overcome the shortage, and also we try also to improve the skill of the existing one. The program component is program in the NCD department, where there is the management, program management. We set the goals, the budgeting, we have the auditing, QA, the dashboard, training setting, and the reading center also. We have also call center who can deliver the result to the patient by phone, or now also moving to the SMS. We have clinics, which is either mobile clinics or fixed clinic. Just last month, we delivered 12 mobile clinics to 12 cities in the kingdom. We have also, as I said, fixed clinic either inside the hospital or in the mall. And by the way, there is a very nice one in Hayel, in Grand Mall, where you can have the mammogram there, as well as other screening tests for diabetes, hypertension, for colorectal, and for osteoporosis. We have also data center inside the main building of the Ministry of Health, where all the tests sent to there, and from these sent to the reading center. And all, by the way, all, and of course we have very important, that's the referral center. All our positive cases should be referred to a center. طبعا center have all the diagnostic capacity as well as the treatment. And this is also different according to each region. This all will be integrated and by the what we call it the MOH cloud, where patients come to the clinics and then doing mammography and then sent to the data center, and from data center go to the reading center, and then when the report is ready and issues by our BIS system, call center will receive the result and inform the patient. We have also KPI for all these steps. The implementation and the scale-up plan, which is, as I said, extending to 2025, we start our pilot study in 2012 with, we have only 2 mobile clinics. Then we increase it, including, it was only in Riyadh, the city, and then we extend to the Al-Hassa region, where we have also 6 mobile and 2 malls. Phase 2, which is extend to 22, we have at least 48, and actually it was more than 48 hospital-based center. It was, we achieved to have an 85 within these, with the help of the all stakeholders. We open at 8 clinics in the malls, and we are aiming to open 20 plus over the mobile. As I said, mentioned, we add also another 12 mobile only last month. Of course, we are aiming to cover all the regions and cities with the early detection clinic. Very important. This is very important point when you aware or the lady and motivate her to do a screening, you should also provide a place, because this is the second question, or the logic question after you do awareness, where I have to go. So always with our program and our website as well as the Twitter, we put the location of the clinics, including the Google map. So this is the workflow, as I said. Patient come, or woman, we will not say a patient, because this is for screening, will come for the clinics, either walk-in or be called scheduled. Will initiate the study by the BIS breast informative solution. And then she do the mammography exam. At the same time, this study will go to the data center in the main building of the MOH, and also will go to the reading center where double-blind reading is mandatory. And of course, according to the result, either if the double reading was negative, this will go back to screening, usually in 2 years for an average risk patient or woman, or every year for the high risk lady. And of course, if the double reading, the result was positive, will go directly to the diagnostic center, referral center. In case there's discrepancy, we'll go to the third reader. Of course, use the teleradiology in this case. If after this turn to be negative, we'll go to the screening, and in case of positive, we'll go to the referral center. Until now, we screen more than 300,000 lady. We detect more than about 2,138, which is 7 in 1,000 mammogram. And this is exactly the same rate for the detection in the other screening program. Recall of is even now less than 9%. The biopsy rate for us is not high. It's around 1.36 for total screening, and from abnormal screening, it's about 15%. However, most of the biopsies, if it's benign, we have also in high-risk lesions like atypia, radial scar with or borderline phyllodes, which is justify the also doing the biopsy. Another KPI for us to evaluate the performance is the waiting time from screen to final diagnosis. And this is very important. We have, we call it fast track, film screen to notification of the result of the mammography. It does not exceed 10 days, usually an average between 3 to 4 days. And among abnormal screen time from abnormal screen to the first diagnostic assessment is less than 2 weeks, and from definite diagnosis when she will have biopsy as well as the tumor board, the treatment plan, it should be less than 1 month. Now, according to our statistics and analysis, we have 59% of our ladies who attend are obese, and most of the well-established breast cancer risk factor is not in most of our ladies who have a cancer, they have no factor. This is also will emphasize the need, the importance of teaching the society the importance of an early detection, even if there is no any high risk, or of course if there is no any symptoms. 41% is postmenopausal cancer, only more than in premenopausal. And what is also good for us and that the mammographic density is not high. This is why still the good strategy for us to do screening is the mammography. Now we will go for some challenges we face it, and this will give us some lessons to learn and what we propose solution for that. The main challenges were the cultural barrier and misconceptions. There is fear of cancer. Cancer is quite scary word, and there is denial, there is lack of knowledge, of course. There's a lot of beliefs that this is okay, what God sent us, we have to accept. And of course, there is also afraid of the for marriage or for the daughters. You know, this is a very important point we find it. There's also sometimes some of the barriers of lack of transportation, but I think now with the ladies now are driving, alhamdulillah, I think this will be less burden or less barrier. The importance of these pictures, because you can see the difference between the ladies. There's average lady live in a tent, lady in very high place. I found it all they are facing the case, the breast cancer, the concept of early detection, almost the same. So women facing this and how they deal with the breast cancer at the same. And I think this is also in the other countries, whatever the way they react for doing an early detection and look for a cancer early is still the same. This is the solution we proposed. Of course, we did a lot of awareness. We improved the community intervention. We set strategy also to eliminate these barriers. We outreach the people. We go for we take the vans. We open also in the malls. We do a lot of awareness in not only in primary care centers or health centers. We go to the every place where women there. We have very good health education section in our program where we teach them how they do the communication with the women. We have outreach mobile to all in social area where there is a women traffic and also in the rural area. Now we are using the advantage of social media for promotion of the program and promotion of the also early detection concept. We collaborate, we have very good and nice collaboration with all NGOs and partnership who are, of course, interested in awareness and prevention. And also we provide, very important that also, as I said, when you aware the lady, also to provide a place where there's an easy access for doing the screening test. This is why we established what we call it. This is a slide show you how we are using really the social media just to promote the concept of an early detection. And you can see the curve, how it's increasing by years and years. And as I said, one of our intervention that we open prestigious clinics, screening clinics in the malls, where the mall is a nice place for all women. And as I said, this is, by the way, this is picture photos from Hayel Clinic in Grand Mall, where the lady come with 40 minutes. They can do a screening or examination for hypertension, for diabetes, for osteoporosis, for, of course, in addition to the breast cancer, where there is mammography, and also colorectal. There is also a clinic for mental health where we ask for, this is, by the way, the clinic run by family medicine, family physician specialty. As you can see, the clinic is really nice. This is, by the way, the one in Grand Mall was also supported from SABIC and Zahra, donated from SABIC and Zahra Foundation. And we are aiming to open many of these, inshallah, in a lot of malls in the most of the region. With this, by the way, the malls is the Well Women Clinic in malls is totally PPP, or what we call it private partner, public partnership, where we have support from SABIC, from the owner of the malls, give the place for free, and also the building the clinic, and also the all instrument or whatever it's needed there in the clinic, also supported or donated from private companies, and only of course, the operation will be run by the MOH. Another challenge which is very critical and crucial, it's the primary care, the physician or the role of primary care centers was very poor. And most of the successful program, the key of success was the primary care center, where they have very good يعني collaboration and support for this. The most يعني in ground here, one of the problem that there is no trust for primary care centers, maybe with the corona pandemic, now the trust is becoming more. Hopefully this will also affect the service in other aspect. And there is difference between the primary care center, the quality and standard between the urban and the rural areas. And the problem that the primary care physician, they don't practice screening. They think that it's not their يعني responsibility. However, in 2007, we focused a lot on intervention on these to enhance the role of the primary care centers. We did a lot of training programs. We set policy regulation KPIs to also evaluate the performance of the primary care. And fortunately, we can see a lot of changes where we have increased the intake of the mammogram, and most of this was by referral from the primary care centers. So now we have better intake or better performance for primary care centers. Another challenges is, of course, that to have a stable network and connectivity, as well as to have BISO for breast cancer screening information system. And this was mandatory when we started. It was all manual, and then we have not really very outstanding or solution. Alhamdulillah, this year we installed a solution from Fuji, and hopefully this will give us a lot of release, as well as support that we have this solution where we can, of course, communicate with all the clinics, and we have our data, we have our dashboard, we can also evaluate the performance of the program. Manpower challenges, the shortage, challenges. This is, I said, as I mentioned, we did a lot of TOT training, workshop, even we do a lot of one-to-one training. Now with the corona, period, we have less, of course, workshop, but inshallah, when we are settled, we will go back to our full capacity. We do usually workshop with very high standard. We for the technologists, for the health educator, for primary care physicians, as well for the radiologists. Of course, at the end, we have financial challenges. Who does not have? Not only now in the corona time, but also before. But however, as I said, we depend a lot on PPP, and we have good communication with private sectors that fund a lot of our activity, as well as fund of the clinics. Now, from these 12 clinics, mobile clinics, we delivered to the regions. 2 of them was also supported by SABIC and Zahra. We have also one mobile clinic was also delivered to Al-Ahsa region in 2018, supported by SABIC also. Other challenges, research important. Still, as I said, we have research going on. However, still we have shortage of the expertise. Expertise is very important to do good research. We want with high quality, high standards, and of course the fund. So key lessons to be learned from these challenges. I got to know that the passion I have and the commitment is not enough. There should be always collaboration with other stakeholders. And this is vital to have an holistic and approach and to improve the, in order to improve the nation of the health of the nation. So stop doing silo and work with others, because this, if you work a silo, this will create resistance to change. And vital also, very vital to improve the, to have a creative way to improve the community intervention, because this is big barrier, the misconception in the community. So very important to have collaboration with strategic partnership like foundations, social foundations usually, who or societies who work for in prevention and in awareness. And very important to have an efficient and stable network, very important. This is the soul of the program. Screening software is essential to monitoring the program. And important to develop a training program for all the manpower and with high good quality. And training, I say it's the key of improve the skill of the existing manpower and also to overcome the shortage. And very important to collaborate with other global training centers. We have good collaboration with others like ACR and other parts. Regulation, very important to set regulation like we did for the risk factors, to reduce risk factor, all to the primary care physicians or to the region now. Every year we send the target number for doing mammogram for each region according to the number or the percentage of the target group between 40 to 65. We set a KPI, we follow this in Hassan system, and this KPI been also followed by the high authority in the Ministry of Health. Continuing, as I said, training and continuous workshop to increase the awareness of the their role in the fight against breast cancer. Also, incentive and appreciation is very important. Don't forget that. Quality, quality, quality is very important, is critical actually to for the success of the program. And there always should be guideline, which should be always followed strictly, and indicators should be set to monitor the performance of the program. Thank you.
Thank you so much, Dr. Fatani. It's a great talk. And because we are running late, I have just one question for you. And we are far away from make compulsory all women above 40 to do a breast screening. So because some country now worldwide, they established the system, it's compulsory for the women to be do scanning after 40. So we are far away in Saudi Arabia?
This is very painful question. It really hurts me because we have a lot of try to do this, but there is always people who tell you this is against human rights. We cannot make it mandate. We cannot do this. We cannot do. Although there is a lot of justification to do it mandatory. I mean, and but there's a lot of people who I don't want to say challenges. There is a lot of obstacles.
Obstacles about this.
Tried, but we will not stop, inshallah. We will continue trying. Inshallah. Why? Because this is for benefit of the ladies. Some ladies, they don't know what's the good for them. Yeah? They think this is okay. The cancer will not come to them. Yeah, this is the problem.
Thank you so much. Thank you so much, Dr. Fatina. And I do apologize for all panelists and participants. Professor, we are too late. We didn't have time.
Yes. Okay, very good. I accept it.
Yes. So now we will go with Dr. Salman Al-Baishan. He working as associate professor in King Saud University. He will give a talk because I do apologize for all panelists and all attendants. We are running late today, is about 20 minutes. So we will finish with Salman, and we will take some time from break for Dr. Bandar because he stay with us for a morning session. Yes, Dr. Salman, go ahead.
Yes, hello, good morning. I'm sharing my screen. It's clear now.
Yes, it is shared, yes.
It's already shared, right?
Yes, 1 second, please. Yes, it's shared now, just enlarge it, yeah. And go ahead.
Yes. Assalamu alaikum, everyone. I'm happy to be part of this fantastic event. I'm lucky to have this presentation after Dr. Fatina presentation and Dr. Jolie, so we can have a holistic approach on the burden of breast cancer incidence in Saudi Arabia. In this presentation, I will talk about the burden of incidence, particularly from 2004 to 2016. We will go briefly on the background and objectives of this presentation, materials and method used, some fantastic results, I believe, and then the discussion and conclusion. As Dr. Jolie said, breast cancer is a global issue. In 2018, millions of women affected of this breast cancer here in Saudi. The incidence is low. However, it's an increasing if we compare it with the other Western countries. For example, in the US, the ASR, the age standardized incidence rate, it's almost 85 compared with 27 here in Saudi Arabia. As I said, the increasing in incidence should be taken seriously and should be analyzed to see where the implementation should be done. So the objective is to explore the incidence in terms of age, stage, and regional perspectives, and then we will see the annual percent change, which means how many incidents per year are happening in each region in Saudi Arabia. So in this talk, when we talk about annual percent change, it hasn't been analyzed previously in Saudi, and this paper now is under review, so hopefully it will be published soon and will be available for everyone. So first, I retrieved the data from Saudi Cancer Registry, which is an open access, publicly available source of data. And then we did a descriptive analysis for the stage, age, and incidence per region. And then we go deeply to analyze the annual percent change using the joint point regression analysis. So let's move forward directly to the results. So if we look to the incidence rates as we see, it's an increasing from 2004 and into 2016, a total of 18,000 cancer cases have been recorded, and the number has increased from almost 783 in 2004 to 2,000 into 2016, almost 3-fold increase in breast cancer. And the age standardized rate also increased in this period. Regionally, as expected, Riyadh, Mecca, and Eastern region have held the most increase. The first reason, as we notice, it's the population density in these regions. In terms of incidence according to age and stage, here's an interesting result. Almost 60% of the breast cancer data have been recorded in women aged 40 to 60. And what we can see in terms of the stage at diagnosis, this is very interesting and I think a good news for all of us. The number of localized breast cancer have increased. or the percentage, and the number of regional breast cancer has decreased, as well as the unknown breast cancer. If we do the analysis of annual percent change for each region, we can see that Asir, Medina, Qasim, Jawf, Riyadh, Mecca, Eastern are significantly different from Azirus. It means that the p-value it's significant. The highest increase was seen in Riyadh and Mecca, followed by Medina. It's interesting to see Medina to be one of the top highest incidents in terms of annual percent change. For example, if we look to Riyadh, it means that 4.5% of increase from 2004 to 2016. There is 4.5% of annual increase in breast cancer incidence. And here is a graph of the joint point regression. We take 4 years between each joint. Okay, for the overall result, there was an increase. It's an expected. The population is increasing, as we know. In Saudi, we are a developing countries. So why Riyadh is one of the highest? In Riyadh, almost 22% of Saudi population live in Riyadh, almost 7 million. So it's an expected to have a higher incidence rate. Another region, Riyadh, Mecca, and I believe Dammam have the largest health center. So it's a big referral. So women, as you can see, women from the peripheral region are referred to Riyadh, Mecca, and Medina. The eastern region, I believe in the previous research, has consistently being one of the highest. In the previous epidemiological data by Professor Ibrahim, it says that one of the reasons it's because the chemical and petroleum industry in the eastern region. In one paper, I think cited in Saudi Medical Journal, researchers have found that there was a possible relationship between the breast cancer and the concentration of nitrogen in the air, particularly in Al Jubail area. And another link between petrochemical industry have been found in the US as well. I believe this is an interesting area of research in the future. Increase, there is a lot of risk factor population, so social economic. We all see the shift in the last 15 to 20 years here in Saudi, particularly after the founding of oil industry. The kingdom witnesses a mass shift in everything. Women have moved from traditional lifestyle to more westernized lifestyle. So do we have all bad news? No, we do have some good news. The good news is that, as I said, in the previous epidemiological data from 2001 to 2008, the percentage of young women diagnosed with breast cancer from 30 to 44, it was 38, and from 45 to 58, it was 31. In this analysis, the percentage of young women decrease and the percentage of women after 40 increase. Researchers believe that breast cancer diagnosed in one young women have an aggressive form and therefore aggressive treatment. The good news that there was a 3-year incremental increase in the median age of diagnosis in breast cancer. In the year of 2004, I think until 2009, the median age was 47, and in 2015 and 16, it was 50, which is a good news. If we compare it with the US, for example, the median age was 60. If we keep this movement, I think at some point in the future, the gap between the westernized profile of breast cancer and our gap and our profile here will be, I think, lessened. Another good news, as we saw in the previous graph, it's the increase in the number of localized breast cancer by 17% in this 13 years. In this 13 years period, and also the reduction in the number of regional cases. This is, as Dr. Fatima said, early detection is the key. If we catch the breast cancer early, the prognosis of women will be fantastic. I think one of the important aspects of increasing localized breast cancer is the early detection program, as mentioned by Dr. Fatima. And we are awaiting for the publication for that breast cancer early detection program to link all these thoughts together. The main limitation is that the Saudi Cancer Registry doesn't provide the age for each region, so we didn't include the annual percent change per age and per year. In conclusion, the incidence is increasing. However, there is a good news in terms of the median age at diagnosis, in terms of the cases diagnosed at early stages. I believe we need to do a holistic approach in terms of regional study and the national epidemiological risk factor as well. Now, based on my experience, we are lacking for multidisciplinary research team, and I hope in the future and this meeting might have some good collaborations. For more information, we did a review in 2017 about breast cancer epidemiology in the Gulf Cooperation countries, and because people are look same in the GCC, so we can apply each risk factor to all of the GCC countries. And here is the references, and please feel free if you have any question.
Thank you so much, Dr. Salman. Actually, the chair of this session is Dr. Prof. Abdul Man'am from Prince Sultan University. So, Prof. Abdul Man'am, are you with us? Okay, so thank you so much for this burden. So my question for you, Dr. Salman, how about the increases cases in Saudi Arabia? Do you feel expectation for 5 or 10 years it will be increase or decrease from your background and study?
I believe globally the breast cancer increasing. We need to look to the aspect of the cases diagnosed at later stage, and in every country, not only here in Saudi, breast cancer is increasing. If we compare Saudi, for example, to Australia, in Australia the incidence it's almost compared with Saudi. However, the incidence, it's not the key. The key it's when we catch the disease.
The disease. Okay. So the stages of the disease. Thank you so much, Dr. Salman. And now we'll go to the last speaker in the morning session, consultant Bandar Al-Harthi. Bandar Al-Harthi is a consultant surgeon of breast and endocrine at King Fahd Medical City. He is expert and he has long experience in surgery, and also he's working associated professor of surgery at King Saud bin Abdulaziz University for Health Science in Riyadh. Thank you so much, Dr. Bandar, and we are so sorry to late for you. Yeah, go ahead.
Yeah, I would like first to share my.
Yes.
Is it okay?
Yes, it's okay.
Yeah. At the beginning, I would like to thank the organizing committee for their invitation to be as a speaker for the first conferences of breast cancer management and challenges. I am honored to participate as a speaker and to introduce the surgical part, the surgical advancement part. To understand, at the beginning, to understand the current status of surgical intervention for breast cancer, it might be a good idea to go to the history of breast surgical technique, the breakthrough and innovation progress over times, to understand the current challenges that we're facing from surgical point of view to take of caring of patients with breast cancer. First, I would like to confirm that I don't have any conflict of interest to declare for this presentation. The early reported cases of breast cancer was founded in an Egyptian papyrus, which is named by the archaeologist who discovered and translated in 1862. His name is Edwin Smith. It has been thought that this papyrus is written between 3,000 to 1,500 years before the Common Era. What of interest for this was including 48 cases, descriptive of cases of trauma and intervention for tumor at that time. What of interest is for us is the case number 45, where a description of swelling at the breast described on this document, but there is no intervention documented. Hippocrates, later on the father of medicine, described a breast tumor again, which is associated with blood enable discharge, but again, no intervention was suggested as a treatment. Leonid, perhaps the first breast oncologist surgeon, advocate for an alternating incision and cautery and complete removal of the tumor if it can be possible at the first century. Galen, a Greek physician who distinguished the difference between venous and arterial blood, he did many dissection for animals at his time, and he suggests a similarity between the anatomy of, he was actually the first one who suggests a similarity between the anatomy of an animals and human. He suggests at that time that en-bloc removal of breast swelling and its crepe-like is the only hope. He described this and the therapeutic effect. His main concern was the hemorrhagic potential associated with this intervention. Razi, an Arabic doctor, recommended excision and cautery only if the tumor could be removed entirely or otherwise to leave it alone. Advancement in medicine and surgery there is no advancement until the 16th century, when we start to have the breast printing technology, which fastening the dissemination of information between scientists in the world. Andreas Vizalis, he published the first comprehensive human anatomy textbook, De Humani Corporis Fabrica Libri Septem. He argued against cautery and favoring of ligatures suggested by Gren earlier to maintain hemostasis. Ambrose Barry was the first to know the coincident between swelling of the axillary gland and the advancement of the breast tumor. Servetus, in the meanwhile, who was first to advocate removing the axillary lymph node in addition to the breast tumor. William Fabry, the father of a German surgeon, devised an instrument to fastening the mastectomy at his era. Shortly after that, after 1 year, Jean Petit recommended breast removal with the pectoralis muscle and the axillary lymph node. The advancement from surgical point from surgery was slow after this period due to many reasons. The unavailability of the reconstruction when we are removing the breast and leave a disfiguring wound, the mortality associated with septicemia, because most of those procedures is done under no aseptic technique, plus the mortality which was high and continued to be high, and the paucity of the skills to do this kind of procedure. In the 19th centuries, breakthrough happened in the management of breast cancer. This could be related to the performance or the discovery of general anesthesia. The first mastectomy done by a Japanese surgeon, Sishu Hanoka, in the early 19th century. William Morton demonstrated the use of ether shortly after. Joseph Lister described the antiseptic technique in the same era. Despite this innovation, the confusion of breast oncological surgery continued and this mainly related to the disfiguring intervention and leaving of those patients after the intervention. In early 20th century, we noticed, especially in United States, that it was characterized by individual surgeons advocating for their specific intervention. What of interest to us at this stage is the procedure described by William Halsted. He first advocated what we know later as a radical mastectomy through removing the whole breast, removing the pectoralis major, also to do the axillary dissection, in addition to the removing of the fascia of the anterior abdominal wall, which reaching to the lower fold of the breast. This intervention considered very aggressive. The bleeding is very high. Again, this was not matched with his peer in the same era. Although that Dr. Halsted document maintained or mentioning that there is a 7% mortality rate associated with his intervention compared with high and the other procedure. Jerome Orban and Owen Wengenstein advocate shortly after what is even more aggressive intervention by doing what was called as a supraradical mastectomy. Not only, in addition to what Halsted advocate, they are also suggesting removal of the internal mammary lymph node and doing a supraclavicular dissection of the lymph node. The more aggressive surgical intervention showed no benefit, honestly, from the survival point of view. This led to the belief that to fight against this disease, we need the medical advancement rather than surgical advancement intervention. In early 20th century, a Russian physicist, Goldberg, successfully showed a use of radiation to treat cancer treatment. It is not surprisingly that this use after modified radical mastectomy shortly after by Mac in Edinburgh. In the meantime, Batey and Dyson from the Middlesex Hospital in London advocate for less aggressive surgical intervention by doing what was labeled later on by modified radical mastectomy, by removing the breast and the fascia and doing the axillary dissection alone. Subsequent studies strikingly showed a similar outcome regardless of the mastectomy type, and this led to the idea that we might rethink of the next stage, which is, can we do a breast conservative intervention and improve the survival of the patient? Breast conservative surgery means that we remove the tumor with a rim of normal tissue surrounding rather than removing the whole breast, in a hope that we maintain the breast and minimize the burden or increase the quality of life for those women, especially when at that time also we don't have the privilege of doing reconstruction. By the 70s, advancement in cancer biology, advancement in systemic therapy with a widespread of mammogram, which allowed an early detection, have led to this to become a reality and start to think of doing a breast conservative surgery rather than removing the whole breast. Many trials in the 90s, like the B4 trials and B6 trials, Milan trials, and other randomized studies, which was done worldwide, showed us with a significant follow-up of 15 to 25 years, successfully proved to us the equivalent survival between mastectomy and BCT surgery for stage 1 and 2 breast cancer, which were the targeted patient population for this intervention at that time. BCT raised many issues. This includes the issue of multicentricity for breast cancer and what we mean by targeted safe margin. What is the safe margin that we are aiming for, and whom should go for the BCT, and the reliability of a sentinel lymph node dissection technique. Regarding the multicentricity of breast cancer, many incidents showed a variation between what we call multicentricity in breast cancer, between 9 and 75%. And this could be related to the definition used, different definition used, the different slicing technique, and the pathological examination. Holland in 1985 provide detailed description of the extent and distribution of cancer in breast with an apparent, which looks apparently as a localized tumor. And he found an interesting conclusion that 41% of the patient have a residual cancer, which is 2 centimeters far away from the referred tumor. This increased to the dilemma of what is best for our patient. However, we thought that radiotherapy, which was introduced as a tool to help us against the war of breast cancer, against breast cancer, showed the effectiveness in controlling the majority of those what's supposed to be an occult foci away from the referred tumor site. This proven to Gaig and Veronesi from Milano Group showed that the risk by adding the radiotherapy is 0.63 per 100 treated patient in the same site, compared with 0.66% for the contralateral site. This is really a very important information. Also, this led us to think that we need to have a lifelong follow-up for those patients who have selected to go through the BCT technique. The Joint Committee for Radiotherapy experience in 2000 demonstrate an 8 years crude recurrence rate of 7% in almost around 300 patients with a negative ink margin, which was excised after the addition of a 60-gray treatment post-operatively for the tumor bed, compared with a higher rate of 18% in patients with a positive margin. This emphasized the importance of having a negative margin if we are looking for a less local recurrence in those patients. And it was very clear that there is many other factors need to be considered, like the patient age and extensive of epithelial component. The BCT patient selection is now another issue because we notice now it can be offered, especially for stage 1 and 2 breast cancer, but whom will have higher rate of local recurrence is the questions. But many studies showed a risk factor that can lead to the treatment failure could be related to a patient, from patient side to the tumor character or the treatment which is delivered. Regarding the patient risk factor, we noticed that many studies showed that the younger patients, they are having more local recurrence than older patients after BCT, and this could be related to the estrogen. Most of the claim was to the estrogen exposure during an early age, or the women early age. Inherited susceptibility is clear. Those who have a BRCA1 and BRCA2 are more prone to have a failure if they could select a BCT, because we know those inherited gene is associated with high recurrences, high also multicentricity, and associated with other tumor away from the breast. Tumor risk factor could be related to the aggressiveness of the disease from the beginning and to the extent of the margin which is resected. The more aggressive, the more likely to have a higher local recurrence. The positive margin have a more recurrence after BCT. This is clear and obvious. Treatment factor, the extent of resection is mainly because, when we are talking about the volume of a normal tissue associated with the tumor when we are doing the resection. Many studies showed that if we do a BCT and we try to minimize the volume of the breast, we have a higher local recurrence than when we are doing a quadrectomy, which is more more aggressive and more disfiguring for the breast. The use of post and adjuvant systemic therapy showed a very effective in minimizing the local recurrence after BCT. Therefore, we can see here that the absolute contraindication for BCT list became less and less. Women who have a primary tumor in separate quadrant are not prone to select this intervention, including a history of previous therapeutic radiation. Pregnancy, especially in early trimester, also a factor, and the persistent positive margin after reasonable surgical attempts is again against the choice of BCT for women with breast cancer. Relative contraindication, now the history of collagen vascular disease now became, in spite of being an absolute before, now it became a relative contraindication. Many studies showed the safety of delivering this kind of intervention for those group of patients. We have a multiple gross tumor in the same quadrant. Again, if we're able to excise it at once and preserve the breast, can be considered as a relative contraindication rather than absolute contraindication. The ratio between the tumor and breast is important. You don't want to choose a BCT if you want to preserve the cosmetic and you ended by disfigured breast. This should be avoided. Therefore, tumor size is very important. Initially, I remember that during my training, we considered a tumor less than 4 centimeters a candidate for BCT. Nowadays, many surgeons, they don't have, or they don't consider that the initial tumor size, and rather than that, compare or do the ratio between the tumor and the breast size before selecting the BCT for stage 1 and stage 2 breast cancer patient. Sentinel lymph node biopsy, the concept start to raise in the early of 20th century. The sentinel lymph node concept is based on hypothesis that there is an afferent lymphatic channels which is draining the primary tumor. This hypothesis was tested on animals models and validated in clinical setting in melanoma patient in 1992, validated by Turner's in 1997 in a breast cancer patient. We know now, currently we have a large body of evidence suggesting that the sentinel lymph node is an accurate staging procedure, reliable with a low skip metastatic rate. What we mean by sentinel lymph nodes, sentinel lymph node is based on that when we have a non-palpable axillary lymph node, which is which we know from our anatomy that is draining 97% of the breast. If we don't have any palpable axillary lymph node, we can use this technique to save those patients from doing the formal axillary dissection and avoid the complication which could be unnecessarily after the axillary dissection. This technique is done by either doing radioactive, to take radioactive substances and inject it around the nipple, see where is and map the draining first group of lymph nodes to the axilla, try to localize it by the gamma probe intraoperatively and do a small incision, take this lymph nodes for histopathological examination, and from the result you can decide either to go for the former axillary dissection or preserving the patient from this intervention. The other technique we are using is by doing a methylene blue, taking the methylene blue and inject it around the nipple, and with the help of visualized the blue shining of the lymph node, you will be able to localize it in the axilla and take it for pathological examination. This technique, is very common now. It is used in almost 99% of breast cancer centers worldwide, and at King Fahd Medical City. Initially, we were started with the methylene injection because we did not establish yet our radioactive iodine method in the first 2 years, with a sensitivity and specificity of 85% during the first 2 years. When we add the radioactive nanocolloid technique, we were able to reach to 95 and 97% successful rate of localizing the lymph node and take it for pathological examination. After that, it might be an important now to go to what is the current argumental issue that we are facing on the field of surgical intervention for treatment of breast cancer. One of the most important to us, especially at the Kingdom, is the efficacy of downstaging treatment modality. Maybe, as mentioned by my previous colleagues, Professor Tahan and Professor Suleiman, the efficacy, most of our cases in the Kingdom, 70 to 75% of our cases are presenting in later stage of breast cancer and more aggressive disease, clinical presentation. Therefore, this topic of downstaging treatment is very important. How we are doing this? There is two ways. The commonest way is to see to give what we call a neoadjuvant chemotherapy and to see the response of the tumor, and from there decide, or after commencing this treatment, to do the surgical later on. The second way is by giving on hormonal, and this is in minority of cases, which is having a high, whom are reluctant to go to the chemotherapy or at high risk of having the chemotherapy preoperatively. The efficacy of this intervention is again not well established yet. There is many ongoing study worldwide. We still think that it is one of the tools that became more clear for the coming in the forehead in the forthcoming times. The other topic, which is a controversial also, is the intervention, surgical intervention for metastatic breast cancer. Here we can divide it to two groups, the oligometastasis and the multimetastasis. For oligometastasis, although many ongoing studies are going on, the recruitment number of patients is low, but it have been shows some benefit of doing the removal of the tumor from the breast with a concomitant removal of the site of the an oligocyte of metastasis, either to the lung or to the liver. Still, we are far away from taking any conclusion from this studies. The idea in multi-metastasis is much dismal, and therefore I don't think that we will have any progress on this unless we clarify the oligometastatic breast cancer response. So the continued advancement in a systemic therapy have led to an improvement in survival trend, and this increased the focus of quality of life and rethinking of improving the aesthetic outcome via reconstruction. Therefore, the idea came nowadays over the coming years of the concept of doing an oncoplastic single-stage breast surgery to provide the patient with the best cosmetic result in one stage, rather than make the patient suffering from the consequences of disfiguring for many years before considering reconstruction. This is again, it is coming very shortly, and we are working in collaboration with our plastic section at King Fahd Medical City to establish this kind of oncoplastic reconstruction as one stage. And we have many patients so far with promising results. So finally, breast cancer treatment is composed of a wide assumption of imaging modalities, chemotherapy, radiotherapy, and targeted systemic therapy, in addition to the surgical intervention. And we are also nowadays involving our plastic group and colleagues for the best option to our patient. The mortality rate we know is decreasing worldwide by 36% from 1989 to 2012. And we hope that we will able to make the burden of this disease much less on our patient in near future. Thank you.
Thank you so much, Consultant Bender. It's a great talk. And the chair of this session actually Prof. Bushra. So, Prof. Bushra, if you have a question and discussion, please.
Hello, thank you, Professor Harthi. We have fought very much against your time and your engagements to have you with us. I think you have contributed very positively to this conference, and thank you very much for your participation. It is most appreciated. I would like to have comments on going into breast surgery from lumpectomy, partial mastectomy, total mastectomy, total radical mastectomy. Is it a type of school of surgery, different schools of surgery, or is it a need? The second small question is the plastic and reconstruction surgery?
Prof. Bushra, one by one, please.
It is just completing the question.
Okay. Yeah, sure.
I'm very sorry. Do you think that the plastic and reconstruction surgeries, is it a medical need, surgical need, or medical need, or is it the patient requirements, sort of psychological rehabilitation? Thank you.
Thank you, Professor, for these questions. Really, I appreciate it. Regarding your first part of the questions, I think it is not, the issue with the breast cancer management is a multidisciplinary. It became much more clear for every one of us that it is not a one-man show. It should be a multidisciplinary decision. Yes. Each patient should be treated individually. Many factors are involving our treatment selection. I think it is an individual decision, and this is not only in our institution, but it is worldwide. It is the best for our patient, and I think we are in the common track regarding this. It is not related to which medical city is preferring, and most of the consensus now worldwide is going with a multidisciplinary decision rather than a one-man decision. Regarding your second part, I believe that reconstruction should be part of the treatment, because this will minimize the burden of the psychological burden of the breast cancer in our patient. We see it actually in our patients, and their acceptance of the treatment is much better appreciated after if you considering reconstruction at the first stage. Unfortunately, as I mentioned here before, most of our patients, they are actually presenting in a late stage, and this raised the issue of the safety of doing reconstruction for those patients. You don't want to do a reconstruction and after radiotherapy you have a disfigured also outcome.
Yes. Sure. Thank you very much, Professor.
Yes.
Thank you, Professor Harisi.
Thank you so much, Prof. But I have a question for you, Prof. Al-Harthi. So the same question for Prof. Alfonso. So do you have a cycle for assessment in your department before you start the surgery for the patient? Where the patient should start during this stage? Should you go to the oncologist or go to the surgery or go to the diagnostic? Yes. Thanks.
No, we are having a multidisciplinary meeting for every single patient came with breast cancer. The treatment decision is not a decision of one-man show. It's a decision of a multidisciplinary. We need to discuss the patient throughoutly in the presence of every specialty. We have a tumor board. We confirm or we document our treatment plan in our form, and we rediscuss this option with our patient actually. And I think this is the best way of how to help our patients with breast cancer. And I think this should be actually the standard of care in everywhere.
Oh, okay. So should you concentrate to the screening area, screening diagnostic area for the cancer progress before go to the surgery? Do you think should we go to this area to make the less progress in surgery? Because you deal with these cases, difficult cases. So should we go where we should go? Go to the education, go to the screening tool, where we should go?
I think what we are seeing now, we are seeing much more high rate of early detection in patients who came to our clinic, and this is thankful for the national program of early detection. We see now more and more patients of presenting in early stage, and this is really give us a good opportunity to select the best for them, because we can discuss a multimodality of intervention for them rather than just doing. And I remember 10 years ago, toilet mastectomy was a common. I was doing a toilet mastectomy, which is a mastectomy done for palliation only, for those who have presented with an ugly ulceration. Nowadays, we are having less and less patients, and I think there is an improvement. We can see as an end user of the referred hospital for breast cancer that we see the advancement and the advantage of having the early detection program.
Okay. Is there any question or a comment before we end the session? Thank you so much.
You are welcome.
Thank you very much.
Thank you for your time. We are so glad and appreciate you coming today with us. Thank you so much. Thanks a lot. Thanks. Now we have a break, so we are so sorry we delay a little bit to take the time from break because we have ceremony in the morning. So thank you so much. We take the break about 30 minutes. Then we'll come at 1 o'clock with with the consultant. Noor Naimi, so she will start at 1 o'clock. So thank you so much for you. It's a break time now. Thanks. And now we have a poster presentation, so it will be shown in the slide, and we have a panel they will assess and estimate these poster. So time by time, it will be show different poster coming to the conference. Thank you so much.
After prayer time, sir.
It will show now. We have another committee. They will show the poster. They will assess and evaluate a poster presentation. So not us. So we'll come at 1 o'clock. Thank you so much.
Thank you very much, Mr. Chairman. Thank you very much.
السلام عليكم دكتورة نور.
عليكم السلام ورحمة الله وبركاته.
الله يعطيك العافية. دقيقة إن شاء الله نبدأ بس يدخل زملاء. بسم الله والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا ونبينا محمد وعلى آله وصحبه أجمعين. Thank you so much. We are coming back now. The next presentation it will be by consultant Noor Naimi. Noor Naimi is a consultant of breast imaging and women imaging at King Fahad Specialist Hospital at Dammam. She has medical imaging department deputy chair at King Fahad Specialist Hospital. Also, she is the director of male jabber in early tumor detection. And please join me to welcome her. And the title of her presentation, it will be Newly Diagnosed Breast Cancer, the role of mammogram, ultrasound, MRI, and contrast imaging in evaluation of disease extent. Thank you so much, Dr. Noor, to coming with us today, and you can share and start your presentation now.
Assalamu alaikum, everybody. Thank you for your invitation, Dr. Green. Thank you for the esteemed speakers allowing me to present some of our work in the Eastern Province and to share the knowledge and have the chance to hear from elite people. As you know that just to bring everybody on the same track, we started the work, maybe just to be on the same page. We started the talk about screening. We talk about statistics. We heard from Dr. Salman Al-Baishan, a great talk about statistics. We heard from our leader in the screening program, the early detection, Dr. Fatima Tahan, about their great effort in establishing a network of screening for detecting the disease to do the radical changes in patient lives. Now, we heard from Professor Alfonso and Dr. Bender a great talk about lymphedema and surgical interventional procedure. However, we need to go back into our patient. If we detect the cancer, which is a great job, through a screening program, then what's next? There is global needs. It's not in our country, it's a global need. We need to have a fast access to the service, fast access to the patient, to the service. We need to deliver standard of care and not to do any harm for the patient. I meant to bring this slide to show the way we tailored our pathway in the Eastern Province and to secure that the patient will have a pleasant at least not a misery journey from the time she detected at the screening center till she turned to be positive, if there is a chance to be a positive, and the service that can be provided. And this is, if you follow the arrows, you can see that there is many people engaged in this pathway. They are the army, to make sure that the patient will not fall in crack. So if the patient detected at the screening center, we know that she's within a certain time frame, she will be referred to the secondary hospital to be served. And we know when she will get her appointment at the surgical service, mainly surgical. The biopsy, if she turned positive, how long she will take to be served at the tertiary hospital. My objectives in my presentation is to go through the standards and guidelines in the assessment if the patient discovered to be cancer in a screening setting, to evaluate the standards assessment tools, and to go through the new trends and impact on management. There is a global cancer statistics showing that the breast cancer is the most frequently diagnosed cancer and the leading cause of cancer death among females. Breast cancer is now also the leading cause of cancer death among females in economically developing countries. Most breast cancer are diagnosed as a result of abnormal mammogram, but not all mammographically findings represent cancer. This is one of the reasons why one of the reason, not the major reason, why cancer present lately. Women who have an abnormal screening mammogram often need further diagnostic evaluation with additional imaging. Additionally, not all cancers are detectable on mammogram. A clinically suspicious masses should be biopsied regardless of the imaging finding, as approximately 15% of such lesions can be mammographically occurred. Now let's go through the first objective, which is the standards and guidelines in assessment. Now we know there is, globally, there are many tools used to image the patient. I'm talking about the imaging part here. There is diagnostic mammogram, ultrasound, MRI, chest CT, abdominal pelvic CT, and MRI. I've seen some centers, they assess disease extension as initial investigation using PET, and the new trend, the contrast enhanced mammography. So which one we should start with? Why I should choose one over another? Maybe the patient is not comfortable with mammogram. Shall I skip mammogram and go for ultrasound? Maybe the patient is willing to pay. Shall I go for MRI first? What is controlling our practice? There are many bodies or institutions that they are releasing guidelines on annual basis and recommendation. The guidelines are tested and proven to be the best for the patient, depending on the outcome. For instance, we have the American Society of Clinical Oncology. We have the NCCN guidelines, the National Comprehensive Cancer Network. We have the European Society of Medical Oncology, and of course, the beloved for radiologists, the American College of Radiology. These four main bodies, institutions or networks, are the main source of guidelines, at least in our part of the world. They are the source of the guidelines based on, as I stated, based on testing, experience, studies, and exposure to many different settings, after which the outcome presented at the end of the year as guidelines and recommendation. I'll give you an example. This is a screenshot from the NCCN guidelines. By the way, the NCCN guidelines can be even downloaded as an app in our mobiles. For instance, this is a case of suspected DCIS, ductal carcinoma in situ. Now, it's not up to us what to do. as a management team. No, there are guidelines. If the patient is found to have a ductal carcinoma in situ, there is no lymph node N0, M0, there is no evidence of distant metastasis, then the workup will be as follows: with physical examination and history, diagnostic bilateral mammogram, okay? If there is any need for breast MRI, then it is as indicated. And as indicated, this is a long history or long list of things. And there is a recommended primary treatment protocol as well. Another example is when the patient presented with a sized tumor between 0 and 3 tumor size, N1 palpable lymph node. This is a clinical assessment, by the way, not radiological. So initial presentation will be to the surgical clinic, and the surgeon will see that the patient tumor size between T0 to T3, lymph node is palpable, and there is no clinical evidence of distant metastasis. Or when it is between 2, 1, and 3, no palpable lymph node, or possibly 1, and no evidence of distant metastasis. So the workup will be, the imaging workup will be diagnostic bilateral mammogram, ultrasound, and MRI optional, with a special consideration for mammographically occult tumor. Additionally, if patient give history of bone symptoms like back pain or alkaline phosphatase was high, then we'll do bone scan or PET-CT. Yeah, this is a screenshot from the ACR, the American College of Radiology. It shows all the guidelines to what is the appropriate exam we need to do for each symptoms or stage. Another influencing factor that guide us in selecting our modality to be used to assess the disease extent in our case and our patient is the appropriateness of the modality. And this is what is I just mentioned by the ACR. So the ACR see how appropriate to use each modality. I am a radiologist, and there is a patient referred to me to do MRI because they want to assess the disease extent for 2 centimeter nodule, palpated and biopsied and proven to be cancer. So is MRI a diagnostic tool? It takes, it was given by ACR, the American College of Radiology, 1, okay, in terms of rating. And in terms of relative radiation level, it is 0. So it's radiation-wise, it's appropriate, but diagnostic-wise, it's not the appropriate tool. What's appropriate tool in this setting is the diagnostic mammogram, although it has a radiation exposure level, but it is the benefit is overweight the harm. Likewise, the tomosynthesis and the diagnostic ultrasound. Another example of utilizing the appropriateness criteria when we want to order a request for a patient. If a patient came and we want to rule out metastasis, you can see that the PET is not the first choice. It has a low rate of appropriateness and a high rate of radiation. Okay, so we saw together that the guidelines always recommend diagnostic bilateral mammogram. So what's the difference between diagnostic bilateral mammogram and the screening? Just a quick talk that the screening is when you do, you just take the conventional views for a patient, and she's for a lady, and she's asymptomatic. That can be done on mall, on a clinic, or anywhere where the setup is appropriate. But in diagnostic setting, it's more than this, and it required the attendance of a radiologist to assess each image you are taking. We can use diagnostic mammogram in disease characterization, either through 3D, the tomo, or additional views or magnification, or a compression for a certain lesions that we want to confirm that they are not an additional focus of the disease. Mammogram as well can be used to exclude or include multiplicity and multicentricity. Are we talking about a lesion, a single focus of the disease, or multiple focus within the same quadrant, or multiple foci within multiple quadrants? Again, a diagnostic mammogram can be used to characterize microcalcification that has been seen on screening mammogram, but it's not informative technique. Also, diagnostic mammogram used to as a guidance tool in interventional procedure. I'll give you some examples. This is a case. A patient has a dense breast, extremely dense breast actually, and we can all appreciate the microcalcification extended for almost 9 centimeters posterior to the nipple. The other thing that's seen is the nodule seen posterior to the nipple, projecting over the pectoralis muscle, along with dense lymph node. So we have a good information extracted from the routine basic views. Yet, we don't know if the disease is ended here, but we know that there is microcalcification. Another way to assess the disease, if we see a disease, this is a lady with fat background, so the disease is more clear than the previous case. We can appreciate as well the thickness in the nipple areolar complex, the distortion in the surrounding parenchyma. However, with tomo, we could appreciate more satellite nodules inferior to the index mass. So this is another way of assessing the disease extent. This is an example of a compression with magnification. We compress the nodule, which was seen in the routine setup. You could appreciate the spicules, more characterization of the feature, along with the associated cluster of microcalcification, which is suspicious by feature. Okay. These images show how can mammogram be of benefit in interventional procedure. This is an example of stereotactic guided biopsy. When we see microcalcification, which cannot be seen in other modalities, we go and take biopsy under mammogram guidance. And this is the sample X-ray, proving that there is microcalcification in the sample. The image here is a guide wire inserted to guide the surgeon. They are inserted through 3 different sites of surgery. These are nodules have been biopsied and clip marker placed at the site of the biopsy. And then for the conservative surgery, we insert wires under the guidance of mammogram through these clip markers to guide the surgeon for conservative lumpectomy. Okay, now let's move to the next favorite modality, which is the diagnostic ultrasound. Ultrasound is an important, essential tool and a cornerstone in diagnostic setup. It assesses the size, it assesses the vascularity, will map out for us the interventional approach. It will help us and decide about the presence of multifocal disease or multicentric. It will assess the axilla as well. And it's an important tool in interventional procedure for biopsy, whether it's for the breast or the axilla, for inserting the clip marker and for wire localization. I'll give you some example. Remember our case. We stated that the patient has microcalcification extending for almost 9 centimeters posterior to the nipple. We have this nodule, which is partially visualized and projecting over the axillary, over the pectoralis muscle. And we have the dense lymph node on the right axilla. Okay, now this is a lesion seen under ultrasound. It was labeled 5 because there are more lesions discovered at 5 o'clock as well. And the ultrasound delineate what was seen at the axilla as a dense node, as a diseased lymph node. Losing its fatty hilum, the entire lymph node is totally replaced by the disease. There is no differentiation between the cortex and the hilum to call it partially involved. And overall, generally, it is hypoechoic, all the feature of malignancy in the axilla. Under ultrasound guidance, biopsy was taken from this lymph node, and it proves that it is diseased lymph node. So ultrasound is a good tool for guidance for biopsy. This is the needle we insert to take the biopsy, and the image said pass 1 because you need to record, to document all the passes through your procedure. Also, ultrasound is used to put wire. This is a wire inserted on the day of the surgery. This is a lesion which have been biopsied. You can appreciate this ring. It's a clip marker placed in the lesion before. Patient went for neoadjuvant chemotherapy. The size of the tumor reduced. That's why we see the clip on the periphery. Usually we drop it at the center. So when it is shrunk, sometimes we see that because of the necrosis, the clip marker moved to sides. So we insert, on the day of the surgery, we insert the wire. There is supposed to be a hook, but it's not included in the image. The hook will be placed beyond the lesion border, or we can insert the wire just posterior to it. And again, we can advance it for a couple of centimeters beyond the border of the lesion, and we fix it to the skin, label it as well, label the tip, then we send it to OR on the same day. But let's move to MRI, the favorite topic or the favorite modality for surgeon, I would call it. And in private, with all the due respect for private whom are working with the standards and guidelines. This is a screenshot from the ACR, the practice parameter for the performance of contrast enhanced MRI for breast. Now, part of the indication is to assess the disease extent, okay? And this is inclusive to DCIS, the ductal carcinoma in situ, the assessment of the invasion deep to fascia, and post-chemotherapy, when patient has a baseline MRI, then given neoadjuvant chemotherapy to assess the overall reduction in the size, and post-lumpectomy. In post-lumpectomy, sometimes you just end up by having patients who have been managed in different hospital, and the mass is taken out by lumpectomy with no excising the margin to secure negative borders. So post-lumpectomy to assess if there is any residual disease. Okay, so in assessing disease extension, the main reason we do MRI is to assess the disease, how far is the disease extending within the breast, to check for chest wall invasion beyond the fascia, if there is any multifocal disease, multicentricity, bilaterality, and axilla involvement. And the MRI can be used as well as a guidance tool for interventional procedure. This is an example of a disease which have been seen on ultrasound. It's clear, it's a large lesion, yet the relation of the lesion to the chest wall cannot be assured or detected on ultrasound. That's why MRI was done, and you can see that there is a linear extension of the tumor toward the chest wall, although it's a small one. Multifocal disease, yeah. We saw a lesion on ultrasound and mammogram in a diagnostic setting, and it was labeled as single focus. But because of the disease, because of the breast nature, as you can see, the breast here is extremely dense. To a lesser extent, we can call it heterogeneously dense. Other focus of disease cannot be excluded. So when MRI done, we see the lesion is deeply seated. It's sitting on the pectoralis muscle, and there are more than 4 satellite nodules of the disease. So it's a multifocal disease. This is a case I had a few weeks back. She's a young patient, presented, unfortunately, because she's young, she's not a candidate for our screening program. However, she presented to us as a mass. This is the mass where she felt. She went for consultation, biopsy taken, proven to be lobular cancer. Now, in lobular cancer, we know it comes with a great percentage of multifocal disease and multicentric, along with bilateral component as well. So when we did the MRI, the disease is not only the palpable part, it's beyond this. It's a multicentric disease. It extends in more than one quadrant. It crossed, this is the nipple, it crossed the nipple. It's just anterior to the chest wall. Unfortunately, the other breast was having another focus of the disease. So this is a multicentric bilateral lobular carcinoma, invasive lobular carcinoma. MRI as well used as a diagnostic tool, plus guidance for interventional procedure in lesions that cannot be seen in other modalities. Now let's move for the contrast enhanced media, contrast enhanced mammogram, the indication, and why we are using it and not using it. There are a lot of published research talking about the contrast enhanced and their analysis and comparing its benefit versus the MRI utilization. So it is performed by using dual energy technique that capitalized on the inherent difference in X-ray attenuation of breast tissue and iodine to highlight areas of contrast agent uptake within the breast that may associate with breast cancer. The technique is that we, with the breast out of compression, we inject the non-ionic low osmolar iodinated contrast, IV injection, of course, and it has to be a power injector as a standard dose of 1.5 ml per kg and a rate of 3 ml per second. 2 minutes after the starting of the injection, the breast placed into the compression paddle in the compression platform, and pairs of low energy and high energy images are obtained in a standard CC and MLO. Recombining images are found by the subtraction of a low energy images from a high energy images, which cancels signals from background breast tissue and highlight areas of iodine uptake. This is just an algorithm showing that at 0 minutes, we put the patient, and of course, there are certain things need to be taken consideration that the patient is not radiation-wise and contrast-wise. So at 0 minutes, we inject the patient through an automated injector. We give 1.5 ml per kg at 3 ml per second rate. Then we pause for 2 minutes. Then we place the site of concern. If we are having a mass on the right side, we'll start with the right side with CC view. Then the normal side CC, then the concern side MLO, then the normal side MLO. Then if there is any additional views we need to take, we should plan it, or even if needed through the procedure, we can proceed to it. This is an example of low energy image, high energy image, then the subtracted images through recombining them. Of course, like any other modality, it has its own limitation. The background enhancement is one of the limitations. This is an example of background enhancement. Sometimes we don't have a background enhancement. Sometimes it's mild. Sometimes it's moderate. And other times it is extensive or marked background enhancement, which can interfere with the result. I'll give some examples, quick examples. This is an obvious disease with speculation, pulling of the adjacent tissue. And because of the background, we have a heterogeneously background, we needed to assess the disease extension further. We have either to go through the MRI or to try the contrast-enhanced mammogram. On contrast-enhanced mammogram, we have an index mass and multiple satellite nodules. So the actual size of the tumor changed dramatically. This is another example. We have an area which is seen by ultrasound as cyst, yet, sorry, not cyst, it's a post-surgical changes. And this is a residual seroma from a patient known to have the disease. On follow-up, and again, because of the dense background, the procedure changed or went further to contrast-enhanced mammogram. Two disease foci, focus, seen beyond the seroma area. In assessing the ductal carcinoma in situ, one of the indications of contrast-enhanced mammogram, we can appreciate that these are multiple areas of increased parenchymal density, focus of the area where calcification is seen. However, how far is the disease is extended is confirmed by the contrast-enhanced mammogram. This is an area seen under mammogram as a focus of parenchymal alignment distortion. It is distortion and taking the contrast, however, another focus seen by the contrast. An example of where contrast-enhanced mammogram can be of benefit is when you see breasts that have been, that has an interventional procedure. This is a marker indicating the site of the surgery. Just anterior to it, we can see changes in the alignment, which can be a disease recurrence or can be just a post-surgical changes. On contrast-enhanced mammogram, we appreciate no uptake by contrast, confirming that this is post-surgical changes, benign changes. Currently, there is no contrast-enhanced mammogram specific breast imaging reporting data. You know that the American College of Radiology standards of reporting is by using the BI-RADS lexicon. However, for contrast, there is no BI-RADS system yet. Yet, what's in the articles I've read that for low energy images and they use the BI-RADS, the mammogram BI-RADS, while for the high energy images they use the MRI BI-RADS. Contrast enhanced is associated with a level of radiation exposure. There are some studies have shown that the contrast enhanced mammogram examination exposed the patient to radiation dose between 20 and 80% higher than that of standards. A recent study demonstrated that the dose of radiation almost within the same that used for a routine mammographic exam. Multiple studies have evaluated whether contrast enhanced mammogram can be used for the indication by comparing it with conventional mammogram and ultrasound or MRI. When compared with conventional mammogram with or without ultrasound, contrast enhanced mammogram is superior in detecting malignant tumor when compared to tumor size report at histopathology analysis. Contrast enhanced mammogram leads to overestimate of tumor size by 2.9 millimeter, and ultrasound usually underestimate the tumor size by the same number. There is a study by Lee Felker and others demonstrate comparable sensitivity and performance of MRI and contrast enhanced mammogram for evaluating disease extent in patients with a newly diagnosed breast cancer, as in our case. Contrast enhanced mammogram demonstrated satisfactory size correlation at pathological analysis. Compared with mammography alone or mammography and ultrasound, showing sensitivity of 100% and specificity of 87.7%. So it was found to increase the sensitivity and specificity as a result in more accurate tumor size estimated when evaluating the symptomatic breast. So in evaluation of suspicious microcalcification, the negative predictive value of the contrast-enhanced mammogram has been reported to be up to 93%. Literature related to the performance of contrast-enhanced mammogram in patients with newly diagnosed breast cancer has been repeatedly shown to have an ability to accurately estimate lesion size and disease extent. Again, I'm putting this slide just to bring to everybody's attention, including myself, that the choosing of the modality to assess disease extent is not by preferences, it's not by cost, it is by relating the findings into the guidelines and follow the standard to provide a standard of care. So in conclusion, the guideline criteria address the initial imaging workup of women with stage 1 breast cancer, specifically regarding which imaging test should be done to rule out the unexpected metastatic disease. Individualized the case specific management, meaning that each patient has his own way. It's not like a one template fit everybody. So this needs to be considered as a management strategy. Precise disease extension by imaging assessment is an initial step in management. Thank you.
Thank you so much, Dr. Noor. It's a great talk, and we will open the question. If the staff have a question, Prof. Bushra?
Yeah.
Yes.
Thank you very much, Doctor, for the nice lecture you had delivered in this conference. It's actually very amusing to compare the different modalities, and especially in the diagnostic part of the mammogram or after the surveillance. After the surveillance, we would like to confirm or exclude the findings. And so what you have presented is actually quite helpful. In terms of exposure, actually, the exposure of for mammography is actually of low energy. It is well known.
True. You always, you are asking me, right, Prof. Bushra?
You did your question, you complete your question, Prof. Bushra.
But it's still, the whole exposure is low. And as you have mentioned, it is not that harmful to the patient. Very, very sure. Do you think ultrasound should be used in the cases where screening showed suspicious areas or had stated by rats for the lesion seen to confirm the diagnosis or to have more information before going into extra doses in terms of radiation dose? Ultrasound is safe, easy, quick, and then you can then say, we have to proceed, yes. Can you use intermediately between the screening mammogram and the diagnostic mammogram to use ultrasound as a safe aiding tool to lead you to the other sophisticated like contrast enhanced mammogram? Do you think it is beneficial?
Yeah, and I like your sense of being cautious regarding the radiation.
Yeah.
But remember, we are now shifting from screening setup to diagnostic. When we shifted to diagnostic, we always consider the appropriateness of the tool that we are using, in addition to the efficiency of which the appropriateness is how effective is this machine, this tool to diagnose, and the radiation exposure. So I believe that ultrasound is a great helpful, but remember, it's always a complementary tool. For instance, if a patient is having, which is happening too many times, if a patient has a family history and she's 30 years old and she does not want to do mammogram, and her mom and her sister are having breast cancer, but she preferred to do ultrasound. In this scenario, ultrasound is not acceptable tool to screen her. So if in case we saw something on a screening setup like a mass, okay, and the mass is more of a benign or probably benign, the way to go, the way to go is to do an ultrasound, targeted ultrasound, because what we see might be a cyst, which is by RAD2, then no further management need, or a fibroadenoma, which is a probably benign, which needs a short interval follow-up. So yes, but it's tailored based on the scenario that you are living. That's why a case-specific management is the way to go now. There is nothing like a checklist we put and we apply it on all our patients. No, it's a case-specific management. Some patient has a small mass in a fatty breast, the same case and palpable, yet it does not show a benign feature. And there is a small focus of microcalcification near to it. So the next step is definitely MAG with compression to characterize the microcalcification, to exclude the possibility of ductal carcinoma in situ, or the suspicion of ductal carcinoma in situ beside the invasive component we are seeing on mammogram.
Thank you very much. Yes, you have clarified my point, actually. Thank you.
Thank you so much. We have a question from audience, Widad Abdullah. So I will allow you now to speak. Please, your question. Widad Abdullah, if you hear us.
Oh, I'd just like to thank Dr. Noor for her presentation. I don't have any more questions. It was very clear, very neat presentation. Thank you again, Dr. Noor.
Welcome, dear colleague.
Thank you so much. Actually, just to let all attendants, we are currently have live online in university YouTube channel. So we have almost now 5,000 attendants there. So as the media center told me now, so we have because the Zoom have limited number to be entered in the room, but we open the all the live session discussion now is all live in university channel and YouTube, and now attendance almost 5,000 participants. Thank you so much, Dr. Noor, for a great talk today. And now we are pleased to move forward with our next great expert consultant, Nawf Abdullah. We are so glad to be with us, Consultant Nawf, today. And Dr. Nawf is a consultant of breast imaging and women imaging. Dr. Nawf is a member and licensed American and Canadian board in radiology. She's working international. Currently, she is working at International Medical Center in Jeddah. So she will talk today about multi-modality breast imaging technique, risk versus benefit. So we are so lucky today. We have Dr. Noor, Dr. Nawf, and also following by our expert radiologist, Dr. Fatah. Thank you so much, Dr. Nawf, and go ahead. Thank you.
Assalamu alaikum. Good afternoon, everyone. Thank you, Dr. Shambari, for the invitation, and it's an honor for us to be with you. I'll stop the video now, and I will start sharing my screen. So I'm going to talk today about multimodality breast imaging technique, risk versus benefits. And I'm going to talk mainly about screening setting rather than diagnostic. I'll start that the screening of breast cancer is an area that is very rich. There's tons of studies that have been done, and it have been studied so well with different controversies about that. Given the fact, there are some facts about breast cancer that we all know. We know that breast cancer is the most common cancer in female. Most of the patients, they get it above age of 65 or elderly. However, in Saudi Arabia, we have it at age 52. The average age of diagnosis of breast cancer in Saudi Arabia is about 48, which is 10 years younger than the average age when it is diagnosed in the state at age 58. So we tend to have younger patients with breast cancer. To talk about the different modality technique and the relationship with the screening, we have to understand what is the risk of breast cancer. And when we talk generally, we have to divide our population into 3 different groups. This would include average risk women, the intermediate risk women, and the high risk women. And I'm going to give you a definition later on about each group and how we're going to use the different modalities available for screening of these population. So when we talk about average risk women, we're talking about women with less than 15% lifetime risk for breast cancer, and we get the percent based on the assessment by one of the modules available. When we talk about intermediate risk women, we're talking about women who have a risk of 15 to 20% lifetime risk for developing breast cancer. And there are some criteria that we can utilize to know that these patients belong to this group, including women with personal history of breast cancer, women who had previous biopsy of atypical ductal hyperplasia. High-risk women include specific group of women, such as people who have BRCA gene mutations, women with history of chest irradiation between age 10 to 30 years. And then these people, they usually have a risk of more than 20% lifetime risk to develop breast cancer. So based on that, we have different modality, and I have the 3 groups as you can see on the screen. And these are the major modalities that we are usually use. And again, I would say that based on recommendations, based on guidelines, we follow what should we use, which one of these we should use, and that's what I'm going to talk about. So we have in the 3 groups, we have the mammography, digital breast tomosynthesis, we have the breast ultrasound, and the MR. And if we go to the average risk woman, we know that in all the 3 groups, mammography is very good, and it's the major modality to be utilized for screening. However, in high risk group, the major modality is MRI. Digital breast tomosynthesis is valuable and it's good for all groups. Ultrasound, I will discuss with you when do we use the ultrasound for screening, and then the MR, the evidence behind it, and what should we do with that. Mammography screening, starting with that, we have areas of agreement. We know that, and this is part of the benefits of mammogram. Screening has been demonstrated to save lives of women in all randomized controlled trial. And we know that as per all groups, the one that Dr. Noor presented, it is recommended for all groups at age 50 to 74. We have to understand that it is a screening test, and as any other screening test, it is imperfect and it has its own harms. We have to use it for a very long time to have the impact from it and see it. And it does not prevent breast cancer. However, it does help to detect breast cancer earlier, which would change the prognosis of the patient. And people still, they might die even if we use the breast cancer. So this is just to show you the SEER data for the state, the cancer cases number from 2007 to 2011, where you can compare the age of 35, 39 to age 40, and then 45 to 49, then 50 to 54. And obviously you can see that there is a jump and doubling of the number of cases when we reach to age 40, and more increase when we reach to age 45. And as you can see here, gradual increase in the number. So there is enough burden to start screening at age 40. Society of Breast Imaging, American Cancer, American College of Radiology, they all recommended screening at age 40. American Cancer Society stated is screening at age 40, and then the US Task Force stated the age of 50. And I will not discuss what is the controversies because it is not the time for it, but that's just to show you that all organizations, all groups, they have recommended screening. We come to the benefit of breast cancer screening. So if you look at this graph, this would show the mortality in the state from 1975 to 2007. So if we look carefully here, we can say that in the state, they started screening around mid-80s, and it took few years for screening to show it is benefit, where there is drop of mortality of about 30% in the patients. Another important fact that we keep in mind when we use breast cancer screening is the Survival rate is significantly different when we diagnose breast cancer in early stages, where you have a survival rate of 99 when you diagnose it at the level of in situ. It drops to 84 when it is regional, about less than 2 centimeters, and then it drops significantly to 23% when the patient has distant metastasis. So that means screening has its own value. Show you a couple of studies that showed the reduction in mortality. So this is the famous Swedish 2-county trial done by Dr. Tabar to show the screening impact on breast cancer mortality with 29%. So if you look at these two graphs for patients who were invited to screening and people who did not were not invited to screening, you can see that there is difference in the mortality with a reduction of 30% comparing the invited versus the non-invited. Very similar results to that is the Norwegian breast cancer screening program, where you can see people who were attended in and compared to people who were not attended, there is separation between the two paragraphs, between the two lines, where there is 62% reduction in mortality. Again, it shows the effect and the benefit of screening. If we use the benefit of screening as well and compare the drop in mortality between all age groups, starting from age 35 to age 75, 79, you can see once they started screening, there is drop of mortality. The only age group that didn't show that is the age of 85, and this is because of the other comorbidities in this group. This graph just shows the meta-analysis of randomized controlled trial that showed the effect of screening in reduction mortality with a confidence interval of 95, where you see that there is 18 to 30% reduction in mortality. The only group, two studies that didn't show that effect are the Canadian, and I will touch quickly on that later. You have to keep in mind that some of the randomized controlled trial, they have their own limitation, which could underestimate the value of screening mammogram, but it definitely showed it is reduction in mortality. The only studies that didn't show that are the studies that were done in the Canadian studies, where it showed that there is no difference in mortality between the control arm and the mammography arm. Again, I will not go into the details of that, but there are some reasons, and if you go and read in the literature, you can identify what is the reason for that. Compare this graph to the graph that I showed you that was done in Norway, and you can definitely see the difference between the reduction in mortality. So these are the two only outlier studies that were done in Canada, and these are the reason. They used poor quality mammogram, all devices, no grids, no training for technologists. General radiologists were reading the mammogram, and actually more women with breast cancer were invited into the study, into the screening arm, which definitely affected that. So these are the reasons for the bias that happened in the Canadian study. Moving into the harms of mammography, and this area is quite important because I get question a lot from my patients and sometimes from the physician about that. We know that the mammogram can create lots of false positive and result in an anxiety. The false positive come from additional imaging, and it comes with additional biopsies, and there is the risk of overdiagnosis and the radiation. And I have to tell you that there are a few studies when you look at the literature, but whenever you have a percent of 4.3 to 6.7 per thousand, if you compare biannual screening versus annual screening, additional imaging of 64 to 84 per thousand for biannual against annual over 12 to 16 years. So definitely we have false positive. Definitely you will get more biopsies. But when you look at the effect of the screening using annual versus biannual, what makes the difference is when you do screening, the stage 3, stage 4 breast cancer will drops. You have drop in the stage of 3 and 4, which will improve and decreases will improve the survival rate of our patients. How can I work with the false positive inconvenience? So What we usually do in the centers where you have a breast imaging radiologist, we can do same-day interpretation where we tell the patients immediately about the finding. We can do same-day biopsies. We can utilize the tomosynthesis. And then when we talk to the patients, none of my patients, when I tell them, would you prefer to get breast cancer in few months or in 2 years without doing the screening or doing these extra steps to be sure, all of them, they agreed that they prefer to go through the usual process and be sure that they have no breast cancer. So moving into digital breast tomosynthesis, what is it? What is the basic principle? We usually acquire multiple low-dose mammograms at multiple angles, reconstructed as a slice through the breast. We go through it as if we are going through a CT scan. And this is how it is technically being done. The tube is here. We do multiple images and then received by the detector, and then it will create the image. What is the benefit of tomosynthesis? The benefit is when you see something like that as on the screen, it is very difficult for you to read, and it's very difficult to come up with a finding on that. However, when we do the tomosynthesis, you will be able to identify the abnormality. For example, if I tell you this mammogram definitely has breast cancer, look at the screening mammogram. It's very difficult to tell where is the breast cancer. I cannot see it, and I wouldn't say that I will be able to identify. But when you look here, this is an area of speculated lesion, biopsy-proven invasive ductal carcinoma. This is another case where you have a heterogeneous dense breast. Look at the mammo. I don't think I would be able to tell there is a cancer in this case. I would definitely go and do ultrasound because I wouldn't feel comfortable letting it go. But when you look at the tomosynthesis, you can identify that there is an area of speculated lesions. What are the disadvantages of tomosynthesis? You have definite increase in the amount of radiation to the breast, where you get 3 milligray for a single view digital breast tomosynthesis. However, the total amount of radiation in a good center where they follow the guidelines and the ALARA, the amount of radiation should be accepted and within the guidelines of the MQSA and the European guidelines, those limit. So what we usually do, we have to know that the radiation dose for digital breast tomosynthesis is about 2.24 times greater for combo in comparison to a full field digital mammogram. What are the benefits of digital breast tomosynthesis? There are two important benefits. We reduce the false positive rate, which means that we reduce the recall back rate, and we definitely increase the cancer detection rate. This is the different studies that were done. I would encourage you to go and have a look about it. The most popular is the STORM trial and the MANMO trial. And all of these studies, they have showed a fact. There is increased cancer detection rate ranging from 0 to 28%, and we reduce the recall rate up to 30%. So this is great. This is something that we have to keep in mind. The next question that I usually get asked about, who should be screened? Should they do it only for a high risk? There is nothing in the literature about that. Should they do it only for dense breast? Should they do it for all women? And should be used for screening as a negative? And I will show you this. So this is comparing the effect of digital breast tomosynthesis in fatty versus dense breast. And as you can see, using full field digital mammo plus tomo in both fatty and dense breast will reduce the false positive fraction rate. If you compare it for dense versus fatty breast, so we have the 4 categories of the breast: fatty, scattered, heterogeneous, and extremely dense. The two groups that digital breast tomosynthesis showed the best effect are these two groups, where the number of cancer detected jumped from 26 to 36, and in heterogeneous group 23 to 34. In extremely dense breast, it's not very useful and helpful. In fatty breast, it is increased. However, it is not statistically significant. So again, this to show just the reduction in the recall rate. Reduction in recall rate happens in all types of breast density. So what should we do? 70% of cancers are best seen only on digital breast tomosynthesis, especially for type 2 and type 3 breast density. There is no statistical difference between fatty and extremely dense breast. Moving into the third technique that we use is the breast MRI. So I want to cover a few points, and for me, it's very important for all physicians to understand what we deal with. So I know that there are some challenges associated with women at high risk, and I'm talking here because, as I mentioned at the beginning of the talk, that MRI is basically used for screening of high risk women. And then I'm going to show you quickly the difference in sensitivity of mammogram, ultrasound, and MRI in screening in different age groups and different groups. And then what is the benefit and the risk of screening MRI? So the challenges that we have is usually patients who are at high risk, they develop the breast cancer at young age group. And these women, they are usually BRCA mutation. And mammography in this group is usually less sensitive because they usually have a very dense breast and they tend to develop a very aggressive cancer. Screening mammogram usually detect only 50% of the breast cancer in this age group. And in routinely screened patients, half of the cancer usually spread to the node at the time of the diagnosis because it's usually very aggressive. We don't want to expose these groups into radiation because they are young, as we said, their breast is very sensitive, and we don't want them to get breast cancer because of radiation. So if we read about what's the benefits of using breast MRI in high risk groups, there is tons of studies available. But there are some facts again. MRI have shown to have the highest sensitivity. And if we compare MR to mammography to ultrasound, you can see that it has a sensitivity of 85% as compared to 40% in mammography and 40% in ultrasound. This is just to show you the meta-analysis of different studies comparing the sensitivity of mammo, ultrasound, MRI. Again, the same thing, MRI has the highest sensitivity. This table just to show you the cancer yield of different modality in utilizing it for screening of high-risk group. And again, if you look and you compare MRI in comparison to ultrasound, mammogram, the cancer yield of MRI is almost double in comparison to mammogram and ultrasound. This is a very important graph that I always like to mention, that they studied the difference of cancer yield of different imaging modality. And if you look here, for mammogram, it is 6 per 1,000. If I add an ultrasound to the mammogram, it will increase 1,000, one cancer per 1,000. MRI alone, it will detect about 15 cancer per 1,000. If I add mammogram to MRI, it will be the total of 16. So they were questioning really, should I utilize mammogram in addition to MRI to screen these patients, because it will increase only one patient or only one cancer in comparison to MRI alone. So this is an area that we should think about. The only problem with MRI is we have ignored MRI for screening for high risk because we thought that it has a low positive predicted value. It is very expensive test and it takes long time to be done. However, this have changed. And if we compare 10 years ago or 20 years ago, when our experience was not great with MRI, our specificity with MRI has gone significantly high, and this was published in JAMA. We come to a very important fact that we cannot deny is the price of MRI. If you compare it in any private sector, the price of MRI ranging from $1,200 to $3,600 in some institute. And for ultrasound or mammogram, it ranges from $400 to $1,200. So there is a real fact that MRI is expensive. So the idea of abbreviated breast MRI that Dr. Rain will talk about, it is very quick, it has a very positive predictive value, and it will definitely increase the cancer detection rate. And lots of studies available. The best one is the one that was published by Dr. Poole, and I would advise you to go and read it, which is just demonstrated how beautiful the fast screening MRI would be optimal. What are the current recommendations for utilization of MRI for screening? MRI should be utilized for screening of BRCA mutation, people who have first degree relative of BRCA, people who have other types of risk, and we calculated their risk reaching 20 to 25% as per any of the risk module, and then radiation to chest, Li-Fraumoni syndrome, and other syndrome. There is insufficient evidence to recommend screening MRI for moderate risk group. and these are the one we talked at the beginning. They have 15 to 20%, and they have history of ADH, ALH, LCIS, or personal history of breast cancer. So this is area, there is no strong recommendation that I would utilize it. I want to point out about this data, which is very interesting to me. They collected the data in the state from 2005 and 2009, and it showed a very interesting finding. They compared people who are high risk and people who are not high risk. They divided them into 3 groups, and they studied how many of them have done MRI and how many of them have received only mammogram. And interestingly, if you look here, this is the group who received MRI. You can see that 800 people who have risk less than 15%, they had MRI for screening, while the high risk group, they did not receive that. And again, if we look at the mammo group, you can see that people who have high risk of 20%, they had mammogram instead of doing an MRI. And this would bring a very important question. What are we doing? Is it the problem from the radiologist or not? Are we educating our colleague and telling them when should utilize the MRI? Should we talk about the family physician? Should we do more education? So how to change that? We have to identify women who will benefit from MRI, genetic testing. We have to improve risk profiling. If we want to use screening, we use abbreviated breast MRI, and then other stuff. How can we improve that? As I said, we have to improve the education for our colleague. So MRI is a very important tool for breast cancer detection, has a high diagnostic accuracy. However, it should be utilized properly for screening, and it should be really evidence-based, and we shouldn't use it for all patients. The last part that I will talk about is breast ultrasound. We know that breast ultrasound has its diagnostic indication. It is usually used for solid cystic characterization, evaluation of palpable mass, but that's not the part that I want to talk about. The part that I want to talk about, what's the role of ultrasound for screening? So there is some emerging indications for breast ultrasound. It is used as a supplemental test screening in women with high risk for breast cancer. We can utilize it for dense breast tissue because they are considered as an intermediate risk group. And dense breast tissue, we know it is independent risk factor, and it is difficult to be detected on mammogram. So mammogram, it is proven the best. However, when we have dense breast, probably we should add ultrasound to be utilized. So based on that, from the 5th edition, BI-RADS lexicon, there is recommendation that we should mention what type of density of breast cancer. And as I will show you, ultrasound have shown it is benefit. These are the benefits of ultrasound. There is no ionizing radiation, no injection. There is incremental cancer detection rate. It is less than MRI, but better than mammography alone. It has support and additional evidence of cancer detection. However, sometimes it's a lengthy procedure, takes about 30 minutes, and it needs a person who's very expert in doing the ultrasound. Generally speaking, it would improve the overall diagnostic accuracy, and we will tend to see small cancer. The famous Akron 666 trial about using ultrasound in screening settings showed definite evidence in using the ultrasound, and it would show that there is increased detection of breast cancer of about 3 per 1,000 when we use screening ultrasound, especially for dense breast. Another modality that came is the automated whole breast ultrasound, where it is very reproducible. It is not operator dependent, where the technician will do the ultrasound, and then it will send 6 sets of standard images, and it will be read by the radiologist. We will be able to pick small cancer on that. And if we compare ABUS to handheld ultrasound, they are very comparable. I would say they are almost the same in cancer detection rate, ranging from 3 to 4 per 1,000. The diagnostic accuracy is very high, and the specificity is very high. Just keep in mind, I'm talking about a very expert person who knows how to read breast ultrasound and to perform breast ultrasound, because this is an operator dependence for the handheld ultrasound. So To summarize, mammography is the main modality for screening average risk women. It has proven to reduce mortality. Digital breast tomosynthesis is great. It reduces the recall rate, improve cancer detection rate. If we add ultrasound, it would improve the detection rate, especially in dense breast. MRI is the most sensitive modality. However, we should utilize it only for high-risk women for screening. Thank you so much, and I would love to hear any question from you, and these are the way how to contact me if you need anything further. Thank you.
Thank you so much, Dr. Noor. It's a great talk, and to compare between modality, especially I like when you explain about MRI. So Dr. Prof. Abdul Menam will be a chair for this session. Go ahead, Prof. Abdul Menam.
Thank you very much, Dr. Anouf. Really, I enjoyed your presentation. Very outstanding and fruitful. I have 3 questions. I need your comments. First, we conducted a study in Kharj here. We collected data for 60 patients. We analyzed the reports. We found that almost 80% of the patients with normal findings. We feel that this results unjustified. We don't know the percentage of normal rate of patients with findings when they undergone mammography, but we feel that might be some unjustified procedures. What do you think? What is the normal rate of normal findings for suspicious or suspected breast cancers?
So I would say the other way to answer this is I would say that the recall rate is variable, and what was recommended by the American College of Radiology is the recall rate should be 5 to 15%. So if we exceeded that up to 20%, sometimes it is acceptable. More than that, I think it should be questionable. So I would say that it really depends on the expertise and the experience of the radiologist. I would say in the first 2 years of practice, our recall rate and doing more biopsies will be much higher. However, we should have it below 15 as per ACR. I have people, I know that some of my friends, even in the States, it reaches up to 20% and 25%, and they are being questioned. But at the end, I would say with time, this should go down. And I would say that definitely if we have question, we have to go more courses, attend more courses, because with experience, definitely our recall rate and our biopsy rate would definitely go down.
Okay, thank you. So our results is really amazing. We have to collect more data in order to ensure that this is the current situation. Another question, when speaking about risk factors for breast cancer, I think one of the highest risk nowadays is CT scan. CT test, because our data, our international literature shows that when a female less than 40 years old undergoes CT scan for test, it receives a dose almost 30 times higher than normal mammography. That means the cancer risk increase almost 3 in every 100 women per procedures. Do you have an effort just to guide the referring physicians how to justify the CT test, technologists how to use the breast protective shield for other procedures than just X-ray, than CT test? Do you have any comment for that?
Very good question, Doctor. I think this would put a big load on any radiologist. I would always, and I'm a big advocate for our patient. And the reason for that is, as radiologists, we like to sit in our room, close the door, and read the cases without interacting with our colleague physicians. The best way that we should work is we have a patient-centered care. We look at our patient individualized. We review the request before doing it. we have a discussion with our referring physician. What is the reason for the CT? Is it indicated or not? We outweigh the benefit versus the risk. And if it is needed to be done, definitely we will do it. And then we will stick to ALARA. We'll try our benefit. We use the software that would minimize the amount of radiation, and we will try our best to minimize the dose to the patient. But at the end, I would say if the patient is coming, for example, to rule out pulmonary embolism, this is something major that would kill the patient. I would have the discussion, be sure that the referring physician is very worried about it and it's a real concern, and then we will proceed. But again, as a radiologist, we are the patient advocates from the radiation point of view. We have to take care of our patient, think about the radiation, the accumulation, dose that our patients are being exposed to, and keep all of that in mind.
Okay, thank you. My last questions about dense breast patients. Do you think that it is better just to go directly for MRI for patients with dense breast, or to follow the regular procedures?
Thank you for this question. Again, as per the American Cancer Society, dense breast patient, they fall into the category of intermediate risk group, which is 15%. So as per the guidelines and the recommendation, I would say we should not utilize the MRI for this group. I would go with mammogram and ultrasound. And I find mammogram and ultrasounds, they are excellent, really excellent tool. In cases where the patient has very dense shadowing breast, some of the dense breasts are very easy in ultrasound, but some of the dense breasts are extremely shadowing. If I feel I am not comfortable with the ultrasound and I might be missing small cancer in the area of the shadowing, I would recommend doing the breast MRI, and I've seen cases and we picked breast cancer on that. But that would be not the regular practice, and that would be not following guidelines. Mammogram and ultrasound would be enough for intermediate risk group, except if the patient has a real reason to go and proceed with the MRI. Otherwise, no.
Thank you. My other colleagues, Dr. Green, do you have questions?
I think I totally agree with your second point and what Consultant Noof mentioned. We need to stress that. We need to make sure in multi-centers in Saudi Arabia, we follow the international guideline for CT. There is a couple of studies is published recently to compare the practice, the real practice in clinic for CT, either for breast or either for cardiac CT. They found it's a little bit not a little bit. It's far away from international guideline, and there is a huge variation between centers, I mean the hospitals. So I think it's a really interesting point, especially for CT. We need to stress and strict with international guide in CT. And yeah, thank you so much, Dr. Noof. And if there is any question from doctors.
Yeah.
Yes.
Me.
Yeah, go ahead. Go ahead.
Okay, thank you very much. Thank you, Doctor, for the nice lecture delivered and for the exercise of the researches, comparison between researches and modalities as well. You mentioned, or sometimes I come across a study relating the mortality rate by breast cancer with either modalities or methods of investigations or something like that. But it seems to be the type of cancer and the earliness of coming to the clinics is the key rule for having a good prognosis or prognosis in cancer incidences or have good management. Not something else. It is not like modality are the fairest whatsoever the modality is, being one of what we have mentioned, and I am a radiologist as well. But I think how early does the patient comes? What is the type of the cancer he or she has? I think is the key rule of having good prognostic science, as well as having, for example, tomosynthesis means that we are going to have good resolution, good detection of the missed maybe lesions. But we think that you have stood beside mammography and ultrasound, which are the diagnostic tools of the poor people like our countries. I don't think we are exercising these modalities as to be generalized for screening or for spreading it throughout countries like African countries, for example. It is good to use them whenever it is there is means or wealth or strategic thinking of accommodating these modalities at home, like Saudi Arabia or other rich countries. But for other countries like African ones, mammography and ultrasound are the tools for scanning, surveying first, and for diagnosis mammograms in the second stage of classifying which is malignant and which is not. Coming early and the type of cancer are the key rule of prognosis. Thank you very much.
Thank you, Bushra. I just want to comment about what you've mentioned. So I agree with you. Type of cancer does make a difference, but at the end, screening does play a major role, as I showed, in reduction in mortality. When you pick grade 3 breast cancer earlier with mammogram, the outcome of grade 3 cancer would be definitely different if you leave it and the patient come with a palpable mass and metastasis. Another point is, if you compare the mortality in male and female patients to see the effect of chemotherapy, different type of chemotherapy, you can see obviously that the mortality rate in male is much higher if we compare it to female. And the only difference, they are using the same treatment. The only difference is in female, we do screening, we detect breast cancer earlier. In male, these patients, they come when they are advanced with palpable mass. So I am a big advocate. I agree that some cancers, no matter what you do, it is aggressive, they will come with metastasis, but mammo has proven to reduce mortality in all types of cancer. The other thing is regarding the different screening modalities available. The first slide I put is about screening mammogram. It is the only modality that can be utilized in all types of groups. It is the only one that proven to have the benefit. If they have the luxury of having digital breast tomosynthesis and ultrasound, we utilize it. If you don't, then the mammo is the only way to go. And as I said, it is really showing benefit in reduction in mortality. Thank you.
Great. Thank you very much.
Yes. Thank you so much. Thank you, Consultant Noof. We are appreciate your time with us today. Thank you so much. Now we'll move to the second session with Consultant Fatina Mohammed Al-Tahan for missed breast cancer, why and how to avoid. Thank you so much, Dr. Fatina, and go ahead. Thank you so much.
Thank you. I will just now do the sharing. Okay. Is it now? Is it clear?
I see just your photo, just your image, live image. So just,
So,
okay, carrying on.
Did you share? Okay, this one. Is it clear now?
Yes. Yes, Doctor.
Okay. So this is an important topic because we are facing this every day, breast cancer. And actually, it's the third leading cause of death in the United States. And I think this is all over the globe. And this is also a major cause for morbidity as well as mortality. Missed breast cancer, it's the most common medical legal claim against physician, as reported in the United States. Estimated that from 6 to 16% of women who experienced physician caused delay in diagnosis and of course treatment. So it is a major problem, and I was really not surprised, but this is telling me that this massive breast cancer is one of the most common medical legal. Thanks God, still here we don't have this problem till now, but I think it's. So why we care? Why we care? We don't want to miss breast cancer. Why? Because this is the aim of the imaging, is to save lives. Why? Because we want to detect the cancer as early as possible, because as we all, everybody knows that the survival rate is decreasing when we detect late. It's not more than between 22 to 13%. If we detect early, it jumps up to more than 95%. And this is very important. Let me tell you that to detect the cancer early, this is one of these views that all these talk about Vietnam Wars at the same time between 65 to 75 this years, that there's more than 4 times ladies who died from breast cancer from the war, if you compare it to the men who died during the war. Why do we want to detect the cancer early? Because, as I say, survival rate higher, less invasive treatment, the journey for the lady will be easier. Everybody knows that the treatment of the cancer in general and breast cancer, sometimes it is worse than the disease itself, and of course less cost. And as we showed before, that there is dramatic decrease in the number of the breast cancer deaths in all countries who implement the screening programs, reaching up to 35%. And another why we care, because there is also legal problems, failure to diagnose. And as I said, malpractice is not really strong in our country yet. Sewing is not too much, but I think it's coming soon. What's the cause of the missed breast cancer? Missed breast cancer means that we have a problem, failure process of the care. And there is many causes. Some related to the patient or the woman himself, and one to the provider, like patient or patient behavior himself. Sometimes patient did not report symptoms, denial, or doesn't do any exams, or they don't do even screening. They don't go attempt the periodic screening. Or sometimes they have the test, but they did not go for it. Sometimes patient, they don't also adhere the follow-up, like if we said that short follow-up, 6-month follow-up, whatever. This is all related to patient behavior or woman behavior. Now, there is causes related to provider failure. Like, this is very, we can find it now in our practice, especially in clinics where the clinicians are busy with filling the HIS, filling all this software and the application, and too much patient, there's chaos all over, too many. They don't do any, they don't take good medical history, they don't do physical exams. Some people, they think if some clinician, they think if the lady comes, she complain of, even she doesn't complain of any breast problem, but there is usually general breast exam, adequate physical exams. And sometimes, even if there is any problem, patient come with the problem of a breast pain, sometimes significant breast pain, clinician, they don't request the appropriate test. Or sometimes they do order, but they did not perform it in due to many causes, sometimes too much waiting time, waiting list, or and patient, she loses interest to do this exam. And there is a problem, like this kind of causes. But I want today to concentrate on what is really related to the radiology part, the missing or breast cancer, or misinterpreted the findings by radiologists, and whatever was we used tool, mammogram, ultrasound, or MRI. So this is the most common causes they found it in the literature about the causes of the missed breast cancer. But as I said, I will concentrate today in my lecture or my presentation for the causes of missed cancer by the radiology part. And improving breast cancer care really, as you see too many causes of the missing, detecting the cancer, need really require and real intervention, education for all, and training for manpower, as well as the woman. We have to empower the lady to take care of herself and to detect the cancer early, either by training her how to detect the early sign, or attending the screening clinic. Missed breast cancer, what we mean by missed breast cancer by mammography, that cancer can be seen in retrospect, or any interval cancer found during screening less than 12 months. And this is between 1 to 35%. The missed in retrospect, either there's real missing of the critical finding, suspicious finding, or their misinterpretation by the radiologist, where they don't call it as a significant finding or suspicious finding. And the first one, which they missing to see the critical finding or the suspicious changes, is come for 30%, which is more common. Causes of missed breast cancer, there's many causes, and we put it in a table like this, either related technical factors, patient factor, the type of tumor also factors, or provider factors. Now, if we go for technical factor, this is and this is very important, and I see it because I cover even in the private and also in the as well and other places. There is really need to educate and teach and train the technologists. And we say that always, as a radiologist, we say that always our neck in the hand of the technologists. So bad exposure, malpositioning, motion artifacts. Sometimes if we do also ultrasound, poorly trained also ultrasound tech, if you depend on her and she doesn't also detect the lesion, this is also a problem. So technical factors. So proper positioning, it's the key. It's the key of not missing any cancer or any changes. And the technologists, they must have always a unified way of doing the procedures. They don't have to be afraid from the lady to discomfort her. And I always tell my technologists, don't be afraid from your woman, from the lady. She will be upset from you if you miss if we miss the cancer, but don't be afraid that because some lady, they said we do have discomfort, whatever. But always you try. You have always try, and be sure that you involve the whole tissue of the breast in the image. Like if we take the CC, you have to see the pectoralis muscle, even in the CC, as well as the retromemory space. This is very important. Another thing for good technique, also when you do the MLO, you should see it as a mirror image, V-shape. Pectoralis muscles is included and should be not less, the level of the pectoralis not at least at the level of the nipple and with V shape, and should be like mirror image. Now, also to know that we are including the whole breast tissue, because we have to include it posterior, anterior, and from up to down. So what we call it, the pectoralis nipple line should not be different between the CC and the MLO 1 centimeter. If there is difference more than 1 centimeter, that means there is missing of tissue. It's not included in the images. Nipple in profile, because sometimes when nipple in non-profile can cause shadows and do a lot of, and this will cause us to do a lot of more investigation, unnecessary investigations. Okay, like this. You see, this is nipple not in a profile, and this is looks like sometimes this was as a density or symmetrical density or mass, and then will lead us to do an ultrasound, sometimes more, and this so very important also the nipple should be in profile. The same patient, when we put it in profile, this look how there is no any retroareolar shadow. Also inframammary fold, this is very important place where let me say 70% of the technician, they don't include it in the image. That means a third of the breast is not in the view of our to interpret. Also in dense breast, we have to be really careful, even in dense breast, but the positioning should be adequate. Bad exposure look like this, very bad exposure, and if you have good exposure, the same lady, look how it will look. You can see the old calcification there. So bad positioning, bad exposure is also important. And let me tell you, this bad exposure important even with the digital. Sometimes the technician, they try to play with the density and with the window, but really we can miss cases even if they try to play with the window level. So high quality mammography is vital to enhance radiologist ability to do good interpretation. And radiology should be strict with there's always a good relation between the radiologist and the technologist, and he has to train the technologist, and at the same time he has to be, or she has to be strict to ask the technologist that the mammography or whatever kind of modality should be proper. Image should be free of any artifact. There should be, as we said, adequate exposure, high resolution, high contrast. There is proper compression. As I said, sometimes the technologists are afraid from the woman. They don't want to make her upset, so the compression is not really appropriate. And as I said, there should be a must to include all the breast tissue. And this is training is vital. So first step to have a proper interpretation, you as a radiologist, you should have a good relation with the technologist. Train her and give her a trust, and she will give you a very good examination. Like this case, if you see, and also when we train the technology, she should be independent, independent to interpret the image. And I always tell my technologists, when you do the exam, go and say, answer this very important question. This is if you see any finding, this real findings, where is this findings? Can I see also this finding? You should also characterize the lesion. If not, you had to create a position and help the radiologist to do the proper interpretation. Like here, you do like spot magnification and look like how it's the lesion looks very speculated and worrying lesion. So always tell your technologist that she should, before she come back to you and ask you I'm free, and before she release the woman from the mammogram room, she should answer herself if this is what she see. Is it really a real finding, and where this finding, and is all there is really a good characterization of that lesion. This is also another dense breast, and when they did a compression, you can see that speculated lesion here. You hear the compression very clear. You have the speculated area. Another one, when you do, it's clearly there is a speculated lesion, but where I can see it here is this, or this is behind. So the only way to know that this technologist should do an exaggerated CC view, and you can see clearly that this is the speculated lesion is here. And even you can also add a spot compression magnification view. So this is for the technical part. And as I said again, and I emphasize, technical is very important. There is a major mistake happen in all the most of the mammogram suite, especially in the private area. Patient factors, like if we have dense breast, either it's congenital, inherent, or acquired, like implant, augmentation, implant, or large size. You know that large size, sometimes the technologists cannot really place her good, or sometimes even when we do an ultrasound, especially in our case, most of our ladies, they have fatty breasts, which is bad for doing an ultrasound. Large size also make the thing, it's difficult. Let me show you that when you have a fatty breast, between the dense and the fatty breast, this is fatty breast, and how nicely you can see even small cancer, less than, this is about 4 millimeter cancer. So in fatty breasts, we have the pleasure to see even small lesion. And this is the SAR character BI-RAD for the breast composition. And definitely the dense breast, the dense, which, I mean, the breast which usually have tendency to miss a cancer unless you do other tool, either you make do ultrasound or the tomosynthesis. Sometimes with high risk, you can go also for MRI. So as I said, sensitivity of the mammogram related a lot to the composition. On fatty, sensitivity up to reach sometimes even 100. And when it is dense, it's not more than 65 or even 40%. Okay, this case, dense breast, and the patient came with complaint, breast pain. When we do an ultrasound, she has a palpable mass in the left side. However, she did not really palpate it because simply she doesn't do a physical exam for her breast. And we did also MRI, we have the mass, and also there is also another mass in the other side, and ended to do bilateral mastectomy. She was high risk patient. Her mother had a breast cancer when she was 45 years of age. This is another dense breast. You can see that, what about this? If there is a mass, if there is whatever. So you have to be careful not to send the lady with not doing any extra effort, like do an ultrasound, whatever. This is also, however, let me tell you, not always when you see dense breast, just stop searching for a lesion, because even when you have a bad day, a lot of cases, even with dense breast, you can detect a small lesion like this, speculated lesion. And this was one of my favorite picture. I always give it a case, less than 1 centimeter, early detection. Lady, she definitely does not feel this lesion. It was screened in the screening setup. So what we said, we said. Another thing we said that, sorry, I have to go back a little bit, okay. Another thing we have for tumor factors. Tumor factors, of course, there is subtle cancer, sometimes not clear, architecture distortion, small calcification, focal asymmetry, whatever. This is training of the radiologist here is very important. He has to know this subtle sign of cancer, because we are, as a radiologist and especially breast imager, we are not aiming to detect cancer which everybody can see. No, our aim to detect an early cancer less than even 1 centimeter. Yeah. And of course, we have to know the hidden area, where we have always asked ourselves, are we see the hidden area? And also to see there is multifocal, multicentric, sometimes 30% of the cases have multicentric or multifocal cases. And we have to be aware of slow growing cancer and specific type of cancer. I will give an example for this here. So we don't have to ignore any subtle architecture distortion, because this is usually come with the lobular carcinoma. Lobular carcinoma very known to present with the architecture distortion. And don't depend that the ultrasound is negative. When you have something like this and you are worried, you go and you do wiring and you do an excisional biopsy exam. Another, we have to look for, as I said, subtle changes, any tethering in the or disruption or the orientation of the parenchyma. Even in, this is very important to do as a practice or as an exercise, especially in the dense breast. Always look for the parenchyma. There's any tethering, any changes in the orientation of the normal chains. So you have to add another tool to detect, like an ultrasound, and then you can detect the cases. And now we use also the tomosynthesis, which usually help us and reduce the recall in our dense breast. Also look for any asymmetrical density. Don't any asymmetrical density. Also you have to be careful. Look here, this was ignored, and then come back in next year with significant lesion proved to have a lobular carcinoma. Another example case where ignored the density here, asymmetrical density, and in another 1 year come with significant mass also. So you have to be, when we use scan the image or interpret, to do, as I said, mirror image and do these, any asymmetry or difference between right and left side should always attention you to that there is something there. Again, we have also one problem of the or causes of missing cancer, when sometimes you have a lesion. We know that always we depend that to see any changes in the two view. But even if you have changes in one view, don't ignore it. They found that malignancy can happen also in any, of course, because if it's only seen in one view, it's called asymmetry, not a mass. And they found that up to 1.8% in the screening setting, they can detect malignancy in one view asymmetrical density. And it's up to, sometimes can and account to up reach to 38% of all missed cancer actually related to one view asymmetry. So take it, consider it, and always question yourself, especially if you have any previous studies, if this is new asymmetry, is it increasing? If there is any additional finding, there is any suspicious microcalcification, if there is distortion, whatever, and always you can also put your hand and examine this lady and see if there is any palpable findings. And if you find any palpable findings, you should directly do an ultrasound or an MRI. This is more follow-up of the case. And when we did ultrasound, we have a heterogeneous mass and tend to be an intraductal carcinoma. Also, one of the subtle signs of malignancy, subtle calcification sometimes. Do I ignore this, avoid? This is a benign, scattered, small groups, this, whatever. But I always, when I see microcalcification, I don't want to miss the DCIS. And this is kind of, especially the missing with kind of BIRAD3, when we call this BIRAD3. So always, when you have any question of microcalcification, you have to do an additional view examination, at least do an MRI. In the setting of the mammogram, you have to know that there is an area where there should be no lesion or any changes seen. Like this is what we call it Milky Way of the by TABAR. There should be no any density there. So if you see this area, you have always to consider that there is something. And when you do a magnification, you can see that there is density as well as microcalcification. Okay. Another cause of missing cancer is the slow-growing cancer. We know that any stable cancer, any stable changes for 2 years considered benign, and this is not true actually. If you have any mammogram, a previous mammogram, you should go back to at least, if you have even to up 7 years, you can see, and you can go back to this. And don't depend only to compare the case with the exam with only the last previous. You have to go as back as you can, because you can also you can always notice or find the changes. Of course, we know the doubling time is 44 to sometimes, as I said, to sometimes with the slow growing reach more than 2,000 days, so up to 7 years sometimes. And also, don't stop searching when you have changes. Like here, you have definitely this lady, she has a lumpectomy, but what about this is a new lesion? So don't let the other finding stop it. You do the magnification, you can find a small nodule, and when you do mammogram, this is small 3 millimeter lesion. And this is actually our rule to detect the cancer early. Again, also, this is 72 years old lady. Don't say that she will not have a cancer. You have a lesion. You want to characterize it more, and definitely you will have what we call fairly well circumscribed looking lesion, colloid cancer. So be aware also of the benign looking cancer. So this is for the tumor factor. Let's go for the most important also part, the provider factor or the reader factor. In the middle of this chaos day, you have as a breast imager, you have mammogram, ultrasound, whatever kind, biopsies, MRI. Don't let this affect your standard of interpretation. Always go to a quiet place and don't do reading when there is a lot of interruptions. And a lack of perception, they found it is the most common cause of missed breast cancer. What we mean of lack of perception, the lesion is there, but it's not recognized by the radiologist. Yani either it's small, non-speculated mass, area of architecture distortion, as I mentioned, small cluster, whatever. The radiologist, either he in middle of a lot of work, there's a lot of interruptions, or need more training. Training is very important here. So, and when we move, but I have to say that this is very important because I can see sometimes the bad attitude between the, let me say, non-ethical attitude between the radiologists. Remember that when you detect a tumor in retrospect, don't think that you can detect it at that time. So always give an excuse unless there is major problem and they're major missing. But don't always be a judge and say, if I saw this, I will detect it. This is put it. Let's be also have a principle in our way of dealing with the missed cancer. So to avoid the perception error, as I said, always when you see these two and when you see the mammogram, you should view it as mirror image. And now there is a lot of application which can give you the way, even the masking technique or the quadrant that you can see quadrant by quadrant and compare between each other, or you use the mask, either mask in the MLO or in the CC view. This is help you a lot to not missing a lesion. Like here, definitely if you see it as a mirror image, you can definitely detect that there is a area of asymmetrical density with mild stromal distortion. Also, you have also see all the image. Look for the what we call it the blindest blindest area, where usually the radiologists miss this, like inframemory fold. Did you always look that before you leave the exam? Did you always ask yourself, did I check the blind areas? This is very important. I have always to check before I close the mammogram. Did I check really for the blind spots and what we call it forbidden zone by mammography, like here in the inframemory fold, barely seen this speculated mass. What's this, the forbidden zone? The forbidden zone, there is many, in MLO, of course, the Milky Way, the upper pectoralis region, and this is any density you can see here. This is definitely considered an abnormal. Retroareolar area, especially in the old lady, always you have to look for. Even there is also lower Milky Way, in the lower posterior region, always, and when I do, this is my practice, before I close any mammogram, I always check this is 3 area in the mammogram, and I mean in the MLO. In the CC view, always I see the retromemory place, I will call it no man lands, and also we call it also any junctional zone, any changes, any tethering, any extra density. And also always look for the medial part. Medial part sometimes can be missed or not included. And also the nice configurations, the border between the fat glandular area. And this is where I have always to look for the forbidden zone. If I complete this exercise, it will not take that more than 2 minutes, then I can close my mammogram and I feel comfortable that I really scan all the image. This is an example in the Milky Way. Here, there should be no any density. You can see it even in the CC view, although this is a dense breast, and this was case of lobar carcinoma. Another one in the Milky Way, we did spot view, and this is also turned to be a ductal carcinoma. And this is the ultrasound. Now, another cause of the missing cancer is satisfaction. I feel satisfied that, okay, I find one lesion, خلاص, that's it, and then I stop scanning the whole, finishing the whole areas. Detect one or doesn't يعني let me to stop scanning because there is always the chance that there should be there be multifocal or multicentric cases, and this is account, as I said, to 22% of the mirror or missed cancer. And so I sometimes always, if you are not happy, do double reading or ask other colleague to be with you. طبعا double reading is a must, mandatory in the screening setting, but also in diagnostic setting. If you are not happy, you can always ask your colleague to have another look. Two brain is better than one. But the first important thing that the satisfaction of the search. Satisfaction of the search should not be stop you, if you see any lesion, should not stop you from seeing another, looking for another case. I have to stop 1 minute because there, I think, some kind of noise عندي. سامعين noise من عندي ولا ماشي الأمور دكتور كريم؟ في noise؟
ماشي الأمور، ماشي الأمور من عندك دكتورة.
أوكي تمام. And somebody using telephone down, so make me look.
It's okay, it's fine.
Fine. Another thing that you have this here, you have a case where there is an asymmetrical density with also distinctly small nodule. When you do here, when I see like this, it's so clear, maybe it will stop me to see this small density. But this is real also another finding. So when I do an ultrasound, there's real malignant case. If I do also the MRI, it shows me clearly that there is also a lesion there. Also, this case, we have clear there is well circumscribed or fairly well seen mass, ugly looking, but what about the other area here? This also, there is also extension until the nipple, and there is nipple even retraction. Another case of also dense breast, and we have, we have density in the, what we call it here, the no man land. And when we do ultrasound, it shows that there is also a malignant case, cancer. Another case, you have one and a multifocal area, and don't have to let you also, when you see this, to ignore the other finding. We do magnification and this. And always very important, this is, I found it also, if it's available in your institute, to put a radio opaque marker at the area of patient complaint. Or if you train your technologist to do a physical exam, you can tell her also if you find any palpable area, even the thickening, not only a mass or lump, you can also put a marker. This marker can help you a lot also in detecting and do special attention to this area. As I said, always you can use the 3D or the tomosynthesis can help you like this. You can see even there is not only the linear irregular density, but also you can see there is also a group of suspicious microcalcification. Anchoring bias. And this is usually, I found it especially with the junior lady, or when there is even you are tired, just you take the history from the referral physician or from the lady herself, and then you stuck to this finding. Like this lady, she come with sign of inflammation, and then it was stuck in the mind that this is an inflammatory process. She was also lactating lady. And unfortunately, when she came back, there was real she came back after 8 months. She came back with also lymph node metastases. So don't always, okay, it's very important to use to listen to the history, to have all the data, but also you should have your own way of systematic interpretation and evaluation of the case. And if you are not happy about the case, that the finding does not match the presentation, you can bring your patient back in short follow-up, like usually my way of following the inflammatory cases, I always bring her after good course of antibiotic, maximum in 3 weeks. I do another ultrasound. And of course, this lady, definitely you can see there is also a mass in the filling all the right breast, as well as we can see in the ultrasound, there is also an axillary lymphadenopathy. Incorrect interpretation. This has happened usually when we put BI-RAD 2-3 instead of we putting BI-RAD 4-5. Suspicious, but it's misinterpreted. Not it's missing, it's misinterpreted. And this is where we say that you need really to always do an ongoing training, because mammogram especially mammogram, we know that there's a lot of normal variation. Normal variation make a burden on the reading on the mammogram, because either if you don't have good experience, either you will go to do an over-reading or you do under-reading. Over-reading, when you see any changes, you consider it as a malignant or suspicious, and this is over-reading. Or if you have, you don't have, also again, you don't have good experience, you can even don't see the early sign or the suspicious changes. So training is very important, very important. There is always, you should always do periodic, you should always do a self-auditing for yourself. You can go back and see cases, it come to you as from the referral physician, it's missed, or you can also do scattered, just reviewing your cases. And I remember 10 years back, I used to do this before I have this. Now I'm a little bit more busy with administrative work. And sometimes I see for myself missing cases, and then I call back the patient. Patient doesn't know that is a problem. Usually I used to do it by every 3 months. And sometimes I found cases where myself, when I review the cases, I find it and I put the woman again. So these incorrect interpretation, the causes either there is lack of experience, and this is, we need an important advanced training, or there is fatigue, we cannot concentrate. There's always when you think you are tired, stop. Whatever was, there is need that there is a patient following you. I need the report, especially in the private setting. Stop, because you stop better than to miss a case. And when we miss case, we are dealing with death or life. And another thing, another cause of the incorrect interpretation, as I said, as sometimes the quality of the exams is not good. Not all the breast tissue is included. There is slow growing lesions, and when they compare only to the last image, they think that there is no change, stable. So always try to go, if it's available, try to go to the last, the most يعني
Dr. Fatina.
أيوة.
Thank you so much. We almost exceed the time, and we
okay,
have to.
and I finish. Just I will. This is with this slide. Take home message. I'm just giving you take home message.
Sure. Take your time. Just.
Okay. This is very important for the radiologists, especially the junior, and all the people who do, or the radiologists who do mammography or do breast imaging in addition to the general work here. Always you have to look for a place where you do training. Now with the Corona time, there is a lot of virtual training sessions you can attend. Review the clinical data, as I said, compared to the current image with the prior studies, and you can go back even up to 7 years. Don't always say that 2 years is stable, that means it is benign. Be strict for the positioning, for the technical factor with your technologist. Remember to check the blind spot before you close the case. Adherent to the subtle feature of breast cancer, you have to know, train yourself here. Use additional view if it is you need magnification spot. I can see in some private areas they don't even do, or they don't have even the pedal. Use also, if you have a palpable area, and the mammogram is negative, go for an ultrasound. Look for any other lesion. When you see one lesion, remember that there could be chance there's another lesion there. And judge always with the most malignant feature. The problem with some radiologists, they go to the most benign feature and they ignore. If you have only one malignant feature, you have to take it via double reading when it's possible. And always you have to have a close cooperation with all your team, including oncologists and pathologists. And as I said at the end, if tired, overall, stop reading. Whatever the people tell you, I need my report. Thank you.
Thank you so much, Dr. Fatin, and the Dr. Amjad is the chair for this session. Dr. Amjad, the mic with you, please.
Thank you very much, Dr. Fatina, for your great talk. We enjoyed your presentations today. Actually, we appreciate your time and efforts, and we have some questions for you. As you mentioned that the early breast cancer detections can increase the survival rate by 95%. Do you think that women at 40 years old and above who do not have any family history or other health problems should also do the annual mammogram screen, or ultrasound imaging is enough in this case?
Any lady, when she's 40, she should do the periodic exam, mammogram. As I told you from our analysis in our data, most of the cancer patients, they have no any risk factor, including the family history. So don't, and this is one problem with our women. They think if she doesn't have family history or she doesn't have a sign, she should not go and attempt the periodic screening. And very important that also to educate the lady, not only to come for only one time. Our aim to detect the cancer early during the periodic exam, because we aim to detect cancer less than 1 centimeter. So during the periodic exam, either it's 1 year or every 2 years, ladies should come. And we don't usually depend on the ultrasound.
Okay, we heard about the importance of the early detections of breast cancer. But do you think that women also should be informed about the most recent advances in plastic surgery that can restore the shape of the breast after the treatment? Because you know that this problem affects women emotionally as well, doctor.
This is very important. And this is also the job and the duty, responsibility of the plastic surgeon and the dermatologist. And now we are seeing a lot of really scary cases where they do fat augmentation and they do fat augmentation, and lady come with multiple masses, oil cysts, calcified lesions, and she has a nightmare. Nobody told her when they do the fat augmentation that this can be happen. Plastic surgery, the surgeon should tell her that when you do plastic surgery, that means you need either every time, you don't depend only on mammogram, you will have ultrasound or MRI. And of course, we are doing a lot of public awareness for this, because now this is plastic surgery become a trend or pattern between our ladies. And always we should tell them and give them the responsibility to decide whatever it is they want to have a further investigation with the mammogram or only not. And of course, this will not stop the surgery. If the lady she needed, she have the right to ask. But also from our side, we should explain to her, and also from our responsibility when she come back to us, she come to us for any investigation, including the screening, not only diagnostic, to do the proper evaluation.
Thank you very much, Doctor. Do you have any questions, my colleagues? I will leave.
Thank you so much, Dr. Fatina. It's a great talk. Yeah, thank you so much. Yeah, it's a great talk. Now we'll move with the speaker, Dr. Ahmed Al-Jidani, assistant professor in psychology, field in College of Medicine, and he will speak now about the supporting cancer patients throughout their journeys. Go ahead, Dr. Ahmed. Thank you so much.
السلام عليكم. Hello everyone. دكتور صوتي واضح صح؟
نعم واضح.
So my name is Dr. Ahmed Al-Jidani. I am a psychiatry assistant professor at College of Medicine, University of Hail. I am happy to be with you today to talk about supporting cancer patients throughout their journey. I would like to extend my sincere appreciation to Dr. Grain Al-Grain and to entire magnificent conference organization team, and to all speakers, participants, sponsors who work very hard to bring this amazing event. At the beginning, I will go through the psychosocial impact of breast cancer on the patients. Then I will talk briefly about psychiatric intervention, including psychotherapy and medication that can be used to help our patient. First of all, I want to talk about the psychosocial impact of breast cancer. In 2008, Maggie Smith, which is, and she is a well-known Oscar winner actress, was diagnosed with breast cancer. She underwent treatment and went through a chemotherapy. She said, some people say you have to fight cancer, but it was fighting me. So the experience of life-threatening illness such as cancer require a person to consider an array of emotional, medical, social, and existential demands. The experience of diagnosis and treatment of breast cancer may result in considerable distress. So patients might be anxious and have a lot of fears of treatment or treatment-related side effects, fear of cancer spreading or cancer returning, uncertainty, doubt about future. Is this diagnosis mean that I am going to die? Is there a chance of recovery? Also worries over losing independence. Am I going to be dependent on others, on my daily needs? Do this mean that I will be a weak person? So a lot of questions and concerns about the life, the future, family, and many other things. These concerns can lead to patient anxiety, and it's important to be addressed by the primary physician. Also, the second impact is depression. Patients are significantly more likely to develop a major depressive disorder than the general population. in breast cancer patient, depressive disorder is reach up to 20% of breast cancer patient. Patient could complain of low mood, loss of pleasure, sleep disturbance, negative thoughts about oneself, negative view about the future and the world. And also she could have suicidal thoughts. Also, the breast cancer could affect the body image and self-esteem of the patient. After the breast cancer treatment, surgery scars, weight loss, skin changes, hair loss, those can change the way of the patient feel about her body. These changes to the patient body can make her feel less feminine and can affect her confidence and self-esteem. That's why breast reconstructive surgery after mastectomy is very important to patient self-esteem and her mental health. As you can see here, a meta-analysis study aimed to evaluate the impact of breast reconstruction on the psychological aspect in patients with breast cancer. There were around 550 breast cancer patients receiving mastectomy plus breast reconstruction, and around 500,000 breast cancer patients receiving mastectomy alone. The results show that the breast reconstruction can significantly decrease the incidence of anxiety and depression compared with mastectomy alone. Other impact is sexual difficulty. Sexual activity can change after treatment. Patients may want less sexual contact because of the side effect of treatment, prolonged fatigue, anxiety, depression, also low self-esteem about her appearance, also maybe because of vaginal dryness or fear of partner rejection. Sexual life is important part of your patient life, so it's need to be addressed as it is an important element of patient quality of life. Also, the stigma. The stigma is a negative attitude or negative belief, stereotype, a discriminating attitude. Cancer-related stigma is associated with poor self-esteem, anxiety, depression, and poor adherence to treatment, and most importantly is delaying seeking for medical help. And here comes the importance of awareness through TV programs, social media, and awareness campaign. Also, it can affect the interpersonal life. So there is interpersonal difficulty, social difficulty. While the majority of female who have breast cancer share the news of the diagnosis with their closest family member, she seeks their support. There is other women felt obligated to hide the news from their family members for various reasons. Some female patients hide their diagnosis from their children to protect them from worry and grief. For example, here in study done in Saudi Arabia, mother who revealed their diagnosis to their children despite experiencing a strong mother-child bond, they admitted that the news negatively affected their children's academic performance, which in turn increased the burden on them. So many mothers decide to protect their children's emotional state by hiding the diagnosis from them, despite being in need for support oneself. Also, some women hide the diagnosis from their husband, especially in our region, due to the fear of divorce or being forced to accept their husband marrying a second wife. So this is really a stressful situation for the patient. Here I want to talk about the prevalence of mental disorders in cancer patients. Mental health disorders, including depressive disorder, anxiety disorders, adjustment disorders, somatic symptom disorder, nicotine dependence, or alcohol use disorder, or other mental disorder, found to be highest in breast cancer patients compared to other type of cancer. the prevalence of mental disorder in breast cancer patient is 41%, followed by 40% in head and neck cancer, while the lowest found to be in pancreatic and stomach cancer. So, as you can see, the mental disorder prevalence in breast cancer patient is higher compared to general population and also compared to different type of cancer. That's why we need to focus on breast cancer patient mental health, as this can affect their quality of life. Here I will talk about the factor that affecting the quality of life in breast cancer patient. A considerable number of breast cancer patients report emotional well-being decline over time. Early identification of women who are vulnerable is crucial to improve their quality of care. So patients who are younger, patients who have lower level of education, and those who are unmarried with more advanced cancer stage, with presence of other comorbidity, who receive a chemotherapy, or who have a prior depression or prior mental health disorder, they report a lower quality of life during the survivorship period. So those vulnerable patients need more care from the primary physician. So what is the role of mental health team in treating breast cancer patients? As you know, the biopsychosocial model, which is interdisciplinary model that looks to the interconnection between biological, psychological, social, and environmental factors. It is a model that focuses on the patient as a human, not just on the disease itself. So mental health workers, including psychiatrists, clinical psychologists, social worker, can play a major role in improving breast cancer patient quality of life. Here, a meta-analysis study was used for integrating the result derived from almost 76 prospective study. The result demonstrates that depression itself has been shown to increase the mortality rate in cancer patients. So the screening for depression should be routinely conducted in the cancer treatment setting, and referral to mental health specialists should be considered. Also here, another randomized controlled trial found reduced risk of breast cancer recurrence and reduced risk of death from all causes among patients assigned to psychological intervention. So there is almost two main interventions that can be done by psychiatry team: the psychotherapy session and the psychotropic medication, mainly antidepressant and mainly what we call selective serotonin reuptake inhibitor, SSRI, which are the most widely used antidepressant to treat depressive disorder and anxiety disorder. SSRI has shown to be effective in treating depression in cancer patients, but there is some recent controversial result regarding SSRI impact on mortality rate of breast cancer patients, and I will have a brief review on that. The first study was in 2008, which is a retrospective cohort study, and it shows that there is a higher breast cancer mortality rate among SSRI users. But when we revised the study, there is some limitation. The sample size is small, and they rely on a self-reported questionnaire for medication use. Also, there is a poor response rate. The second study, which was in 2011, which is a cohort study, showed that SSRI users had similar breast cancer mortality compared to non-user, which means that SSRI not increasing the mortality rate. Another study in 2016 found that also SSRI were not associated with increasing risk of breast cancer recurrence or mortality. But there is one study in 2018, which is a cohort study, found that selective serotonin reuptake inhibitor could increase the mortality rate. But this study has a limitation as it is an observational study, hence open to a lot of confounding factors. Also in this study, tumor stage and grade were missing for a large proportion, and they don't know whether the patient adhered to their SSRI medication or not. So how can we interpret this controversial result? There are multiple confounding variables could affect the results. So depression itself, depression affects the component of immune function that may affect the cancer itself. Thus, there is evidence of bidirectional relationship between cancer and depression. So mental health itself could be the factor, not the SSRI. Also, depression could affect patient compliance to breast cancer treatment plan, which might increase the mortality rate. So it's not the SSRI. And here, I want to talk about the antidepressant and hyperprolactinemia. So prolactin release is controlled. It's controlled by endogenous dopamine, but is also indirectly modulated by serotonin. Hyperprolactinemia has been implicated in increased risk of malignancy, particularly breast cancer. So antidepressants sometimes induce hyperprolactinemia. Although rises in prolactin are usually small and short-lived. So symptom of hyperprolactinemia with antidepressant is very rare, which means that there is no risk with antidepressant on breast cancer. Also, here I want to talk about tamoxifen and its relation to antidepressant. As you know, tamoxifen is a prodrug that metabolized by the hepatic cytochrome enzyme, mainly cytochrome 2D6, which converted to active metabolite endoxifen. Consequently, drugs that inhibit cytochrome enzyme 2D6 may reduce the clinical benefit of tamoxifen by interfering with its bioactivation, particularly when these medications are used for extended period of time. So in this cohort study, paroxetine antidepressant, which is a potent cytochrome 2D6 inhibitor, can result in treatment failure with tamoxifen, leading to increased mortality. But no such risk was found with other antidepressants. So in conclusion, it's very important to treat mental disorder in breast cancer patient using biopsychosocial model, because it will improve the patient quality of life and decrease the mortality rate. Antidepressant can help breast cancer patient, but it's better to avoid a strong cytochrome enzyme 2D6 inhibitors, such as paroxetine, and to use other antidepressants. Okay, now I will talk briefly about psychotherapy modalities and their effectiveness in treating mental illness in breast cancer patients. First of all, I will talk about cognitive behavior therapy, which is a psychotherapeutic module approach that emphasizes the significance of how our thinking affects our feeling. So CBT may include cognitive restructuring, relaxation technique, skills training, among other modalities. Cognitive behavioral therapy is the most widely used evidence-based practice for improving mental health. And in this meta-analysis, the effect of CBT on the quality of life of breast cancer patient was considered with medium effect size, and for depression and anxiety considers with large effect size. Also here, a randomized trial compared different type of psychotherapy like interpersonal therapy, problem solving therapy, brief supportive psychotherapy. The interpersonal therapy is type of therapy that help individual to solve a crisis and to improve the quality of interpersonal relationships and the quality of role functioning and to help reduce the distress. While brief supportive psychotherapy is types of therapy that use some techniques such as clarification, suggestion, praise, reassurance, normalization, advising, also encouraging with empathic listening. So the three brief psychotherapies showed similar improvement on the depressive symptom with large effect size. Also, a mindfulness, which is a type of therapy in which focus on being intensely aware of what the patient sensing and feeling in the moment without interpretation, without judgment. Also, mindfulness found to be effective on decreasing the pain intensity for female patient treated for breast cancer. And patients were also affected by the presence or absence of familiar support, as well as their family reaction to the illness. The role of family support and social relationship in both diagnosis and treatment stage is very important. And as you know, Prof. Sami Al-Amoudi, a breast cancer survivor, said, سرطان الثدي هو مرض أسرة وليس مرض فرد, which means that breast cancer is a disease that affects all family members, not just the patient himself. So the family dynamic is important in improving the patient quality of life. And as you know, now during this era of COVID-19 pandemic, we can use telepsychiatry methods in treating our patients. So there are some evidence demonstrate that psychosocial intervention delivered by phone or video phone is an effective method. So we shouldn't let this pandemic become an obstacle in helping our patients. Finally, it's very important to spend time with your patient to educate them about the disease nature, about the disease treatment options, about the prognosis. Also, it's very important to support your patient and acknowledge their emotions, their fears, their concerns. And also, it's very important to take patient permission to involve her family to support her in this journey. And as you know, no physical health without mental health. And as you know, almost of half breast cancer patient will have a psychiatric disorder. So it's very important to involve the psychiatry team in patient management. Thank you.
Thank you so much, Dr. Ahmed. It's a great talk. If there is any question, please.
Me asking question? Eh?
Yes, Prof.
Okay. Thank you, Professor Ahmed, for the nice lecture. I have got small 3 questions together, if they can be allowed to deliver in. One is that, do you think, because incidence of cancer rise with age and the anxiety starts at the age of 40, as you know, are we building on a depressed woman going into menopausal stage of her life because of the disturbance of the hormones at this stage? Because there is some sort of depression at this stage of, as I have read, when the woman is getting menopausal, then she starts to get some kind of depression. So are we building on this depression, which we are going to depress her by this screening of breast cancer, as well as the BI-RADS 3 of breast cancer screening mammograms, the patient it starts when she is told or he is told to come after 6 months, a short interval recall for follow-up. Are we again hawking this patient by repetitive appointments for follow-up? And then I've got a third question about tamoxifen is supplied, and you said it is being promoting the risks of the life of the patient and increase the mortality rate. It is the risk and benefit factors which govern giving this drug to not to escalate the dissemination of the breast cancer. So what shall we do? Because this is risk benefit study more than the intention of inducing of any risk to her life or his life. Thank you very much.
Yes, thank you, Prof. As you know, the patient facing a lot of stressors. It's related to the changes in her life, the cognitive way of looking at her new situation. So she is vulnerable to a lot of psychiatric disorder. And when we compare the risk of depression and the quality of life of the patient, it's better, or it must be that the patient have to take a referral for a psychiatric treatment. As you know, the benefit of medication, benefit of psychotherapy outweigh the risk. Just we are concerned about paroxetine, which one medication of a lot of medication, one medication, which is paroxetine, it can interfere with tamoxifen metabolism. So tamoxifen will not be active. That's why we are concerning regarding paroxetine, but not other antidepressants. So the medication have a lot of benefits. As I showed in the beginning, there is a study showed that the depression itself increased the mortality rate. So the benefit of medication, the benefit of psychotherapy, it will outweigh any possible risk from the medication.
Proper, thank you. Yes, yes. Okay.
Okay, thank you so much, Dr. Ahmed. Now I will go with the last session, which is my talk. So I'll just give it in quick time because we just run late for abstract. So we have 6 papers today. We need to listen to them. So I'll just
sound.
Yeah, just 1 second. Can you see the slide?
Yes.
Yes, good. Thank you so much. Yeah, so I'll just give a quick talk about abbreviated breast MRI technique, accuracy in breast cancer patient. Some our colleagues today, they talk about great information about the sensitivity, specificity of mammogram, ultrasound, MRI, etc. All modality for breast cancer technique. However, we have one technique which they call the abbreviated breast MRI, and it's growing 3, 4, 5 years ago, starts now established worldwide, and it's now under the processing, I think from my point of view, under the standardization of abbreviated breast MRI technique. So among Saudi women, the most malignancy tumor is a breast cancer with a prevalence of 21.8 and the 9th leading cause of death and mortality worldwide. Early and accurate detection of breast cancer by various imaging techniques play a vital role for patients saving life, including MRI, ultrasound, mammogram technique. The MRI is the most sensitive test for breast cancer detection. However, the applying MRI as a screening tool is currently limited by the relative high cost, long imaging acquisition and reading time. The abbreviated dynamic contrast enhanced protocol have been recently introduced as a screening tool for breast cancer patients. The objective of this study, to evaluate abbreviated breast MRI technique accuracy in breast cancer patients. So this is a cross-sectional study. So we have multiple, this is the initial or preliminary results. So we have multiple centers inside Saudi Arabia. So at the beginning, we have result with 104 non-breast cancer women. We take the patient is above 40, and we start to narrow the age of our group. 43 plus or minus 4 underwent the abbreviated MRI. The protocol of abbreviated MRI composed of 1.5 MRI standard protocol, short time inpatient recovery state sequences, T1 dynamic series pre and post contrast with gradient echo sequences. Also, we have axial T2 turbo spin echo sequence and coronal T1 turbo spin echo. Some centers and some hospitals, they use fat saturation either pre or post contrast. It depends on the protocol. However, we take the standard protocol now. It's applied for MRI. The abbreviated protocol MRI, we take the abbreviated, we extract imaging from the whole series of protocol for the patient, T1 pre-contrast, T1 post-contrast at single point, subtraction imaging and single maximum intensity projection, MIP imaging, and also the two protocols were compared regarding diagnostic accuracy, acquisition time, and post-processing time. So the sensitivity, the result, the sensitivity and specificity and diagnostic accuracy of the standard and abbreviated protocol were 95% and 94 and 95 respectively, with no statistically significant differences. So we take the summarized protocol with the long protocol. So we get the same, the highest, accuracy of the protocol. The mean acquisition time and the standard deviation of standard and abbreviated protocol were 16 point minus or plus or minus 2 minutes. As you know, the normal routine technique for MRI of the breast, it takes sometimes from 16 to 18 or 20 or 19 minutes. And for plus or minus 1 respectively, with statistically differences, significantly differences. So the abbreviated MRI protocol, it takes about 4 or plus or minus 1 minute. So it sharply decreased the scan time. The mean post-processing time, standard and deviation were respectively 7 plus or minus 2 minutes of a standard protocol. And also we take the average doctors who has experience about 5 to 10 years in reading breast imaging in MRI. However, in abbreviated protocol, we take it will be 2 plus or minus 1 minute for abbreviated protocol. So the conclusion, so we conclude that, which is synchronizing with most of the study now, it's really is the abbreviated protocol for breast imaging for breast cancer patient is sharply decrease imaging acquisition time and post-processing time and maintaining the higher diagnostic accuracy. It could be implemented into clinical routine for screening breast cancer. A further larger study in multi-center may be recommended. Again, we need to standardize this protocol, and we need a large patient across the government of Saudi Arabia. So now we take a preliminary result is about 100 patients, but we need to increase the number until 1,000 of patients, is about 2,000 to 3,000 of patients. To summarize up, we see the abbreviated MRI breast imaging. It's extremely useful for the patient. We can use this as a screen tool. However, we mix with all, we put together all information is happening today, and we need to consider again mammogram, ultrasound about the stage of the breast cancer in compare to patient. So thank you so much. And if you have any question for what I say for abbreviated MRI protocol. Yes. Okay, thank you so much. I just make it short for our for my presentation because we need to go with the podium presentation. Thank you so much. Yes, Prof.
Are we going straight away?
Yes, yeah, we will. I think we maybe we go because we are run a little bit late for presentation. So we minimize the podium presentation from 15 to 10 minutes. We need to finish so quickly to take all participants. Okay. So I think the first one will go with Dr. Associated Professor Dr. Ali Al-Mujrad. So I will allow you to be in panel list now, Dr. Ali. So, Prof. Ali, now you can speak and you can now share your presentation. Just open your presentation and go to the share screen, green icon, and start your presentation. Prof. Ali. Ali Al-Mujrad. So now we'll enter another speaker, which is Dr. Ibtisam Abdullah. So it will be in our panel list as well, because she is second speaker. Dr. Ali. So the chair of podium presentation for today is Dr. Amjad, the Vice Dean of our college, and the channel panel include Prof. Bushra and Prof. Abdul Min'im, if he is still around.
Yes, I'm here.
Okay, okay, Prof.
Yes.
We are here, yes.
Yes, yes.
We're just waiting Dr. Ali Al-Mujrad if he respond.
Okay.
I think.
السلام عليكم.
عليكم السلام دكتور ابتسام.
دكتور ابتسام.
Okay, Dr. Ibtisam will go until we fix with Dr. Ali. Yeah, go with your presentation. So the second podium presentation in our queue is Dr. Ibtisam. She will talk about awareness of breast self-examination among higher region. Dr. Ibtisam, if you don't mind, please summarize your presentation, maximum 10 minutes.
Okay, inshallah. Okay. Bismillah ar-Rahman ar-Rahim. My study about awareness of breast self-examination among higher region population.
اللارج برزنتيشن دكتور الفيو اللي لو تكرمتي كبري الفيو بس عشان تصير على كل الشاشه لو تكرمتي. لا نفس تحت في الايقونه الدكتور الخاصه بالعرض. ايوه
اوكي
شكرا.
Breast self-examination is a screening technique for early breast cancer detection that can be performed by women at home subsequent to the age of 20 years. This is a simple, inexpensive, easy, and effective technique that allow women to examine their breast tissue for any abnormalities. Breast self-examination is one of screening method in addition to clinical breast examination and X-ray mammography. All are early detected of breast cancer. Therefore, early detection of breast cancer to improve breast cancer outcome. Women who carry out breast self-examination regularly have been possibility to recognize any abnormality in their breast. The aim of this study to determine the awareness of breast self-examination among high region population. So the significance of this study is represented in knowledge to breast self-examination to early detection of breast cancer. This study was a cross-sectional design survey in about among high region. The target population was age less than 20 and more than 50 years. The data were collected by online questionnaire. The questionnaire is distributed by social media and contain socio-demographic characteristic, breast self-examination awareness, and practice. The total number of participants in this research was 914 participants. The majority of participants aged between 21 to 35 years, totaling 50.4%. According to gender category, the high percentage of participants were female, with totaling of 98.4%. Most of participants were university educated, totaling 70.9%. Our result indicates that 78% of respondents have a good knowledge about breast self-examination. This result agree with Berhani study in 2017. Our study shows that the source of information of research sample is social media by the percentage 50.3%. This result is consonant with Azizur Rahman study in 2019. Our study finds that 60% of respondents don't know when is the best time to do the breast self-examination. This result is agreed with the Babella study in 2017. In our research, 52.6% of participants perform breast self-examination for purpose of early detection of breast cancer. This result is consonant with Suha Baluch study in 2020. Our findings shows that the participants will read about breast self-examination, and the source of information is the social media. Knowledge about about benefit of breast self-examination was good, but they don't know when is the best time is to do breast self-examination. Finally, we highly recommend that there should be intensive awareness program about self-examination in high city, as well as the level of knowledge should be raised among high population to avoid the breast cancer, particularly in low educated and elderly population. Thank you. Any question?
Thank you very much.
Thank you very much for your presentation. We have questions here for you. What is the best time to do for the breast self-examination? What is the best time for women to do it?
Thank you, Dr. Amjad, for your question. The best time to do breast self-examination about 3 to 5 days after period, because breast in this time is less tender and swelling.
So also looking to do the breast self-examination for a lady who got breast cancer once in her life?
Yes. It is important to do before the prevent or for any recurrent.
Okay. Is there any other tests could be done routinely other than the breast self-examination? You can advise us to do it?
No, the breast self-examination is the best and only safe examination test will do in an easy test, and safe and easy test is the only test.
Thank you, Dr. Ibtisam. Prof. Bushra, do you have any question?
Yeah, I've got a small question, Farah. Did you get any information from where did the patients got this knowledge of doing self-evaluation, self-testing, or self-examination? From where they have the source of knowledge?
From social media.
From social.
Internet, TV, yes.
No, what I mean, not the question. The knowledge of do self-examination. From where did they get it? It is education, patient education. From where did they get this self-evaluation education?
From where?
Yeah. Did they get the information to do breast examination and how to do it? From where did they get it? Is there any question on your
In my study, yes, in my study, there is a question. Do you read about the self-examination, breast self-examination?
Yeah.
Most of participants answer yes.
Yeah, okay. Thank you.
Thank you for you.
Just last question.
Yes.
Is there any relation between the level of awareness and level of education or family history?
Yes, there is a significant relation between the awareness and education.
Do you ask the question, is any family member is a medical doctor or a medical health profession can affect this or not?
Yes.
Do you have this question? I mean,
Yes, I have question. If there is any information about breast self-examination, read or doctor or from hospital.
Okay.
Thank you.
Thank you.
Thank you so much.
Thank you for you.
We'll go now with Dr. Ali Al-Mijrad.
السلام عليكم.
عليكم السلام. السلام سيادة البروف علي. Go ahead, Dr. Amjad.
حياكم الله. Just to benefit from the time, just want to share my PowerPoint now. Please just give me the chance to do the. Did you see the presentation?
Sure.
Yes. Yes. Okay. Assalamu alaikum. First of all, I would like to thank our University of Hail, of course, for organizing such great events, and also for the people who are responsible about this conference, from Dr. Green and his team and all people in the college and the university for their great effort. And from just this effort, we will try to participate in a small part from engineering perspective, a few for this important issue, this, of course, breast cancer, one of the important issues in our society and over the world. Our participation in this conference, inshallah, will be based on developing of virtual imaging system and method for segmentation of mammography images using statistical method for early detection of breast cancer. Our outlines in this talk, inshallah, will start in as an introduction, very brief with the objective, and then we follow that by methodology, and we'll discuss, of course, the developed virtual imaging systems, which is the main subject for our talk, and then we will discuss the results, and also finally we will conclude our talk by the important issue we got from this work. First of all, as we know all, the importance of use of mammography as one of the modules for imaging for breast cancer diagnosis. Based on that technique, we try to use also the available new technology available to develop solution using computer aided diagnosis for early detection of breast cancer. Of course, this solution we put in our consideration that to be applicable and also easy to use, and also can be used this as a tool for even teaching, for training, and for also clinicians to be used in real time or offline. The objective of this research that we started maybe a few years ago, and we established some new solution currently to be participated in the conference, to of course to solve one of the important issue regarding finding a solution that early detect breast cancers, and the solution must be fast and accurate, and also very easy solution to be dealt with anyone interested to deal with that issue. Our solution concentrated on developing a virtual system as a tool for image segmentations. We will try to use, of course, statistical methods to help in increasing diagnosis accuracy, and also to be reproducible and with great interpretations for the breast cancer parts of the breast. We put in our consideration also the system to be programmable, that we can use different techniques to help also clinicians or anyone interested to do, breast cancer, see the best technique that can be used programmably through our system. And this, of course, will enable us for smart processing and analysis for breast cancer diagnosis in real time. The methodology that we used in our research to do that system, we started by studying all different methods, using manual techniques, using local techniques that used for imaging, and also some smart automatic techniques. We put it in our solution to find it a possible way to be used as the best method suitable for breast cancer diagnosis. We started after that by making programs to program all different techniques that we searched in the first part of our methodology, using statistical methods for selection the best BCD or breast cancer diagnosis method. And the third step that we did, we developed a virtual user interface for imaging system to help for early detections of breast cancer, to be used by clinician, also to be used by anyone who interested, of course, and this is one of the important parts for teaching and training radiologists for doing the breast cancer diagnosis. And finally, we try to experiment with many clinical cases and analyzing the breast cancer images to validate our developed system. The principle that we developed, we actually mainly based on segmentation principle. We will not go to the mathematical complexity that's under this principle, but we just like in brief that we try to use some statistical model to modeling all the distributions of pixel in the histogram for images by using statistical distribution by many distribution like gamma distribution, like Gaussian distributions, and there are many ways. And we try to model this by using the probability theory and with, of course, some equation. This is the main equation to model that type of histogram data of images. Of course, as we know that the histogram of mammography usually is like white solid on the breast, as we see in here. We see the breast cancer here, that's like small part, and this is just one example, but we investigated and we tried many clinical cases and all actually successful in detecting the area that can be easily detected, as we see in that system that we developed by using many techniques that we can try, even used as a tool that can be also connected to the systems in the hospital, and this is maybe one of our future work. And then finally, we will get from that images after many, of course, processing, heavy mathematical processing, trying to study the histogram and to find the area that's already cancered, and then we detect it easily by using manual technique, local technique, automatic technique, and all, of course, we tried that programmably and are very successful. This is one of the results that we got. We see that image, for example, with that like white, colors that in the image that indicates that in the our distributions of pixels of the images that's at the end of our histograms as shown in the right figure. And from that, we can statistically determine the area that where we can detect the breast cancer exactly. And of course, this is can be evaluated, of course, by clinicians and radiologists to test the validity of our technique. And after that, applying the methods, we will convert, of course, many processing stages. Just like to benefit from the times, I cannot just go in details for that type of processing techniques to because of the shortage of time. And then we can detect the area. This is one example. Of course, we tried many examples and all very successful in high percentage. As a conclusion of our work that we did in this research, that's our developed virtual imaging system and the method that we used, statistical method, advanced statistical method that we used for early detections proved to be reproducible of mammography and also easy to interpret and also able to detect successfully and accurately the boundaries of breast cancer. The system also features can be adopted and interfaced to imaging system to be used as a diagnostic tool in the hospitals or as a tools to be used offline for people who also interested to teach them how to deal with that type of imaging. And as a future work, the system needs to be tested, of course, by clinicians. And this is hopefully that's in the future that we will allow some clinicians to try our system to see if there's any advanced things that we can add to the system. And this is one of the participations in biomedical engineering in medical science. And hopefully that we will, inshallah, in our university, that we established such a program that we will help to develop such using techniques, engineering, and for doing smart solutions for many of health problems. That's our talk, and try to benefit from the time. And I know that's a shortage of time, and thank for all for listening, and I'm ready for any questions.
Great talk. Great talk.
Thank you very much, Professor Ali.
Go ahead.
Thank you very much. As using the computer programming is very important to improve all medical modalities, as we know. Prof. Bushra, do you have any questions for?
Yes. Actually, small questions. I would like to know if he has assessed the sensitivity and specificity of this system. 1, 2.
Actually, we concentrated in the first instance of our work to develop the techniques and then develop the system, because this will take time, as you know, the programming, because we use many modalities and we try to go through many steps of programming. And of course, future work that we will do analysis for images, and we will do all these features for validations, for exact validation for our work.
Prof. Ali, I wanted to say, have you used it to change the did your usage of this program prove to you that you can change the BI-RADS by the sensitivity of this modality or model, or no? Have you changed the BI-RADS from
no, actually we developed the systems for the main point of developing such system, that easier solution, even helping even in teaching. And that's one of the most important things, that use it as a tool for even, to be used as a diagnostic tool. That's, of course, we can't do it because already we developed the systems and we tested the system. But unfortunately, if there is a time that's, hopefully, I know that there's a shortage of time in the conference, that we can do like type a demo for our work to see how the things deal with that type of images. But what I mean by this point, that we will do the next step for that things to deal with type of statistical evaluation for all, the output of the images that we got from our system.
Okay, thank you.
I think we have one lady, two lady. They opened, they raised their hand. Daisy and Ala. I'll just listen to them. Maybe they have questions. Daisy, the mic with you, please. Go ahead.
Yes.
Daisy. Maybe she by mistake. So another one is Ala. So Ala Muhammad.
Yes.
Assalamu alaikum, Dr. Ala Ibrahim.
Yes, go ahead.
Just I want to ask a question. Also
Yes.
for this presentation. Is this a system applied just for 2D digital imaging, or you can also include the 3D tomosynthesis breast?
Included for what?
3D tomosynthesis breast. It's the same like a 2D mammogram, but we had a 3D.
3D?
Can apply this method, yeah.
Data analysis.
Yeah, can we apply your technique for 3D mammogram? That's her question, Dr. Ali.
Hello.
Yes, Dr. Ali, do you hear us? So
Yes.
Yes. Her question asked.
Can you repeat your question?
Yes. Her question: Can we apply 3D for mammo in the same your technique?
Oh, he's not there.
Yeah, maybe
It's connected. It's connected.
But it's okay. He did his task. So I think there is one. So again, Dancy, do you want to ask? Okay, so I think there is a mistake. Lower.
Yes, please. Can you repeat the question? I just lost
The question, Dr. Ali, she asked, can we do your technique in 3D mammogram? So we have
now for the 2D.
Yeah.
The system that we developed, and that's what I mentioned in our conclusion, that this program or this virtual imaging system we developed, that we can develop, of course, we can upgrade this system for any feature that can be requested from the people who are interested in that. We can add any processing technique, new techniques, or 3D. Of course, this we can investigate it as a future work.
Excellent. Good answer.
Yes.
So yeah, I think we finished now. We thank you so much, Dr. Ali. It's a great talk and great
for all.
Yes, great abstract.
Thank you very much for all. Thank you for your effort.
Thank you so much, Saleh. So now we'll go. I think the third one in the presentation with Nadia Dalili. I couldn't find your name, Nadia Dalili. Are you there? Please, if you are there, raise your hand. If not, I will go to second one. Nadia Dalili, the abstract fluorescence spectroscopy for breast cancer detection from Imam Abdurrahman bin Faisal University and Department of Physics, King Saud University. So the author. Are Dr. Nadia Dalili there? Not there. So, okay. So we'll move to the second one. We'll go with
Dr. Miad, I see.
Yes. So I already added Dr. Miad. Go ahead, Dr. Amjad.
Okay, Dr. Miad, welcome. You can upload your presentation if you are here.
Who's coming in?
Miad.
السلام عليكم ورحمة الله.
عليكم السلام ورحمة الله. عليكم السلام، نسمعك دكتورة ميعاد.
أيوة. Today, inshallah, I will talk about the evaluation of breast lesion using ultrasound by RAD classification correlation with the histopathology. This presentation, it's prepared by me, Dr. Miad, and Dr. Hamid Osman, Associate Professor, and Dr. Rania, Associate Professor in Taif University. We will go briefly in introduction. Our colleague, they talk about the introduction in breast cancer and the modality. Here we have a background and objective of the study. material and method, results, discussion, conclusion, and acknowledgement. About the introduction or background, there are some types of tumors that can progress within the various areas of the breast that form the breast masses that are prevalent in women. Most tumors are the result of benign and cancerous changes within the breast, while malignant masses are the most feared among all of breast masses. Breast cancer is the most common cause of cancer in women. It's the second most common cancer death in women in US. Breast cancer refers to breast tissue cancers, most commonly from the inner lining of milk duct or lobules that supply milk duct. According to the report of Saudi National Cancer Registry 2000-2004, the incidence of breast cancer was 127.8 per 100,000 women, and this is a high percentage for in Saudi and high mortality. We have to decrease this rate of mortality by the early investigation and early detection of the cancer. In our study here, we'll talk also about the PI-RAD classification and with the lesion. Here we have 6 categories for PI-RAD. According to this classification, according to breast imaging reporting and data system, we have here from 0 to 6 category. For 0, that is mean when say PI-RAD 0, that is mean we need additional imaging. In this case, most dense breast in mammography or heterogeneous breast in ultrasound. In one PI-RAD or PI-RAD 1, that is mean it's negative or normal only for routinely screening. If above 40, the female is above 40, she can do a routine screening. PI-RAD 2 is some lesion, but it's benign, may ducts, may cyst in ultrasound, and also it's may normal in the mammography or ultrasound scan. In PI-RAD 3, there is some possibility of malignancy, but it's very less. It's less than 200%. Just for follow-up for 6 months, 3 months to 6 months, according to the radiologist. For PI-RAD 4, there is suspicious lesion according to the criteria of the lesion. It's classified to three categories: 4A and 4B and 4C. 4A, it's low suspicious, the percentage from 2 to 10%, and 2B, it's moderate suspicious, also from 10 to 50, and for 4C, it's highly suspicious from 50 to 95. But here in our study, we talk only about the PI-RAD 4 at all, not under the classification. For the diagnosis, we have to take biopsy in PI-RAD 4. PI-RAD 5, it's highly suggestive of malignancy. Also for biopsy or guideline biopsy by ultrasound is better. It's highly from 95 and above, it's malignant. For PI-RAD 6, it's already known for biopsy, just doing follow-up or for clinically appropriate. I'm talking about the PI-RAD because all the study, it's related to the PI-RAD and the ultrasound imaging. This presentation aimed to utilize ultrasonography features of breast lesion for characterization and differentiation between benign and malignant. as well as collate this criteria with histological finding. That is mean we did ultrasound first, and we then put every lesion in some Birat. Then they did histo-guided biopsy and histopathological. We will see how it agrees with the histopathological finding and the Birat. The material and method used. This study is performed in King Abdulaziz Specialty Hospital in the Taif. After all ethical approval was obtained from hospital, the study started. 200 female patients with 227 lesions scanned by ultrasound and done biopsy for all patients and all lesions. All images acquire biologic 7 machine GE healthcare with 12 megahertz frequency. Of course, we have to use the high frequency because the breast is a superficial organ. And images were interrupted by experienced sonographer and radiologists in the department. Data analysis, it's by SPSS and static analysis for the sensitivity and specificity. The result. Here I will talk about the result briefly. The mean age of the 200 patients was 34. Ranging from 25 until 82 years, 227 intermediate Birat 3, category 3, or suspicious breast lesion, category 4 and 5. Of these lesions, 74 were confirmed to be malignant. Also, 153 had benign histopathological features, also seen in the next table. Ultrasound description of the lesion, including mass shape, echo pattern, margin orientation, posterior acoustic features, and their power Doppler flow criteria penetrating puzzle. Here we added the power Doppler flow. In Birat, they did not consider the Doppler, but in our study, we add the Doppler to make a comparison or additional. For Birat, it may increase the specificity or sensitivity. And in the result, we found it's increased in specificity. Regarding the probability of malignancy, it was determined by the radiologist according to the Birat for all lesions. The sensitivity, specificity, positive predictive value, and negative predictive value were also calculated for estimation of Birat category of the lesion and indicator of malignancy, and combined lesion estimated by Birat category and presence of penetrating puzzle, and indicator malignancy of table 6 and 7. Here we have our table. Almost the histopathological finding in 74 malignant case. We found the invasive ductal carcinoma is the most common malignant for breast cancer. Here in benign lesion, from 153, we found the fibroadenoma is the most common, and also fibrocystic disease. In this table, we have frequency benign and malignancy masses for grayscale description and power Doppler flow criteria. A percentage of 227 masses. B is the percentage of benign lesion among total number of masses within given descriptor, and C percentage of malignant lesion among total number of the masses with given descriptor. Here, I will brief about this table. Here we have the irregular shape. We took the shape, echogenicity, margin, orientation, posterior acoustic features, and power Doppler flow. Regarding this criteria of the lesion, we found the oval shape, almost oval shape for lesion. It's become a benign lesion. Only 10 percentage, only 10 percentage is become malignant in oval shape. Rounded shape and irregular shape, it's increase in irregular shape, that's suspected malignancy here. We have here the malignancy. 62 of irregular shape, it's become a malignancy from all the lesion. We have also hypoechogenicity here. If you can see here, hypoechogenicity also, it's in malignant lesion, it's also increase the suspicious. That is mean when we have irregular hypoechoic lesion or speculated lesion, it's increase the incidence of the malignancy. After that, the last thing we have here, according to the Power Doppler flow, 34 lesion with the Doppler flow or penetrated vessel, it's become a malignant. In the, sorry, you can listen me?
Yes, we can listen you, and you have 1 minute more, please.
Okay, I'll try. That is mean here also the number and incident of malignant histological finding in relation their estimated BI-RADS category was compared malignancy breast imaging reporting and data system here. We have in BI-RADS, we said before, in BI-RADS category 3, less from 0 to 2. And our study is agree with that. Also for BI-RADS 4, 139, it's BI-RADS 4, but only 5 lesion, it's a malignant, but it is still agree with the BI-RADS, but it later we will see it's less specificity. BI-RADS 4, it's highly suspicious, and here also agree with the BI-RADS classification. Category 4 and 5 here in the according to the sensitivity and specificity, it's positive predictive value, negative predictive value. I will talk about the BI-RADS 5 here. BI-RADS 5, 78.9 its specificity. That is mean BI-RADS 5, it's more accurate, more than the BI-RADS 4 in this study.
Just in your presentation, please. Just you have 30 seconds for your presentation, please.
Okay, it's the last thing. It's the last table. Yes.
You exceed the time now, 4 minutes. Thanks.
Okay. For this, when we add the modality of Doppler to the BI-RADS classification, we increase the specificity here from 10 to 51 in category of BI-RADS 4. Okay, all conclusion I mentioned before in table or discussion I mentioned before. We will go to the conclusion. Breast ultrasound is a useful diagnostic tool in breast cancer detection and can be used to characterize breast lesion. The vascular flow pattern of breast lesion of Power Doppler ultrasound provide additional benefit for the differentiation of benign and malignant breast lesion. According to the BI-RADS classification, provide standardized terminology to facilitate accurate and consistent breast sonography reporting and can be helpful in distinguishing benign from the malignant breast masses. Thank you for your listening, and I'm happy to listen to your question. Thank you. Thank you very much.
I think it's very important, as we know.
Hello. Who's mine? Do you have any questions for her? Thank you very much for your presentation. It is, I have gone through it last night. It is a rather long poster, but it is very useful, a very useful experience and a good done ultrasound work. If I've got a question for you. You didn't mention the type of probe in your, you mentioned the megahertz, but the type of probe, is it linear, convex, or linear? You didn't mention.
Yes, it's linear.
You use linear. Second,
Yes.
the second question is, do you think by coming to this sensitivity and specificity and positive predictive values, negative predictive values of your research, do you think we can couple the two devices, ultrasound device and mammography, together in one mobile clinic when we are surveying for breast cancer? Have you got any recommendation like that?
Yes.
Because you said,
yes, of course. If we can add the mammography and tomosynthesis, of course we can increase specificity.
Ultrasound.
And ultrasound, we have to add the Doppler, because the BI-RADS Doppler. Yes.
No, I mean by doing it for the same patient in surveying or surveillance of breast cancer. When you are doing the mammograms for surveying of breast cancer, do you advise to avail to make the ultrasound machine available in the same clinic in order to make a reinforcing report for the mammogram? Do you think it is better?
Yes, it's better to make to be ultrasound scanning complementary study for mammography screening.
Okay.
As a complementary study for all, because dense breast now at this time, the breast cancer is become not in the old age only, also in the young female, 36, 32, we have cases, it's breast cancer. Mammography, this is breast is high dense. It cannot evaluate, accurately, but when add the ultrasound, may we increase the chance for diagnosis.
Okay.
Early diagnosis.
Do you advise the patient to be scanned for both breasts as in mammography, to be scanned for both breasts in mammography as in mammography for ultrasound? Do you advise or recommend to do ultrasound for the both breasts in those who have got family risk factors, or do you do only one breast always without going into the other side?
No, two breasts always.
Always two breasts.
I comment, yes, and I did this. Every patient two breasts, not only area of the lesion, bulbable lesion, or one breast. No.
Yeah, because the patient, when he comes as a whole. You do not scan one breast because there is suspicion or pain in that breast. You should examine both breasts because there is risk factor in getting a silent mass on the other side.
Yes.
Okay. Any questions, please?
Dr. Amjad.
I think we can see that the ultrasound shows promise, inshallah, in the future to be more superior than the other modalities that use radiation and has some risk and side effects.
Just one question.
You okay, Prof?
Just the level of experience required to do these procedures. Level of experience and education. Do you think that simple users can do it, or it requires special equipment and department experience?
All of us, we know the ultrasound is dependent operator, depend on operator. Must the operator or sonographer or a specialist must have a good experience for this, because his decision or report it's make difference when he say normal or abnormal in the early scanning. May some patient come after 2 or 3 months with a large lesion, and he come before and do a scanning with poor scanning or for positioning for may يعني not senior only beginner of ultrasound using that is mean this is a big problem.
Yeah, you need experience.
Yes, of course, we need experience, especially in breast.
Thank you very much. Mr. Chairman, do you think we can proceed, go on questions, or shall we shift to the others?
No, if you have a question, if you are interested, it's go ahead. Yeah, so we have just remaining two podium abstract. So if you have one question, just end up, because just to save the time. Do you have a question?
Any question, or should we close the session? Okay, we close the session. Thank you very much for your nice presentation. Wish you all the best.
Yes, now we'll go to the second one. Go, Dr. Amjad.
Welcome, doctor. Thank you. Thank you very much.
Now we will go to the next program. Welcome, Dr. Mason, and go ahead.
I think the presenter Mahasan Yaqub.
Okay,
Mahasan
Yaqub, yeah, because she will be presenter, not the first daughter. Yeah.
Yes. Okay, Dr. Mahasan, yes.
Dr. Mahasan, just unmute, so I'll send. So unmute, please.
Dr. Mahasan.
السلام عليكم.
عليكم السلام ورحمة الله.
عليكم السلام, Doctor.
Good afternoon. Really, I appreciate this opportunity. I am Mahasin Jamaluddin Yaqub, Assistant Prof at Faculty of Health and Rehabilitation Sciences, Department of Radiological Sciences in Princess Noura bin Abdurrahman University. I'm going to present an abstract regarding a study titled The Agreement of Breast Masses Description Using Breast Imaging Reporting and Data System by RADS with Routine Interpretation of Digital Mammography. This work is done by Dr. Maysoon Wanasi, me, Dr. Ikhlas Abdelaziz, and Dr. Lubna Bishara. This presentation contains background, aim of the study, methods, results and discussion, and conclusion.
Dr. Mahasan, Dr. Mahasan, just put like presentation mode, please. Make it large.
Okay.
Just go to enable editing up in your presentation and make it in a presentation mode.
Okay. This is the presentation mode.
I think no. For me, I couldn't see this presentation mode. Just go in your presentation. Just at the top, you will see the yellow row. They call it enable editing. Just click it and go to the presentation mode, because I think now you're stuck in the middle of the slide. Just your name.
Let her go to the second slide.
I
Yeah.
think there's a problem.
Yeah,
I can't see this icon.
Yes, just 1 second. Just stop sharing and upload it again. Just stop sharing.
Okay, okay.
For the audience, they couldn't see your slide. Yeah, just stop sharing and upload it again. Take it easy, relax.
Okay.
Yes, upload it again, Dr. Mahasan. Share it again. Yes.
Is it okay now?
No. عندك دكتورة محاسن الشريط الأصفر البرزنتيشن موجود، لازم تسوي enable.
اوكي.
عندك موجود بالأصفر، احنا قاعدين نشوفه هنا. الآن البرزنتيشن مفتوحة، حتى تعدلي وتغيري فيها في موجود الأصفر.
اوكي.
افتح البرزنتيشن لا
هل
تحمل
هو في خيارات الزوم يا دكتور إبراهيم؟
لا هو الان انت فاتح البرزنتيشن، شوفي فوق موجود، انت حاطه فوق مكتوب enable editing، طالع لك انت ما تقدر تغيري في البرزنتيشن لما تسوي enable editing، تسوي accept يعني الخيار، بعدين تروحين تكبرين الشاشه.
It is the same.
ايوه شوف الان enable editing عند الماوس حقك هذا.
يا
استخدمي اكتبي yes enable editing. اوكي اضغطي عليها، نعم، روحي كبري الان الشاشه من تحت، بسيطه جدا. اذا قبل معك اوكي.
not working. Sorry, it's not working.
Yeah, because enable editing is still inactive. Okay, it's fine. Just go to the second slide. Now we see your big picture is the first slide.
Okay.
Just we can see the small one. It's okay, fine. Just go to the second slide one by one.
Okay.
نعم. ايوه حط اللي هو برزنتيشن مود عادي. ممتاز الان ممتاز. تفضل. Go ahead.
Okay.
Go ahead.
To write a mammography report, there are many steps should be followed, starting with describing the indications of the study, then describing the breast composition, what about the important findings, compare the results to previous investigations, final assessment and recommendations, and finally, communicate with the referring physician for unsuspected findings. Regarding step 5, final assessment, radiologists can use the traditional way of reporting. That is meaning the radiologist uses his own words and terms for describing the findings, or uses BI-RADS, which is provided by the American College of Radiology. In BI-RADS, we have specific terms and words for describing the findings, and this is called BI-RADS lexicon. Here is the lexicon, which is related to mammography because we have ultrasound and MRI lexicon. There are specific terms related to breast composition, related to mass, asymmetry, architectural distortion, calcifications, and associated features. The results are sorted into categories, started with 0, which means incomplete and we need more investigations, and ended with 6, which means proven malignancy and we need biopsy. Because of the wide variability in the description of breast lesions, the importance of BI-RADS system comes. BI-RADS system provides a complete approach to standardize both lesion description and management recommendations. Despite this, still, their radiologists are using the traditional way of reporting. So this study aimed to assess the agreement of BI-RADS with the traditional interpretation of digital mammography in breast mass descriptions. This is descriptive and retrospective study was conducted from 2015 to 2019 at different hospitals with digital mammography machine in Khartoum. The study was approved by all relevant ethics committees. About 300 mammograms for women aged between 15 and 90 years old were included. A design data collection sheet was used, which include the variables are related to breast mass, according to the BI-RADS system, the presence of the mass, yes, no, or undefined, the shape of the mass, round, oval, or irregular, the margin of the mass, circumscribed, obscured, microlobulated, indistinct, or speculated, and the density of the mass, high, equal, or low, compared to the surrounding tissue. Radiologists reported the mammographic images according to the traditional way of reporting firstly. Then the images were evaluated according to BI-RADS to define the degree of concordance or the degree of agreement between them. Concerning analysis, SPSS program was used for creating descriptive statistics figures and tables and calculating the kappa value to assess the inter-observer variability. And this table demonstrates the strength of agreement according to the kappa value. In results, we can see the variability of readings when we compare between two methods of interpretation or two methods of reporting. Figure 1 demonstrates the frequencies according to the breast mass presence. For example, in BI-RAD, we have 12 undefined masses, while in routine, there is no undefined mass. Figure 2 demonstrates the distribution of samples according to the mass shape. For example, in routine, there are 126 irregular masses, while in BI-RAD, there are 66 masses are considered irregular. Regarding figure 3, which demonstrates the frequencies of samples according to the mass margin, the frequency of well-circumscribed masses in BI-RAD and routine interpretation are equal, but there is variability among the other types of mass margin. Regarding figure 4, which demonstrates the distribution of frequencies according to density, the frequencies of low density mass in BI-RAD and routine are equal, but there is variability in the distribution regarding equal and high densities. This table demonstrates the degree of agreement or the degree of concordance between the two methods of interpretation. As we can see here, all the values, kappa values, are less than 1. That is meaning there is no total agreement. Regarding the presence of mass, the kappa value is 0.8, which indicates very good agreement. Regarding the density, the kappa value is 0.742, which indicates good agreement. Shape and margin show moderate agreement because the values are in between 0.4 to 0.6. And these values regarding shape and margin are less than the presence and density values because the variability among radiologists in traditional way itself is high. At the end, there is a degree of difference in the description of mammography findings. Therefore, it's very important to follow the standard lexicon to diagnose mammography images, which avoids any misunderstanding or confusion and facilitates breast lesions follow-up. Thank you so much for listening, and I'm ready for any question.
Thank you so much. Do you have any questions, professors?
If somebody with a question, I let somebody to ask, or otherwise I want to ask a question.
Thank you very much for the nice presentation. I would like to ask this procedure, how can it affect the need for biopsy?
Okay, Dr. Mahasin?
Yes.
Are you around? Have you heard Professor
Yes,
Abdul?
yes, I heard the professor. Yes. BI-RADS procedure help us to decide if we need biopsy or not. According to the categories, we have 0 through 6. 6 meaning proven malignancy. If we use BI-RAD, that's meaning it is better than the using of the traditional way of reporting.
This is it. Yeah, I was about to ask this question because it seems to be you are comparing the conventional reporting with the mammo BI-RADS lexicon. Yeah. But they say that even the ACR, the American College of Radiology, this is not an obligatory method for reporting, but most of the radiologists do. So if somebody is behaving or using the routine conventional reporting and doing well, this is governed by statistics. And the statistical reading is dependent on the histopathology and the surgical findings. So if the conventional reporting is being supported by histopathological positive results, then there is no way you can deny that conventional reporting is not good, because the ACR themselves saying this is not an obligatory method to do the report. Other reports can do conventional reports, for example. It has to be the golden standard, I mean, is the histopathology. Does it agree with conventional or non-conventional reports or not? So do you think from the histopathology, have you got substantial evidence that the conventional reports are not compatible with the ACR BI-RADS or not? Have you got it from the histopathology?
Okay, well, BI-RADS, the accuracy of BI-RADS is considered high, but we can't omit a biopsy. We need biopsy even with BI-RADS.
Yes, so have you proved this by biopsy taking? Have you read the result of pathology, histopathology, to support your findings?
Inshallah, in process will be done, inshallah.
Okay, good. Thank you.
You are welcome.
Another question? Any question?
Dr. Amjad.
We can now move to the last speaker today, Dr. Nahla.
Yes, I think with us. Yes. Nahla Faizo, please.
What your presentations, please.
Mrs. Nahla, could you please hear us? Rahaf Al-Jahani, I will open the mic for you. Go ahead, Rahaf. Rahaf Al-Jahani.
السلام عليكم، صوتي واضح؟
يا صوتك واضح. انت اللي بتتكلمي عن البرزنتيشن هذا؟
ايوه.
يا الحين اغير. I'll just change your setting to the panel list. So Nahla Faiza is not there, so she will be go to attendee. So Rahaf, do you hear me? Rahaf, do you hear us?
صوتي واضح كذا؟
Yes, واضح صوتك بس كأنه في صدى شوية. Now open your presentation and go to green button تحت or up. Share screen. عندي الخيار اسمه share screen تحت أو فوق. رهف أنت student؟
لا أنا متخرجة.
أوكي. bachelor معك؟ bachelor or master معك؟
لا بكالوريوس.
يلا الآن افتح البرزنتيشن عندك على الديسكتوب، بعدين روحي لأيقونة تحت اسمه شير سكرين لونها بالأخضر، واضغطيها ويفتح لك خيار آخر، وبعدين تدخل على البرزنتيشن اللي تبغين تختارين ويصير عندنا موجود على الشاشة. ممتاز. أحسنتي. Yes. That's your role. Go ahead.
Good day, everyone. My name is Rahab Lishhani, and I will be the representative of our research presentation, which is about evaluation of magnetic resonance imaging in the identification of breast cancer. Breast cancer is the most common malignancy in the female worldwide. It is the second common cancer in Saudi female with the prevalence of 21.8%. The incidence rate of breast cancer has increased in the last few years, making it the most common newly diagnosed malignancy among Saudi female. The purpose of our project to evaluate the effectiveness of MRI in cancer. The objective of our study: evaluate the most common symptom of breast cancer among patients who were referred for breast MRI as suspected case of breast cancer. Assess the ability of the MRI to differentiate between malignant and benign lesion using BI-RADS classification and kinetic curve. Examine the sensitivity and specificity of breast MRI in diagnosing breast cancer. Was conducted at King Faisal Hospital in Taif City. The study included data from breast MRI report and packs of 50 female patients who were suspected to have breast cancer. Patients were categorized into 4 age groups. Data were analyzing using the SPSS. Breast lesions were classified according to MRI finding and kinetic curve, and then correlated finding with fine needle aspiration cytology. The result. In this figure, we examined the relation between age and symptom, and the results show that the symptoms of lump are more prevalent at age 30 to 40. The second place in the symptom is breast pain, and it is more prevalent in the age of 30 to 40, followed by age over 50 years. In reviewing the BI-RADS classification in MARA report, we found that 6% patients are classified in class 1% patients are classified in class 2, 30% patients are class 3, which means they have benign lesion or other normal case, but still they are free of cancer. 26% patients are classified in class 4, which means they are probably benign or suspicion in cancer, and lead to biopsy and further test. 12% patients are classified in class 5, and 2% patients are classified in class 6, which means they are proven malignancy. Following administration of gadolinium, which is contrast media used in MRI imaging, there can be 3 possible kinetic curve for lesion in breast MRI. Type 1, persistently enhancing curve, usually considered benign. Type 2, plateau curve, considered concerning of malignancy. Type 3, washout curve, considered strongly suggestive of malignancy. And in our study, we found that in washout curve, the cancer showed a higher percent by 60, and no normal case in washout curve. In plateau kinetic curve, benign lesion showed a higher percent by 57.1. In persistently enhancing curve, the benign lesion showed a higher percent by 53.8, without any case of cancer lesion. Following biopsy for final diagnosis for the 13 patients who were suspected case of breast cancer in class 4, we found that 61.5% patients were identified as a benign, 38.5% patients were identified as a cancer. We also examined the sensitivity and specificity of MRI imaging, and the results show that MRI imaging has a high sensitivity in the percent of 100, where 30 cases classified as a negative predictive value, they all correctly identified as true negative, and low specificity in the percent of 78.9, where 8 out of 20 patients were wrongly diagnosed as a cancer. Limitation of our study: low prevalence of malignancy cases compared with median cases in our sample, transition in the archiving system, so some of the files were not transferred to the new system, limited time for study completion. In conclusion, the most common symptom for breast lesion was breast lump followed by breast pain. It's important to perform fine needle aspiration after MRI to finalize the result, especially in the lesion in the class 4. MRI has sensitivity to detect breast lesion. MRI has low specificity to differentiate between breast lesion. The use of a kinetic curve improves the specificity of breast MRI, which consequently increase the ability of the MRI to differentiating malignant from benign breast lesion. This is the end of our research presentation. Thank you for listening. Any question?
Thanks. It's a great talk, Rahaf, and especially from bachelor's graduate student. What I see, it's a great high standard quality presentation, to be honest with you. Thank you so much.
Okay.
With the chair, Dr. Amjad, yeah. The mic for you.
Yes, Prof. Do you have any questions, Prof. Bushra? For Rahaf?
Yes.
Prof. Bushra, do you have any questions?
I just have a little question for you. Your scan time, how long does it take for one patient?
Scan time for one patient?
Yeah, how long?
For MRI imaging?
Yes, please. Do you have idea?
30 minutes. 30 minutes. Usually 30 minutes take.
Okay. Okay.
Okay, thank you, Rahaf. Inshallah, as a doctor in near future. Do you have any questions?
Inshallah, thank you.
I think we would like to thank all the speakers today, Doctor, and we really enjoyed all the talks today, and we learned a lot of useful information.
Thank you so much, Dr. Amjad. Thank you for all participants today. Thanks for all speakers, for all podium presenters today, and for attendance. So it was a great and long day, but we should thank everyone for active listening and attention and participation. And we will see you tomorrow. Thank you so much for everyone. Thanks. Thank you.
السلام عليكم. الشبكة طلعتني شوية.
لا ولا يهمك، خلصنا احنا. دان انا راح اكلمك في الجوال.
اي
الحين اكلمك شوي في الجوال، بس اخلص المسج مع المعالي وارجع اكلمك ان شاء الله.
حاضر جدا. خلاص خلصت السيشن. ها
خلص السيشن. الله يعطيك الف عافيه يا برو.
ألف عافية. الله يحييك سعادتك. والله يعني نهنيك ونهني كل القائمين بأمر هذا المؤتمر على نجاحه في اليوم الأول. كان رائعا بالرغم من شوية الشبكة، مشاكل الشبكة، لكن كان هذا لا ينقص منه أبدا، كان رائعا بالامتياز.
الحمد لله الحمد لله. لا بالعكس الحمد لله، حتى هو بالإخراج حقه أفضل من الفعاليات اللي صارت. الحمد لله. أنا بس
والله
شوي
حلو والله حلو.
الحمد لله. أنا شوية أكلمك بروف لأنه أنا الحين عندي لقاء مع القناة الإخبارية وأخلص بس منه.
أيوة.
وأرجع أكلمك.
مبروك مبروك. الله يحييك. تسلم. الله يحييك.
مع السلامة.